Good morning, Daisy. All our early birds are from Philippines.
Good morning. Good morning.
Good morning, Dr. Suman. I hope you don't mind I'm in the faculty link because I cannot get into the delegate link.
No issues. In fact, we have enough place in the faculty link, and therefore anyone who is interested can join this link. You're most welcome. We are yet to start. They are setting up the live streaming, and we will be starting at 8:45 with a welcome and promptly at 9 with Vishwajit's panel. All set, Vishwajit?
Thank you, thank you. I have with me my other colleagues, Drs. Daisy Garcia and Dr. Aldrich Gaspar, also from the Philippines.
Most welcome to them. Most welcome. And I hope you can stay through the whole program.
Yes, we did last time. Yesterday we did. We also have Dr. Louis Esguerra here. So thank you very much.
Thank you so much. Thank you. I'm also just heading to the like we are doing it, at least the organizing team we are still doing it from our hospital so that we are together. So I'm just heading there, yeah. So you might hear some car noise on the background.
I saw your video inside the car.
Yeah.
Okay.
Just pardon me, I'm getting a call.
Okay, thank you. We'll be here.
Good morning, all. Is Dr. Suki there? Okay, I'll just call up Dr. Suki Vishwajit.
You want me to call? I can call her.
I'll call her Vishwajit, not a problem.
Perfect.
We can call Suki for you.
Hello.
We can call Suki for you.
Okay,
Hello, Dr. Suman.
Peter.
Dr. Suman.
Hello.
Yeah, hello.
Yeah, I can't see who is talking.
Yeah,
Sorry.
I'm Dr. Sumita. Dr. Sumita.
Hello,
Yeah.
madam.
So I just joined to see whether I can, I'm audible and all, and you can start whenever. Yeah.
Yes, ma'am.
I'll be
Thank you
off
so much.
on
Hi, everyone.
mute and video off. Okay. So
Yes, ma'am.
whenever you are ready, so
Ma'am, you're very nicely audible and also visible. Thank you so much
that's
for
why I
joining.
joined. Yeah, okay. And you will be sharing the presentation, I believe.
Okay, we can share the presentation.
Yeah, it has been received.
Yeah, we have received
Okay.
yours.
Thank
Yeah.
you so much.
Okay,
Thank
fine.
you so much.
Thank you,
Okay,
ma'am.
bye.
Hi.
Dr.
Good
Suman,
morning.
Dr. Suman. Suki will join soon. She's preparing her slides.
Okay, soon. Fine, Tita. Thank you so much. So I will not call her. She will join.
Hi, Suman, and everybody else. Just to say I'm on, and I hope you can hear me.
Very well, Anne Marie. Thank you so much.
Okay,
It
so
must be
I
what,
think
5:30 in the morning for you?
yeah, but it's fine. We are.
Udani ma'am, namaskar.
Yeah, okay. I thought you are not able to see me. It was very nice that early morning. I could even see Anne Mary. She is my mentor.
I'm very happy to see you too.
Hi.
Good morning, Dr. Udani.
How
This is
are
Vishwajit here. So good to see
Nice
you.
to see you.
Vishwajit, nobody will
Hey,
recognize you.
I know. This is my COVID look.
Now you look like the king now. You look like the lion you are. Or are you going the Narendra Modi way?
No, no, I'm just scaling up my. I'm scaling up my beard. That's all that I'm doing.
Good morning, Koturesh sir.
Morning, madam. And everything is going well. Lot of things have become strain from you, and very nice for this program. KMC National Conference you have got Bangalore this time, and only sorry about the not a physical, is a virtual.
Yes, I agree, sir. It would have been so much better if it was physical.
But
we
though
have to do the
virtual,
best.
you have done a wonderful job. The KMC Foundation team and Karnataka team, including you and the college and
And
Vani
NNF,
Hospital.
sir. And NNF Karnataka.
Karnataka, yeah. And nobody could have done this type of work. Suppose if you get the other things, I should not comment about those things. Wonderfully done, even organization, even timings, even faculty, even delegates, even the subject wise also. And I feel this should be accreditation point in future for NNF, because the preventive aspect of preterm care and as well as the well-being of the mental ability of the preterm care, especially with the mother, along with the mother, less expensive for the mother and as a family and the society also. And hats off to your work, madam.
Presentation. Thank you, sir. Thank you. All your blessings.
Can I talk to Anne Mary just
Yes,
I'm feeling
ma'am.
shy because I have not yet written 3 papers. I'm remembering, I'm talking to Suman, but I have not done it. I had told you after a year, but I have not yet done it. Let's hope that by next year I do it. I will try now this time because I had talked to you that time and looking at you, I remember that very bad. Okay. I,
Good morning, Deepa. Your presentation was so much appreciated by everyone yesterday, Deepa. And good morning, Sri Krishna. Good morning, Deepa. Your presentation was so much appreciated by everyone yesterday, Deepa.
Good morning, Suman.
And good morning, Sri Krishna.
Hi, Suman. How are things?
Hi, Somshekhar.
We should be
Good
starting
morning,
in
Dr.
10 minutes.
Somshekhar. Dr. Somshekhar,
Good morning,
good morning.
Dr. Kuturesha. Good
Good
morning.
sir. Wonderfully done, sir.
Yes, yesterday was very nice, brilliant. And I am sure today also was nice. So,
Yeah,
Dr. Joy
all the
Lon was
three.
tweeting.
Decision
Dr.
is
Joy
taken,
Lon was
huh, Dr.
tweeting on Twitter.
Dr.
Yeah, so Suman, Dr. Joy Lon was tweeting on Twitter that she's going to be talking today
Oh, she'll be tweeting.
at this
Oh, she was
conference.
tweeting. Great.
Yeah, she was
She's
tweeting in the
also
morning.
like Dr. Devrari. She's very active on Twitter.
She tagged Dr. Devrari also in the morning. So good morning, Anne-Marie and Daisy, Deepa, Sri Krishna, Akiti. Dr. Sumita is there, I think. Dr. Natali has joined. Wow, great.
Hello.
Good morning, ma'am. Hi, how are you?
Fine. Hello, Reka. How are you, Dr. Reka?
hello, Natali. Nice to see you.
Very nice to see you too.
Dr. Vishwadita has joined. Great. So we are all, I think everyone is here today, right?
Hi.
In the morning, so we're going to be starting on time. Great.
What is the time there, Natali?
10:30 at night.
10:30. Okay, so not bad.
But when Natali finishes, it is going to be 1 o'clock at night.
Thank you very much.
And initially our plan was to have it after the inauguration, and then it would have been 3 a.m. in the morning. So that's when we said that's too much, and we changed it.
Thank you very much.
But even now we're keeping you awake a little bit. Has Dr. Suki joined? I want to just check.
Dr. Natali.
Yeah.
I have been saying that our Suman is Indian Natali. Okay?
Ma'am.
Natali from India.
I believe so. Yeah.
So she is going to be doing the job how you have done it.
What a great honor you're conferring on me, ma'am.
Perfect.
But such a wonderful sessions were there yesterday. And in that first 2 sessions, I couldn't understand how it was so much in detail. You will see them.
I will see. No, I will stay as long as possible. Hello, Deepa. How are you?
Good morning. Hello. So nice to see you. Wish we could see you in person.
Hi, Suki. Good morning. Welcome.
She joined. Yeah, she just joined.
So
it just took a while to get in.
So I think we are all set for day 2.
Can you hear me?
Yes, we can hear you. We can hear you well.
Okay.
Hi, Ratan.
Can you hear me?
Yes.
Wonderful.
Hi.
Thank you.
Morning, Dr.
Yes.
Ruchi.
the slides will.
Hi, Dr. Rekha. It's nice to see you.
Welcome, Nanavati ma'am. Welcome, everyone.
Yeah.
Good morning, everyone. I think it's a bright, nice Sunday out here, and I hope it is across the globe. I know it's in the evening for some of you all, but welcome for this day too. And I hope we have as great a session as we had yesterday with all the stalwarts all packed into this today's program. I am sure it is going to be fantastic. So welcome again, and I hand over to Dr. Koturesh to welcome you all, and then to Dr. Somshekhar.
Good morning to all who is involved in KMC National Conference 2021. And I welcome especially Karnataka Foundation team, Dr. Vani and Dr. Nimbalkar. Dr. Prayag must be available after some time. At the same time, Karnataka team, including Dr. Suman Rao and Prashant Gowda, have been taken a must-train. I luckily have a president of NNF from Karnataka, Dr. Ranjan Pejava. He has taken a must-train to conduct this conference. I hats off to Dr. Suman Rao organizing such a good session, all the topics, including delegates and as well as the virtual conference. I welcome for all the faculties for this day 2 conference and good success, and should be memorable to the faculty, memorable to the academic activities. In future also, you should be able to conduct very nicely. All the pictures, all the video coverage should be taken as seriously to consider the KMC kangaroo mother care in future, just to prevent the morbidity and mortality of the preterm care. And I welcome all the delegates for senior faculty to this conference on second day. Thank you.
Thank you, Koturesha sir, for that wonderful introduction once again. Now I ask Dr. Somshekhar Nimbalkar, the Secretary of the KMC Foundation, to address us.
Thank you, Dr. Bharti. Good morning, everyone. It's a great pleasure to welcome you all to the 5th National Conference of Kangaroo Mother Care. This is our second day, and actually the 4th day if you consider the first 2 days of workshops that we have had. We have a very interesting day today. We actually also have the inaugural or the plenary session that is going to be held at 11:30. And there are various theme-based sessions where a lot of international speakers have already joined, are on the Zoom account currently, and who will be speaking to us. Many of these, and rather all of these people have worked actually in Kangaroo Mother Care on the ground, and they will be sharing their experiences as well as the evidence that they have generated. It would be, we also will be having Professor Rekha Odani, KMC Oration at 12:30. Please joining for that and stay in for that and listen to the work that has been done by Dr. Kumutha, who will be speaking at that point of time. A lot of interesting sessions today. Yesterday was very, very interesting, and I would like to thank NNF Karnataka, the St. John's Medical College, Bangalore, and Vani Hospital, BMCRA for helping us organize this conference. A big shout out to Dr. Suman Rao and her team for ensuring that we are on time almost every time yesterday, and doing things and having a very great scientific content. I look forward to your feedback, and we will be collecting feedback at the end. So please stay on till the end of the conference to ensure that we have some feedback for our next conference. We hope that it will be virtual, and stay safe, everyone. Thank you. Over to you back, Bharti.
Thank you, Somshekhar sir, for those very motivating words. So they say that if we aim for the stars, we could reach the treetop. But today, what we want to do is go up and up and up. That is why the next is a panel on the scale up and implementation. For this panel, we have eminent persons in the field who have not only practiced kangaroo mother care, but have also been involved in scaling up. I invite the moderator of this panel, Dr. Vishwajit Kumar, who is a CEO and principal scientist of Community Empowerment Lab, Lucknow, and who has more than 60 publications and 24 projects on improvement of maternal and newborn outcomes. Over to you, sir.
Thank you very much. Am I audible?
Yes, sir.
Thank you so much. Before I begin, I have a very serious objection for the organizers, particularly Dr. Suman, the Kangaroo Care Foundation. And that is that, you know, whatever I've heard since yesterday, this is not a national conference. What you have actually organized is a global conference at global scale. This is the only thing national that I see about this conference is actually the time zone. So our apologies to our global speakers and participants from all over the world. And, you know, just before this was starting, we were just having a small chit chat. And I was just overhearing, we had Dr. Udani, Dr. Natalie Sharpak, and of course, you know, Dr. Shashi Vani, Dr. Suman, and others. And I was just kind of thinking the kind of pioneering effort that each one of you have made all over the world over the past 30 years. And today, what an incredible moment for us that in this panel discussion, we have a stellar set of panelists, and we are here to talk about scale up. And that should be making each one of you who have been at the front line for the past 3 decades to be extremely proud of what you have achieved. We are extremely grateful and humbled by your contribution over the decades. And to begin with, who better than Dr. Anne-Marie Berg? You know, I've known her for a long time. She has always, and every time I have interacted, it's been pure inspiration. She's at the University of Pretoria and at the South African Medical Research Council. She's one of the pioneers in the field of kangaroo care. And she is, you know, on the panel for the next 10 minutes. We are going to listen to her story because she has been involved right from the very inception. And her insights from taking it there to scaling up and her experience, particularly as it relates to Africa, as well as the lessons from Africa that we can take to the rest of the world. And therefore, I am absolutely honored and privileged to welcome Dr. Anne-Marie Berg. Over to you.
Thank you so much for the introduction. Thank you so much for this invitation. It's always such a pleasure to meet with all my colleagues that we've been working with for so many years. And I would like to share my screen just to give some introduction, but unfortunately, my host disabled participant screen sharing. So I would appreciate if the host could screen saving.
Yes, ma'am, we have enabled it.
Thank you very much. Can you see my screen now?
Yes, ma'am.
So thank you so much for this opportunity, and it's a pleasure for me just to share a little bit about our experience from Sub-Saharan Africa. Actually, Dr. Queen Dube yesterday already said such a lot of the same things that I was experiencing. I worked in a couple of African countries. Inter alia, Malawi is one of my favorite ones. And we also did a big outreach initiative in Ghana a couple of years ago. So I just want to take you back to the early days of KMC implementation, which many of you can remember. In the 1990s, there were this cautious KMC implementation by a few pioneering doctors. Some of them had influence and they could sustain what they were doing in their specific health facilities. Now, in South Africa, we had 2 facilitating factors for implementation. The one was that we had a perinatal death audit system in place, so we could trace what happened in places
Dr.
where...
Mary, we can't hear. Please.
Sorry, can you hear me better now?
And a little more, a little louder, please.
Okay, I would have to try to put on my...
Dr. Anne-Marie, can you come closer and speak? That should be sufficient. You can come closer and speak. That should be sufficient.
I'm trying to put on a microphone to see if that could work. If you could just give me a minute here. Is this a bit better?
Yes, yes.
Is this better?
Little better.
Okay, so it looks as if this would be the best that I
hear
could do.
very.
Yes, now it is fine.
Okay. Okay, so I will do the microphone thing, which is not my favorite way. So the two facilitating factors in South Africa was that we had a perinatal death audit system in place, which made it possible for us to measure some of the impact of the implementation of KMC. And then we also had tertiary teaching hospitals that already had continuous KMC wards. So for scaling up, that was very important. So in the 1999-2000 time, we did some formative research because we had the question, what actually is needed to implement KMC in a hospital? And we developed an implementation package and then also a stages of change model with a measuring tool. So in the early 2000s, we did our first scale ups, and different from in other countries, our focus was on level 1 and level 2 hospitals, because that is where our audit system told us that we had the high neonatal mortality rate. Then after we've done that research, we did 2 randomized trials to test different outreach strategies for KMC implementation. And we were involved in 3 of the provinces, 2002 to 2006, just to say that the total population of South Africa is less than 9 of the states in India. So you can just, I sort of appreciate the kind of scale that you have to work with. Now, one of the tools that we developed was a stages of change model. And what we use that for is to monitor progress with KMC implementation. So you can see here, this model has got 3 phases: pre-implementation, pre-implementation, and institutionalization. And each of these phases have 2 stages. The one is, before you can even start thinking of doing any implementation is that you have to know what the problem is, and we could do that with our audit system. And then you had to know what the possible solutions would be, and one of those solutions was kangaroo mother care. But it doesn't help knowing that if you don't create awareness across the board. And if that awareness creation or sensitization is not done properly, then a lot of things can fall flat in your process of implementation. Now, the second stage is then you have to commit to implement. And what we had is that hospital directors had to sign a commitment that they would allow their staff time to implement KMC. So there was a commitment at the hospital level. Then the next 2 stages are you have to prepare to implement. There are things that you have to get in place. Yesterday, we talked quite a bit about the infrastructure issues and so forth. One also has to do rearrangement of staffing because often you have to work with the same staff complement. And then also the training and orientation of staff to be able to practice a safe kangaroo mother care method. And then one gets to the point of implementation. So it's when your first baby gets into the KMC position and receives, if possible, exclusive breastfeeding, etc., etc. But to start to implement doesn't mean it's going to keep on. So there must also be evidence that you integrate it into routine practice. And then you also have to sustain new practices. Now, we developed a scoring system with indicators for each of these stages, and it counts up to 30 points. And that gives us just an idea of where a specific hospital, or then also if it's a set of hospitals, it also gives some representation for the government or for the particular agency that is implementing, on how well particular hospitals then scored after the end of a project. It's usually a project that one then can measure what was the progress that was made. And so there is a system that we've used, and this tool, the measuring tool that goes with this, we've used in quite a number of countries. Also, together with Dr. Rekha Udani and Suman in India in 2013, also with Dr. Suki and so forth. So it has been used also in other settings, and there are ways in which one can adapt the tool, still scoring the basic points that have to be there, but then also finding out specific issues that are important for your specific context. And we found that this was a useful way, not only of evaluating, so initially we use it for evaluation of the progress, monitoring the progress, but then we also started using it when you don't have KMC. How do you plan for implementing? And then also using it as a kind of a tool in the process of implementation. And then if you've already implemented KMC, it's a useful tool to see where are the gaps that we have. And sometimes you find that you didn't do your first two stages, the pre-implementation stage as well, and that then can explain why you have so much difficulty with some of the other issues that you are working with. So what we then also started thinking about is looking at coverage of KMC and quality of care. And we linked that up with readiness of different kinds of people and also systems. So for stages 1 and 2, the pre-implementation, this is where the stakeholder readiness is very important. This is also where you know, governments start doing their guidelines, doing their policy documents, etc., etc. And then when you start with prepare and implement stages 3 and 4, it has to do with the readiness of the facility and also the readiness of the health system. And there's quite a bit of publications available on the readiness of facilities for KMC implementation. And then when you get to your 5 and 6, it's where you really are looking at quality of care, and where you link up with indicators in HMS, and also with standards for newborn services accreditation and standards for quality of maternal and newborn care. So this is where you are really integrated into the system, and this is what we've heard quite a bit about yesterday too, is where a lot of the facilities in India with KMC services is where they embark on quality improvement initiatives and so forth. So this is just a way of looking at how to implement, and then also for the health system, how to scale up. Important questions for implementation and scale up. Pathways to scale up. In some cases, you have individual champions driving the process in a health facility. A lot of scale up has to do with, is in a project mode where there's specific funding available from a development agency. And then the last one is it is embedded in the health system. And I think that is where our strength in South Africa is we embedded it in the health system from the beginning. We did not have any extra staff to do anything. We did not have any we had to do with what was in the health system. The question of ownership is also important, and roles and responsibilities were also touched upon yesterday. And there are, at all the levels, there are things that have to be done, and there has to be some kind of ownership. Your scale-up models, you can do a big bang. That's what we did in one province in South Africa, where we did all the district hospitals in 1 year. And then we also used that model when we did our scale up in Ghana. The other model is to use a staggered approach, and we used 3 years to cover all hospitals in 2 of the other provinces. And in one of the provinces that had has been integrated with the nutrition, with the baby friendly hospital initiative. So in that province, it was not maternal, child and women's health who did the scale up, but the nutrition division. And then the question is also, and this is very important, how do we link that with sick and small newborn care? Now, in some instances, we used a pedestal approach. We assumed that the other newborn care services were sufficient to be able to accommodate and to absorb KMC. And then in other cases, which I think is what is more important nowadays, is how do we integrate that into the sick and small newborn care initiatives, but without letting KMC move to the back burner, because that is what is one of the problems that can happen. I think there's a bit too little time here, but just about the project mode. It's a common approach, but it's also a double-edged sword. Nothing happens without projects or targeted funding. But then sometimes nothing happens after a project has ended and the resources just dry up and everything just fizzles out. And I will just skip. So KMC is one of the things that first goes just to the back burner, and after a month or two or a year, everybody has forgotten that it has been done. So I think what is important is the art of finding a symbiotic synergy between bottom up and top down. Now, this quote that you see here, we have a river of policy and a desert of implementation. This was what the South African economist said over the radio last Thursday. And I think we can all also identify with that you have to have policies, decrees, guidelines, and other kinds of initiatives from the government side, and also government side at different levels of the health system. But you also have to operationalize the policies and guidelines where there has to be bottom-up initiatives from health facilities and professionals. And it's not just taking over the guidelines that WHO have done, taking over the guidelines that somebody else has done in another hospital. It doesn't work that way, because then there's no ownership. And then, this is my take, the biggest obstacle is leadership. And it's the politicians and the professionals and people in general. And I think we can all identify with when there's a change of government and there are new officials in certain positions, that one has to start sometimes from scratch or even below scratch. And then professionals who are very keen on their own equipment and having issues of safety and so forth. I think this is now better, especially I think from the professional side, where professional organizations have now come on board and have supported and endorsed KMC. That works better. So these are our mantras, and this is what I will end with. Where there is a will, there is a way. This is what Dr. Udani also said yesterday. Don't wait for the ship to arrive. You must make do with what you have, and that is what we had to do because we did not have funding to have extras. Then KMC is not Dudu's project. It's not one person's project, because that is when the person leaves, the project falls flat. If KMC is not recorded, it's not there. And I think that, the importance of measuring what is happening with KMC is coming more to the foreground now. If KMC does not stay on the agenda of meetings and other structured activities, it is not there. So we have to create accountability mechanisms to make sure that it stays. And you can't eat an elephant in one day. You have to do it step by step, and don't go away. You never give up. Thank you. So this is just to show you some of the activities that we had in other countries with Scale Up in Africa. Thank you.
Thank you so much, Dr. Anne-Marie. What an incredible story. Thank you so much for sharing. And I'm sure everyone across the world, will see in a slide, how relevant it is for us. When I look back and I feel what started as almost a seed of KMC innovation of a few kindred souls, and then started spreading, to champions and pioneers like you in different continents. And what, for me, the biggest takeaway of your contribution as well as this presentation has been that beyond leadership, I think what we also need is to provide a scaffolding which can actually help Kangaroo Mother Care take root and actually take it through a staged process of initiation to institutionalization. This has been awesome. Thank you so much. We'll quickly move now next to Philippines, and therefore I say this is not a national conference. It is a truly global conference. And here we have our speaker, Dr. Socorro. Everybody affectionately calls her Suki, so I'll take the liberty of doing that as well. She is with the Kangaroo Mother Care Foundation Philippines, and she has been leading and taking charge of KMC Scale Up, empowering them in Philippines. So we have, she has been, and congratulations from all of us and all the participants from all over the world for your being the most outstanding pediatrician in 2020. We are not surprised. And so please share with us, your experience scaling up Kangaroo Mother Care on the ground in Philippines. Thank you so much. Over to you, Suki.
Thank you very much, Dr. Kumar, for that very nice introduction. And I really appreciate your giving me this opportunity. Allow me to share my screen, please.
Yes, ma'am, you can.
Okay. Do you see my slide?
Yes, ma'am.
Is it in the presenter view or is it in the full slide view?
Presenter view, ma'am.
Okay, let me end right here. Let me just stop there. Okay. Can you give me 1 second?
Ma'am?
Yeah. Is that okay now?
Yes, ma'am. Yes.
Do you see my slide now?
Yes, ma'am, we do.
Okay. So a pleasant day to all of you. And I really thank the organizing committee for giving me this opportunity to share with you our experience in the Philippines. Thank you, Suman, and congratulations to the organizing committee, to Professor Shashi Vani of the Kangaroo Foundation, and of course to my good friend, Dr. Ranjan Pejavar of the NNF. So for this morning, and in the next 10 minutes, I would like to share with you some vignettes and some highlights of how we have done it in the Philippines. And I must truly appreciate Anne-Marie Berg's lecture because that was a very good introduction to my lecture now. So in the Philippines, over the past 2 decades, we've been implementing KMC for 20 years now. We recognize that for a facility-based KMC program, you don't only need to know what to do, but you have to address all the other 5 aspects of program implementation. So we recognize that these 5 aspects should be on the administration, the training, service provision, advocacy, and research. Program implementation requires not only technical know-how about what to do and how to do KMC, but to address issues on organization, policy, and protocols within your facility. Plan on how you will audit and which indicators you will look at, and of course, financing and budget. In the Philippines, training has taken off in a different mode. We have 3 levels of training: the provider course, the trainer course, and the manager's course. Meaning to say, we do a multidisciplinary and multi-level team training for each hospital, because not all can be managers, and neither the manager will be expected to do a provider level. So we make sure that the team has multiple representation when we conduct core team training for each hospital. And we do supportive supervision after the training has been completed and assure and make sure that the training has been translated into actual learning and skills. When we talk about service provision, I think you discussed this yesterday. We talk about infrastructure, addressing personnel issues, and of course, how the implementation will be carried out. As Anne-Marie Berg also said, we did not ask for additional personnel. We did with whoever is available and what the hospital has in terms of personnel. We must make sure that we inform our colleagues within the facility and conduct awareness campaign of what you are doing. We make sure we have some materials for the lay, for the mothers and the parents, and we request each facility to identify a champion or a team leader who can lead the team towards successful implementation. And then, of course, address research, both clinical research and implementation research. So when we conduct a training of trainers and program managers, all these 5 aspects are already addressed. So Kangaroo Mother Care started in the Philippines at the Dr. Jose Fabella Memorial Hospital in about the same time frame as Anne-Marie Berg was saying, 1999 into 2000. After our NICU head nurse and myself went to Colombia to train. And we saw how the system worked in Colombia, brought it back to the Philippines, and started implementing a multidisciplinary team approach to program implementation at the Jose Fabella Memorial Hospital. So we started with organizing, training of trainers. We had a KMC committee that oversee the program. We proposed the policy and generated the evidence that it will help the hospital. And so within the year, the hospital director made it or adopted the policy as a standard of care for all low birth weights. After 5 years of implementing in Fabella, we started collaborating with the community, or actually the city of Manila. And we started with a memorandum of understanding with the city health department, proposed the multiple levels of training. Manila has 6 districts, 60 health centers, and also 6 hospitals under the local government unit. So in 1 year, we used the same 5 aspects in setting up the program with the city government and trained the 6 hospitals in the district. So this program to this day continues to exist in collaboration with the Fabella Hospital. So this was our first network in Manila, and continuously they generate the data year to year as to how many low birth weights get enrolled within their system, how many gets referred to us and referred back to them. So this is an ongoing collaboration with the community or the city of Manila. I retired early from government, and recognized the need to scale up and accelerate kangaroo mother care in the country. So the Kangaroo Mother Care Foundation was established and registered with the Philippine Securities and Exchange Commission beginning 2008. And in 2009, our Ministry of Health issued a policy memorandum on the essential newborn care and initiation of kangaroo mother care for small babies. With this administrative order, the foundation set up and strategized to how we can conduct team training for the regional hospitals all over the Philippines. So we started slow. We offered the program of training of trainers and program implementers for the regional hospitals. And we started with one region and then followed by another region. And we do post-training supportive supervision until they are able to operationalize their own program. We also adopted a system of accreditation as centers of excellence for the region and allowed them to conduct their own training for the hospitals within their district or within the region. They now create their own networks. So basically, we replicated the Fabella and Manila experience with the other regions of the country. So in 2015, Anne-Marie Berg and her team came to the Philippines, and we were one of those countries assessed as to our level of KMC implementation in the country. And I think India was also part of this project. And we recognized that 5 of the hospitals we were already training using this process achieved level 5 to 6 of program implementation. And those, at that time, there were 13 hospitals already initiated, but some of them were initiated while I was still in Fabella. And so we had to redo the training for the remaining hospitals who were not able to achieve that level of implementation. And I really appreciate Anne-Marie Berg's contribution here, because it has indeed helped us in monitoring and evaluating the facilities we have trained. So in establishing a facility-based KMC program, I look at the high five of establishing this program as to the administration, training, service provision, advocacy, and research, because we recognize that with addressing administration, the team is able to envision and list the people who will train. They embark on program implementation, and they're able to execute with and evolve into their own program implementation. Okay, but that is not enough, you know, for KMC to accelerate in a country. We all know that it takes a village, and in 2013, a global call for acceleration of KMC happened. I think this was in Turkey, and many of us here were also in that meeting, and we recognized that for acceleration to happen to the country, the Ministry of Health should be involved, and development partners are necessary. A foundation cannot, one small NGO as ours cannot do that. So in 2014, we experienced our tipping point for KMC acceleration when the Department of Health integrated KMC into a package of interventions called Care for Small Babies. The Care for Small Babies actually covers essential intrapartum care, kangaroo mother care, and community support. It encapsulated what we want to happen from birth all the way to community support. With this technical package, the foundation worked in partnership with WHO and the Department of Health. And by this time, in 1 year, a total of 40 KMC facilities were trained, and they were in various stages of implementation. And we were able to cover 14 out of the 17 regions of the country. Recognizing that WHO recommends health system building blocks, we also recognize that we must connect our facilities with the home and the community environment. Therefore, the community engagement is necessary for acceleration to happen. The Philippine health system is a devolved system. We have the national, regional, and we have the local government system. At the moment, when we were doing this, we were only covering the national and the regional hospital levels. It is important, therefore, that if you want to accelerate the program down to the communities, you must engage the local government unit as far as our country is concerned. They are an independent unit where prioritization in health programs happen. And so I want you to understand that in the Philippines, our key partners are in the lowest ranks of the health system. These are the community health workers, the barangay nutrition scholars. They're the ones who actually look after the small babies who gets discharged to the community, and also the small babies born in the community who gets eventually referred up into the tertiary level of care. So recognizing this two systems in our country, it is important, therefore, to let you know that in the steering wheel of public health program implementation, such as the care for small babies, political commitment is a very, very important aspect. It is not enough that we deal with the high fives of program implementation, but to accelerate it and involve the community, especially the local government unit, political commitment is truly an important aspect of public health program implementation. And we cannot do this without the national administration and the local government units. So as of 2018, we have covered all of the regions in the Philippines. There are now 171 KMC facilities in various stages of implementation. We now have 22 accredited centers for KMC training and excellence, who themselves create their own regional networks and engage the local government units. At the moment, I know there are 2 operational and established networks. One is up there in the north, that's Ilocos Network, Region 1, and one that is in Davao, which is all the way down south in Region 11. The foundation continues to work in partnership with the facilities, the WHO, but the Department of Health is the director of the National Program on Care for Small Babies. Before I end my talk, I'd like to inform everyone that in 2018, we actually launched the Asia-Oceania KMC Network, currently composed of 13 countries in the region, and India is one of them. And I am delegating the coordination of that network to Professor Shashi Vani beginning this year. As you may be well aware of, there is an international KMC Congress that happens every 2 years. But 2020 is such a challenging year for the Philippines. So as far as I was informed, the next Congress will be in 2022, and this will be in Spain. But the Asian Network will be a strong group, and we will be representing the big Asian Network in this Congress. With that, I'd like to end my talk, and I thank you all for your kind attention.
Thank you so much, Suki. Thank you. You know, when I just, you know, I just see my role here simply listening to these electrifying presentations and these strong, inspiring leaders on the panel. What an incredible journey it has been. I think and it also speaks to how just something that's so natural and that should have been where the mother and baby should have been together right from the inception. What an effort and what a monumental effort it's been launched by pioneers like you all over the world trying to bring them back. You know, one key, the first that I see is just this kindred souls out there, you know, and thanks to, you know, Bogota and the pioneers from there. I think it has played an incredible role in bringing this back into our imagination. Second, I see the role of research has been incredible. What began with a set of believers and by very meticulous scientific evidence generation, what is now the knowledge base, I think probably one of the most comprehensive evidence base that we have. And I think that believers is now giving place to an incredible knowledge base of very irrefutable evidence that KMC is so critical. And the third that I see is how this has powered also the creation of networks across the globe. The fourth that I could hear from Dr. Anne-Marie was just the role of research at the confluence of research and implementation, academia and implementation, to be able to give the world frameworks on which they could go beyond leadership, but also start implementing their program in local settings. And what I could hear from you is how you have taken it further on and actually integrated them, institutionalized them. And now I think you're heading towards a stage where it's actually going to become a norm. And I think the moment you start becoming that, the overall effort will, henceforth will actually be far less, will be far, the results are going to be disproportionate to the investment that we have made. So far, we have seen where there has been a tremendous investment, at least of individual energy and intellectual energy, and we have seen less in terms of scale. But I think now we are seeing this proliferation, and I think all of you, what you have also been building is that critical ecology for kangaroo mother care to actually flourish and to support other countries, other places where it isn't. So this is, thanks so much for this absolutely incredible and so relevant presentation. Now, I'd like to, when we talk of scale, we just cannot talk of scale without India. Whether we talk of, and therefore India is placed, is on the pathway, and any success, wherever we have in the world, the road has to pass through India. And so our next speaker becomes very important. And, just for all our audience, India actually has been at the forefront of this. When the global community came together for the Every Newborn Action Plan, India was amongst the first country to actually come up with the India Newborn Action Plan, and KMC plays a very important role. Even when it comes to, zero separation, I think India has been at the forefront of that movement. And I'm absolutely thrilled and privileged to invite Dr. Sumita Ghosh, who is the Deputy Commissioner, Maternal Health at the Ministry of Health and Family Welfare, and at this point also is in charge of child health and newborn health. Her interests, she's passionate about community health and neonatal survival. And, I'm absolutely honored to welcome you. And just a note before I give the microphone to her is I'd also like to appreciate all the panelists and all the participants and organizers who have been able to make this happen despite, a lot of personal as well as other professional challenges that they face in the face of this pandemic. And Dr. Ghosh is one of them. And so my apologies that you, despite all of those, you were able to, be on the panel and send your presentation. Thank you so much, and over to you.
Thank you, Dr. Biswajit. Good morning, good evening to all the stalwarts of KMC who are present here today. I'll start by saying that the introduction part, which obviously Ministry is so busy, could not, I think this is an old one. I am presently the Additional Commissioner in charge of child health, adolescent health, and several other programs. This is an excellent opportunity, this conference, which is more international and national, to talk about India's journey. So this very, very high impact, low intervention, evidence-based intervention, the kangaroo mother care, India has come a long way in it. And I'd request the first slide to be presented. I'll be speaking briefly on the journey. So you can see it's a long winding journey which we have undertaken, and from the very high level of mortality, we are progressing towards the target of 2030 of SDG and INAP. So the journey, if you can see, the newborn journey really started around 2009, 2010. 2011, we developed our facility-based newborn care guidelines and implementation of the facility-based newborn care. 2014, we took up the the India Newborn Action Plan, and 2014, we came out with this KMC guidelines, rollout and implementation plan. It has been followed by several other breakthroughs in the journey. Whereas as recent as 2020, we have scaled up our facility-based newborn care, and we have come out with special training packages. And of these, I would specially mention the newborn stabilization unit package, which actually will go a long way in promoting kangaroo mother care in stable, low birth weight newborns. And we have to reach our target in 2030. Our next slide, please. So as already has been emphasized, it's a huge cohort, 1.37 billion people, and annual birth is around 26 millions. So if you look at that, preterm and low birth weight, they constitute a huge proportion. 15, these are our SNCU statistics, almost 15% preterm and 20% low birth weight. And we cater to almost 38% global share of low birth and 23% of global share of preterm. So you can well imagine in numerical terms how big the load is. We have reached the NMR of 23 per 1,000 live births in 2018. The latest figures are not there. And the first week vital, and it is 78% death which occurs there, and where KMC comes in a very, very big way in preventing that mortality. If we look at the causes, again, it's almost 50% that mortality causes and neonatal period is by premature and low birth weight. We have to reach a target, which is INAP target is our single digit, SDG target is 12 per 1,000, and NHP target is 16. So this intervention, kangaroo mother care, has been taken in real earnest by the country. Next slide, please. So these figures, I know all of you are very aware how the survival is influenced by kangaroo mother care. And beyond survival, there are several immediate, mid, and long-term impacts which kangaroo mother care can achieve. And I know all the stalwarts who have worked so hard on it, they are very well aware of this. What we have seen that the survival increases, below 2,000 gram babies, 40% there is increase, and sepsis, severe illness, all these are influenced by kangaroo mother care. Hospitalization becomes less. Hypothermia is the immediate prevention of hypothermia is the immediate gain, and very high success rate of exclusive breastfeeding can be achieved with early initiation with KMC. Both the pillars of KMC, the skin to skin care as well as breastfeeding, they individually as well as collectively help the physical, the mental, the neurological, the psychological, the emotional, the cognitive, all these growth. So the importance has been really understood by the ministry, and as back as 2014, and as Anne-Marie said, the implementation stages, we have reached, the 5th implementation stage, that is the routine. It has become part of our routine care in the facilities, facility-born newborn care. Next slide, please. So kangaroo mother care, we know it's a next click please. It's a very low cost and high impact intervention, and with very, very minimal requirements, like having trained nursing or medical personnel, having a basic infrastructure for providing the care, and some logistic supports. But where we have achieved that part, but where the gap lies is the recording and reporting system. There lies our challenge. Next slide, please. So the motivation, the skill of the provider, as well as the confidence in the mother and the family. These are the most important success success points which influences success of kangaroo mother care. So in India, the rollout has happened since 2014. And it has become an integral part, not only of only low birth weight stable, but also in our SNCUs and where sick and small newborns are being provided service. It is in the SNCU movement in India. It is again a big success story. It is supposed to be in all districts, district headquarters and medical colleges, and also subdivisional hospital. And at present, it is we have achieved 914 SNCUs are there presently, and they are they have made kangaroo mother care as an integral part in the public system. We have functional NBSU, newborn stabilization units, 2,500, more than that, at the CHC and FRU level across the country. And all these institutions has been provided the desired support and the counseling skill required for KMC, and the funding, the technical support, the financial part, they are being supported from the national level. And the states, as per their, so many states are there. Each state is in India is a country of countries. So they project their plans, and during annual PIPs and national level, support is provided for the financial support, for HR, for infrastructure, as well as for the logistic support. The HR support, again, nothing additional is envisaged. The capacity building of existing staff are being undertaken for facility-based newborn care and kangaroo mother care. And at the NBSUs, the newborn stabilization units at the CHC and FRU level, we are providing committed medical officer, trained medical officers, and staff nurses round the clock, so that kangaroo mother care, it is around the clock. It is encouraged. Mothers are motivated. They are counseled. They are shown the way, and this is the coverage of kangaroo mother care improves. Beyond the facilities, we have programs at the community level, because after, in a country like India, after discharge, when they go back to the community, then often they fall out of the radar of KMC. So for supervision, for counseling, for motivation, for increasing their duration of skin to skin contact and breastfeeding, exclusive breastfeeding, we have programs, huge programs, like home-based newborn care and home-based newborn care and home-based young child care, home-based newborn care. 6 to, yes.
Anyone? No, Dr. Goos, a minute. We have another speaker, so you have a minute, please.
Yeah.
Thank you so much.
I'll shorten it up.
Thank you so much.
So community level follow-ups are happening, so that this kangaroo mother care is the awareness as well as the commitment to it is involved in the community. Next slide, please. So this is one major intervention which has taken place to keep the mother and the child together. All SNCUs have been, scaled up to, the concept is to scale them up to MNCUs, mother and newborn care units, so that they are together. Nearly 150 units have been approved and they are functional. additional space has been provided, and the infrastructure has been given, funding has been given, so that the SNCUs are decongested when the sick newborn can be shifted out along with the mother, and the kangaroo mother care can continue. The mother is also provided bed, diet, treatment, and other supports. KMC feeding supports are continued in these MNCUs till the adequate weight gain occurs. They are also, the recording is also done in our regular SNCU online software. Next slide, please. So these are some of the results of these huge efforts which are undertaken. You can see that 27% below 2,000 gram newborns, 27% almost in our SNCU. This is from our SNCU online software data. 27% are below 2,000 grams, and around 24% of our total admissions, they are getting kangaroo mother care. Next slide, please. The country is made up of, number of states, and that there are great differentials. So KMC provision has picked up very well in certain states, and in certain states they are lagging. Certain northeastern states and other areas, it is yet to pick up. But Tamil Nadu, Arunachal Pradesh, Andhra Pradesh, so many states have taken seriously this initiative. Next slide, please.
Thank you.
So we have challenges. Yes, we have challenges. Awareness is a problem. Counseling, proper counseling. Main problem is in data, because we get kangaroo mother care data. We have given, not given. Give me another one minute, please. So that does
30
not.
seconds. 30 seconds.
That does not give us the proper pure, data. How long, for how many days, whether it is continuously given, whether it is, lesser than 1 hour. That data, of course, we are not getting. That is the challenge of getting it, because that is will define the success of KMC. Capacity building knowledge is we give by our trainings, but the attitude and the practice, that remains a challenge. And as already said, research, what should improve, what should be done, that is the thing. So way forward is we have to make all the public system KMC compliant. NBSU strengthening, which is happening big way this year. All the NBA states have been asked to really strengthen their NBSUs to improve the kangaroo mother care. Budget, for states are their priorities. They should have their priorities on this. And follow-up, strengthening follow-up is another issue, another way, we want to strengthen use of data. Data is again a big way we are trying to improve it.
Thank you.
Building. So this way we have our partners, we have the foundation, we have our, in collaboration, really.
Thank you.
Materialize the Yes. Thank you.
Thank you so much, Dr. Ghosh. Thank you so much. My sincere apologies that, we have to rush it. And, I'll just invite our last speaker. And I'm extremely sorry, Sri Krishna, that you will have to be a Dhoni as you promised. And
yes.
So the good thing is that you actually had an extended workshop on this, but this is COVID time. And I think the role of quality is absolutely important. And so if you could take and, get to the heart of your presentation, and then I would request the organizers that they can move to the next session without me formally closing it. So you would also end up, Shri, I would request you to close the session as well, and we move on. So we just want to make sure that we finish it as much as possible on time. Thank you so much.
Thank you. And may I request the host to please enable video? I hope the slides are visible.
Yes, sir.
Yeah. Good morning and thank you, organizers. It's a pleasure to be with all of you and inspiring lectures from everyone. Over the next 6 minutes, I won't take more. Let me take you through a nice story, and hopefully this will make us feel good about the current times that we are in. We can't separate COVID from whatever we do, and we faced the situation exactly a year back. Now, what happened last April? COVID was bang into our lives. It was an extraordinary situation. The mother and baby started getting separated from each other. Why? Because there was an assumption that hospital visit causes risk of COVID. And it's true to some extent if you look at it from a layman's perspective. What happened because of this separation? Breastfeeding and kangaroo mother care severely got affected. And the priorities of the government also changed. They had to save lives. COVID was all they could think of, and rightfully so. And then what was the effect on the field? This empty KMC wards, staff who are scared, are in doubt whether KMC could be done or not. SNCU staff started getting infected, they were quarantined. All this happened, and mothers who delivered low birth weight babies were wondering, what is this KMC? Should I really do it? Or let me quickly get back to my house. The system, in short, started to collapse. This was exactly a year back, and we have all seen it happen in our hospitals as well. So we had resolved that there are miles to go before we sleep and babies to be saved before they suffer. And this is what I keep quoting to my SNCU nurses all the time. And we took help of quality improvement, and we strongly believe that QI is the way forward for KMC as well. And we got about a lot of QI projects, and we took up QI. And then one SNCU in particular, SNCU Nalgonda, took up a QI project, improve KMC during and despite COVID. And the aim statement was to increase the number of eligible babies admitted in KMC ward in Q3 of 2020 by a modest 10-20% at least compared to Q2. But then there were bottlenecks. And this was done through a proper analysis, a fishbone analysis, 5 eyes. And the key bottlenecks were there was lack of awareness amongst the healthcare providers. We didn't know whether it was safe. And there was a strong influence of opinion makers at home. They kept saying, no, keep the child away. You get this 5 days of quarantine from your baby, then everybody is going to be fine. And we had to fight this. How did we do that? We took up 2 change ideas to begin with. We started to educate the SNCU staff, told them what is the current guidelines, why is KMC and breastfeeding safe, even if the mother is COVID positive. Counsel the caregivers, and this was a tough task. And we started to do this. And key actions which we took up were, we had a very nice advocacy statement by IAP and NNF, and we conducted webinars by NHM and supported by UNICEF Hyderabad Field Office. Advocacy statement started to build confidence. Everyone understood the rationale, the evidence. It cleared all the myths and misconceptions. And the webinars by NHM and UNICEF, we kept on giving reorientation training. We focused on infection prevention. This was the right time to introduce IPC into KMC and care of preterm. And we started to improve the skills of SNCU staff. And this is an advocacy statement, the first of its kind, where IAP and NNF came together and jointly signed a declaration saying that KMC must be given even during COVID, despite COVID. So we started to see some results. KMC started to improve. Some mothers were confident, initiated KMC, they were feeling good. And then COVID worsened. From April came September. And we all know what happened through July, August, September. Mothers went home and started to become COVID positive. And the fear started. And that spread like wildfire in the community. SNCU nurses also became sick. They turned COVID positive. Now, how do you help a mother who was COVID negative when you strongly feel that you probably are harboring the infection asymptomatically? There was increased apprehension and a constant fear. And for the first time ever, KMC wards started to be closed. And in SNCU Nalgonda, which is well known for its remarkable work in KMC, we had to close down the KMC ward. Not because there were no patients, but because we just couldn't do it. The only way up when you hit rock bottom is way up. You have closed the ward. Now is a good time to start afresh. What do you do next? Pick up another PDSA. This is what happens in QI. It's not always that the first cycle gives you complete results. You need to continuously evaluate, do the PDSs repeatedly. And we started to think out of the box and then try a few interesting things. The nurses got quarantined, and in one small room in a district, they had to spend 14 days. What do they do there? Then we realized, let's use them as our counselors. The mothers started to get discharged from the hospital, but then they had a one-on-one counselor, and the nurses were very happy to do this. What else would they do all day? And then we realized this IEC which is coming from international sources and UNICEF and the ministry will not probably make best impact. Create our own IEC. When your own doctor talks to you in your own language and tells you to do KMC, that is when you do it the maximum. So we started to have videos in Telugu, peer education. A mother who did KMC then started to speak, and her words and her confidence then started to spread to others. The nurses continued to engage the mothers, and this one-on-one counseling worked immensely. And what were the results? KMC SNCU Nalgonda declined by 28% in Q2. We even had to close down the ward. But then strong resolve, and we reopened it. Using QI methods, we showed a 42.3% improvement in Q3 as compared to Q2. And despite COVID at its peak, in Q3, we recorded the highest percentage of KMC care over the last 2 years, even before COVID came up. See this graph, and this is what has been the achievement. A percentage of around 20% sustained over the last 1 year came down, unit got closed, and 2 wonderful PDSAs, and we have reached 26.3, the highest so far. So lessons learned are, COVID is an extraordinary situation. You can't get rid of it, at least for the interim, probably not this year at least. You need to live with it and work our health systems around it. Mother and baby need to be kept together. And we need to realize that this is an issue on field. We need to start working on it. It's a global problem, but the solution has to come from within, from the unit. You need a local solution for a global problem. QI, we have realized, is an effective means to achieve improvement. It starts to make you think, analyze, understand, and then implement, and then show results. Health systems are very resilient. We've seen it over the past 1 year. And humans have tremendous willpower, and I always believe in it. It doesn't matter the category or the grade of the person. All that is needed is just the intent to make a difference. And if you can do your role and get the correct support when it matters, we can indeed change. And this is exactly the lessons we have learned from a small state in the country of India, Telangana, and from a small unit in a district hospital. And this is how it is running right now. Thank you, organizers. I hope I have done justice to whatever little I could at the SNCU level and at the state. And I hope we can continue to do this across all the SNCUs and newborn units across the world. Thank you, organizers. That's all from my end.
I thank all the panelists, Dr. Anne-Marie, Dr. Mendoza, Dr. Ghosh, and Dr. Sri Krishna, and the moderator for that wonderful session. I'm sure this motivates us to think beyond the 4 walls of our hospital. For the next session, I will start with the quote. When life throws bricks at you, use it to make a strong foundation. A preterm baby has to fight many battles during his journey. And KMC is one intervention that helps this preterm to take baby steps on the roadmap to a normal childhood development. For this theme symposium, there are 4 talks: KMC, Nurture Science versus Neuroscience, Immediate Skin-to-Skin Contact, KMC and Neurodevelopment, and Long-Term Outcomes of the Bogota cohort. I invite the 2 eminent chairpersons, Dr. Arun Singh, who is Professor of Neonatology at AIIMS Jodhpur and National Advisor to RBSK, and Dr. Ranjan Pejawar, who is very closely associated to us at home, who is Professor of Neonatology and Chief Neonatologist at People Tree Meenakshi Hospital, and is also the present NNF President. It is a pleasure to have both these eminent chairpersons with us. Now, I hand over the mic to Dr. Suman Rao to introduce the speakers.
Mute yourself, please. It's indeed my pleasure to welcome the eminent speakers of this theme symposium, starting with Niels Bergman from Karolinska Institute, Stockholm. It's been a great pleasure, and for the past 2 years, I've been trying to get Niels to Bangalore and India, and now it's been possible only virtually. He is a public health physician with special interest in bridging the gap between science and implementation. And he has hands-on experience in implementing immediate KMC right from birth to taking the baby forward in kangaroo mother care. And it's indeed going to be a real pleasure to have Niels Bergman with us. He has been the hero of most international KMC workshops, winning the award of the best presenter year after year. Welcome, Niels Bergman, and sorry for pulling you out of your bed at 5:30 a.m. in the morning. Next, we have Dr. Carmen Palas Alonso from Spain. Dr. Carmen has done a great work in immediate kangaroo mother care, and she's been a sought-after speaker in all international KMC conferences. And Dr. Shashi Vani was extremely keen on having Dr. Carmen Palas Alonso with us. Thank you again for making it very early with us, Dr. Carmen. We welcome you. Next, we have my own teacher and mentor, Dr. Ruchi Nanavati, from Professor and Head of Department of Neonatology in KEM Hospital, who's going to take us through how kangaroo mother care helps in neurodevelopment. It's indeed a pleasure to welcome you, ma'am. Thank you for coming here. And last, but I would say the crowning glory of kangaroo mother care globally is Dr. Natali Charpak. We are so honored to have you here, Natali. You are the director of Kangaroo Foundation and scientific coordinator of KMC program of not just Colombia, I would say, but globally. And you have devoted your life to kangaroo mother care. And it's such a pleasure to have you. I know we are making you really wait until 1 a.m. in the morning, but you're so passionate that I think you'd have stayed up the whole night for us if needed. Thank you, Natali. Thank you so much for being with us. I hand over back to the chairpersons, Dr. Arun Singh and Dr. Ranjan Pejawar.
Thank you, Suman. It is indeed a pleasure to have such an eminent panelist. So would you like to speak something, Dr. Pejawar? Or so,
thank you very much for inviting me. I'm
yes.
Happy to be here, and early in the morning it's quiet.
Yes. So just to everyone who are participating in this program, that if the world, the planet has to be made a cognitive capital, then we will have to see ways and means how to do it. And one of the things which is very essential is kangaroo mother care. And when I say kangaroo mother care, it starts right after birth. This first early skin-to-skin contact has a holistic psychophysiological
Suman, will you ask
care for the newborn.
Administrators to let my video be on?
Yes.
No, it's
should I continue? So this holistic psychophysiological care, which leads to a neuroendocrinal mechanism of cascade of hormones, it not only helps the mother to deliver the placenta, to reduce her anxiety, to have more milk, but actually it helps the cognition through the early touch, which is the C tactile efferent. When we were students, we thought that this touch was going to the post-central gyrus, but now we know it also goes to the posterior insular cortex, which is affecting the somatosensory and the socioaffective. So not taking any further time, the bottom line is this 100 billion neurons of a newborn. How do we help them to connect and make the human being the Homo sapien, which we are all? Thank you very much. And I would like request my co-panelist, sir, Dr. Ranjan, if you please could say a few words before we start.
I think it's better to say good day because people are in different time zones. And we have 4 fantastic lectures lined up in this session. And, you know, just Natalia Sherpa getting up early in the morning at 2 a.m. to deliver this lecture shows the commitment all these speakers have. And, you know, it's great to have you at the international conference here in Bangalore. I actually am based in Bangalore. So welcome you all once again. And we have to stick to time because at 11:30 is the inauguration ceremony. May I request the speakers kindly to keep this in mind when they start their presentation. Over to you, the first speaker.
That would be me. Thank you very much. So I'll put my share screen and then thank you very much indeed. And let me be as brief as possible and see that the technology is performing so far. So good. Your screen sharing, we'll do that one. I hope that shows. So you saw this slide earlier. And here's our program, and we've got to keep going very well. I thought I'd say a few words about it, but time is short. So this is a wonderful focus, the foundation of early childhood development and kangaroo mother care, nurture science versus neuroscience. I should just always make a disclosure that I work full-time with this, and so there's the disclosure slide. So nurture. Definition of nurture. The thing about growing into a secure being, people often use, in the United States especially, but also in its etymological root, the nurture comes from food, actually. And then there is other meaning of nature versus nurture. All of this is very relevant to nurture science and core to kangaroo mother care, because we talk about breastfeeding, that's kangaroo mother care. We talk about early childhood development, that's the secure being. But now what's the underlying science, nature versus nurture? So our program is fitting into this very well. When I was at medical school, nurture was something emotional. It was a bit of an oxymoron, a contradiction of terms. Because we were dealing with far more important things than soft and emotional things. The intensive care is not a place for nurture, it's a place for life and death. And we separate mothers and babies to save their lives. And we've always separated mothers and babies. And because of that, our outcomes are improving all the time. Kind of arguments that you'll recognize. And I want to say that, no, we have not always separated. And we have not always improved our outcomes. Yes, for survival, we might have improved our outcomes, but for the last 20 years, since we've had surfactant and since we've had corticosteroids antenatally, our cognitive outcomes, our childhood development has not improved in the first world where we're doing everything according to the state of the art. And then there's this always, because it's not always, it's for 100 years. A new thought process to understand scientific processes is called life history theory. And when we go deeper into this, we find that our roots, our origins, were not separation. Mothers and babies were never separated. It was unthinkable. Fathers were closely involved with them. It was a society, a family. And this goes back the 2 million years we believe we're hominids, and it goes back 30 million years we're primates. That makes it deeply embedded in our fabric, which I shall elaborate. Now, nurture science versus neuroscience. I'm going to keep a very straight line here and tease these two things up because they are not the same. And there's some key things that we got from neuroscience that don't fit the 30 million years. And so I'm going to dissect this out. I hope this will be helpful. Neuroscience measures cognitive outcome as its final outcome. And we talk about early childhood development, the first year, first 2 years, first 3 years. Nurture science focuses on the first, not 1,000 days, but the first 1,000 seconds. And I don't have time to more than state these things. I wish I had an hour to prove them, but I'll just state them. First 1,000 seconds, transition to extrauterine life requires maternal regulation. The microbiota is a race for the skin. And who will win that race? It must be the mother's maternal biota. That's maternal sensitization begins in the first 1,000 seconds of life. And then it's the first 1,000 minutes where this continues and we accomplish regulation of maternal infant and connection between them, and where suckling begins and becomes breastfeeding. In my science, I differentiate these two things. In 1,000 hours, which happens to be almost exactly 6 weeks, we consolidate these things. Immediate starts at birth. The scientific rationale is that in nurture, this is how we accomplish early childhood development over 1,000 days. We didn't begin in the 1,000 days. We began in the first 1,000 minutes. Another key concept, the difference between homeoresis and homeostasis. When I was in medical school, homeostasis was a good thing. You have to accomplish homeostasis, stable vital signs. And because of that, a baby in an incubator is not allowed to be touched, because if you touch it, it becomes unstable. Now, the reason is the difference between regulation and stimulation. Any maternal sensation is regulating. Any non-maternal sensation is stimulating, is threatening, produces cortisol. Cortisol accomplishes homeostasis. Oxytocin, on the other hand, accomplishes homeoresis, which is like homeostasis, but includes growing. And therefore, only mother is accomplishing that. And so just to put a little bit of science into my 15 minutes, this is from Myron Hofer. And it's mother-infant interactions, which is regulation. Maternal sensations make the infant sensations, physiology, psychology work. And it's done by oxytocin and homeoresis. Separation means that there's no maternal regulation. Cortisol, corticosteroids that we give, accomplish homeostasis. This is good. This is what it's meant to do. It's a rescue hormone. But in the process, if it's prolonged, we get toxic stress. And toxic stress alters the epigenetic settings for cortisol metabolism, for the whole of stress biology, which is not just cortisol, it's a number of other hormones. And therefore, the iconic experiment of Meany at the bottom of epigenetic settings for cortisol. And I'm making a leap to say it's the same thing happening in the maternal infant interaction brain. And in this interaction brain, we know these things from MRI studies, where the infant mother interaction shown in MRI studies in the 21st century show that this closeness determines the development. And a number of factors can separate mother and baby interaction. And the more the separation, the more the cortisol biology is dysregulated. And the more that happens, the more vulnerability we inherit across the lifespan. And the contrast to that is resilience. The purpose of the early connection, the immediate kangaroo mother care, is to accomplish oxytocin, dopamine connections in mother and infant that achieves resilience. Resilience is the objective. Nurture science is about accomplishing resilience, a reward circuit that makes for lifelong health, as opposed to a strong fear circuit that makes for homeostasis, yes, but with it, vulnerability to disease. Resilience is the capacity to maintain healthy emotional functioning in the aftermath of a stressful experience. And it comes from emotional connection, and that comes from nurture. Mother regulation, not self-regulation. Mother regulation is the key of nurture science. So, a few more things. There are many to say, but here's one thing. Neuroscience is reductionist. We break down pieces into evidence-based medicine. And I'm a Cochrane review, a Cochrane author. And this is necessary, but I want to say with nurture, it's not enough, because not sufficient. Because now we get a gold standard piece of a puzzle. And the puzzle is a big picture. And ecology very specifically says you can't control all the conditions. You have to ensure that you have organisms that relate to one another, and you must provide the environment. And that environment for the baby is its mother. Dynamic systems theory. I'll come back to this as I finish. Now, cognition, secure attachment or outcomes that we use in neuroscience, Bailey, strange situations. But nurture science says, no, the most important thing is connection, and thereafter resilience. Resilience is the objective that we're accomplishing. And the big picture I've shown in this, and the time is too brief to elaborate on anything on this. Only what I want to say is that these are 2 publications where this is summarized in great detail. I commend them if you'd like to go and look. You can download them on that link. Now, some of you might have taken umbrage a little bit at this idea that a randomized control trial is necessary but not sufficient. And I promised I'd come back to this. The big picture, not just the puzzle. And here's the same stubborn donkey that doesn't want to change. And he says, everybody's in favor of progress. Nobody likes to change. And so actually, I want to provide an ethical imperative to change. For adults, there are 4 ethical principles that we have to respect. And all of these carry equal weight. Ethics can be very difficult. Now, for babies, we know that our low birth weight care is not producing long-term outcomes. And we have this belief that the incubators don't do harm. And justice means that all of India's children must get the best possible care. So that's justice, non-maleficence, beneficence. What about autonomy? Respect for autonomy. The infant, the neonate, the preterm neonate does not have autonomy. The parents don't have that autonomy, nor the neonatologist. And now ethics provides a different scenario, and it's called the best interests of the child are paramount. And it comes from the Convention of the Rights of the Child. And that is that there are rights, and these rights impose obligations on us to be advocates for the best interests of the child, the highest net benefit among the available options. Now I'm coming back to my big picture, and I want to come back to the ethics. And so here we see that when I put cortisol higher and got homeostasis, or I got oxytocin higher and I got resilience, this is an active choice between non-maleficence of risk reduction as opposed to health enhancement of actually beneficence. We've done very well on non-maleficence, but we've neglected beneficence. It is necessary to actively ensure regulation, sensitization, and emotional connection so that we get resilience and health. And therefore, the best interests of the child require that we now know separation does harm. We now know that we're not actively supporting self-enhancement. And so zero separation means profound systems change. I think this came up yesterday also. And so for state-of-the-art care, the best interests of the child are paramount. We have to change the systems in which we live. I showed some pictures of a baby in my hospital many years ago. Separation is necessary. We're changing, saving that baby's life. But now we know that we can delete all of those. This is the same baby that I've taken out of the incubator and put on his mother, because the best interests of the child are paramount. We must make this leap. And it's not a leap of faith. It's a leap based on science. And therefore, kangaroo mother care, zero separation, yes, but nurture science is going to provide us a rationale for zero separation so that we will always ensure the best interests of the child are paramount. Thank you.
That was excellent presentation. It showed the rationality behind what we are doing in a very excellent way. It draws us into a much bigger picture. So with these words, I would say, let's welcome the next speaker to elaborate more on this topic, but this gives a basis of our thinking of what we are doing and the bigger picture. Thank you. So.
Okay.
Welcome, madam.
Yes. Okay. One moment.
I think you'll have to.
It's one moment. Hmm. Okay.
Go to slideshow.
Yeah, no, it's yes. You see my slides?
Yes, we can all see. Can you go to slideshow, ma'am?
Yes, but this is no.
Downwards.
One moment. One moment.
No está en presentación.
Now, yes. Okay.
Yes.
Thank you.
Yes. Okay. Good morning from Madrid. I am very happy sharing with you the next minutes speaking about early skin-to-skin care in different circumstances. Skin-to-skin care is defined as the practice of placing infant in direct contact with their mothers with the ventral skin of the infant facing and touching the ventral skin of the mother. In other words, chest to chest. Here you see this mother with her newborn in skin-to-skin contact, and in my opinion, this is the best way to start the life. As Dr. Bergman said, it's emotional connection. The most important organization recommend the skin-to-skin contact immediately after delivery for all newborns. And also the step 4 for successful breastfeeding recommend skin-to-skin contact immediately after delivery. And now the early skin-to-skin contact is a key element for breastfeeding. For this reason, international guidelines related to normal delivery and also C-section recommend the skin-to-skin contact as the standard care for all the newborns. Skin-to-skin care is recommended now for all mothers and newborns, regardless of feeding or delivery method, immediately after delivery and to continue for at least 1 hour. We have to maintain the skin-to-skin contact until the first breastfeeding is finished. If the mother doesn't wish breastfeeding, you have also to recommend skin-to-skin contact for the benefits on bonding, about the bonding and about the stability of the newborn. We know that immediately after delivery, we have to perform some procedures. We have to assess the newborn and to give the average score, and we have to identify the newborn. But both these procedures, you can perform these procedures in skin-to-skin contact. You don't have to separate the newborn from the mother. We have also to perform some painful procedures, the administration of vitamin K and the ophthalmic prophylaxis. You don't have to perform these procedures immediately after delivery. You have 4 hours, and the perfect way to perform these procedures is during the skin-to-skin contact, because in this way we are going to have the analgesic effect of the skin-to-skin. We are going to review very quickly the benefits of the skin-to-skin care. Related to breastfeeding, we have better sucking pattern, more exclusive breastfeeding, and the skin-to-skin care increases the duration of breastfeeding. Related to the stabilization of the newborn, we have better control of the temperature, better control of glucose. We have less time crying. The newborn is less time crying, and we have better cardiorespiratory stability. As I said, we have a very important analgesic effect with the skin-to-skin contact, and we have also benefits for mother. The mother has less stress, better relationship, again, emotional connection, more interaction, and the skin-to-skin contact reduces the postpartum hemorrhage. And here you see this newborn immediately after delivery. He is looking to the face of the mother, and the father is touching and helping the mother during the skin-to-skin contact. And here you see also how the mother is looking at the face of the newborn. But the Skin-to-skin contact is the early skin-to-skin contact is possible not only in the normal delivery, is possible also during the C-section. Here you see this mother is during the C-section. The obstetrician are working here, and the newborn is in contact with the mother and the father. This is the father helping the mother with the newborn. Here you see better how the father is in the operating theater helping the mother with the skin-to-skin contact during the C-section, and here you see the obstetrician working in the C-section. Here we maintain the skin-to-skin contact during the transfer from the operating theater to the room. Here you see the mother with the baby during the transfer. And the skin-to-skin contact is also possible during the C-section with twins. These small twins around 1,700 grams, and they need to go to the NICU, but during the C-section, they are in skin-to-skin contact with the mother. And this is the father helping the mother with the skin-to-skin contact during the C-section. And here you see another slide from the same family. And here you see also another slide, another family during the C-section with their baby in skin-to-skin contact. But we know that sometimes it's not possible. We don't have available the mother, and we, in this situation, for example, if the mother needs general anesthesia, the best option is the skin-to-skin contact with the father, and it's also a very good opportunity for emotional connection, for interaction between father and newborn. And here you see the administration of vitamin K. This is a mother after the C-section, and the newborn is in skin-to-skin contact. We have very few contraindications for skin-to-skin care, but we have to perform safe skin-to-skin care. Here is my granddaughter. She was born in the 1st of May in the worst moment of the pandemic in Madrid, and she was in skin-to-skin contact, and here you see all the family. As I said, we have to perform safe skin-to-skin contact, and in my opinion, the best thing is to have a protocol, a specific protocol of safe related to safe skin-to-skin contact. You have to give this information, of course, to the professionals, but also to the fathers, to the mothers and fathers. The most important thing is that the mothers cannot be alone during the skin-to-skin contact immediately after delivery, because the mother is tired, very tired immediately after delivery, and she has to check that the newborn is fine, is in the right position. She has to ensure that the airway protection, that she has to check that the newborn is breathing easily, and the mother needs someone close to her. Traditionally, in all the cultures, the mothers immediately after delivery were with another woman helping the mother with the newborn. But now in some hospital, it's a crisis situation. The mother is alone immediately after delivery, and we have professionals, but it's very difficult to have a professional all the time close to the mother. And then we need someone, the father, the grandmother, close to the mother, helping the mother with the skin-to-skin contact. And what happened with the very low birth weight infants? We saw this protocol from Norway some years ago, and here you can see Mia. Mia is a girl, 30 weeks of gestation, 900 grams, and she needs some stabilization, she needs CPAP, and but 10 minutes later, she was ready to come back to start the skin-to-skin contact with the mother during the C-section. Here you see the obstetrician working. The father is helping the mother, and she is the neonatal nurse, and you can see here the CPAP. You can see here better how the mother is with the mirror, looking at the face of Mia, and the neonatal nurse and the father. We know that all very preterm infants have a situation of early life adversity, and we think that the kangaroo mother care, the skin-to-skin contact, is a very good tool to try to compensate this early life adversity. We define early kangaroo mother care after delivery when we have the kangaroo mother care with less than 24 hours. This is some information from our unit. 95 very low birth weight infants with less than 20 weeks of gestation and around 860 grams. 46% perform early kangaroo mother care around 14 hours of life. We have a specific training program for kangaroo mother care and another 13 areas for the parents. We work with the parents, of course, about kangaroo care, about breastfeeding, about prevention and treatment of the pain, prevention of the infection, etc. We organize this training in several steps. For example, related to kangaroo care, in the first step, the parent know how to perform kangaroo care and the benefits of the kangaroo care. And in the fourth step, they know everything about kangaroo care, and they can perform the transfer from the incubator to the chest alone without professional help. Here you see this mother during the transfer from the incubator to the chest, and the father is helping the mother, without professionals. When you have early kangaroo mother care with preterms with less than 28 weeks of gestation and with less than 3 days of life, you can have some problems. The first problem is related to the umbilical catheter, and the other problem is related to the head position. Related to the umbilical catheter is in the traditional position of the kangaroo care. You can check the umbilical catheter, and in our unit this is not a problem, but I know in another unit it's a problem. And the other problem is the head position. In the traditional position of kangaroo care, you have the head in lateral position and the body in front position. And then you can have a negative effect on cerebral blood flow because we have some difficulties for the venous return, and we have more risk of brain damage. For this reason, we have designed this study, Kangulate study, and this is a randomized control trial, and we randomize the newborn, the newborns with less than 28 weeks of gestation to traditional, one group in the traditional position of kangaroo and another group in lateral position. Here you see better the lateral position, and we check the catheter, the temperature, and the blood flow, the cerebral blood flow, and also the rate of brain damage. I can show you the results of this study because we are including more babies, but in the next kangaroo meeting, I will show you the results of the study. The kangaroo care is the best place to start the life, but it's also the best place to when the babies are dying. This is Maria. Maria is dying with her parents, and this is Victor dying with their parents. This is not in our unit now. All the newborns died with the parents in kangaroo care. And also it's a very good opportunity for my family involvement. Now with the pandemic, it's more difficult, but here you see this very proud boy with his sister in kangaroo care. And here you see this very proud sister with her brother in kangaroo care. Some key points. The skin-to-skin contact is a standard care after delivery for all newborns. The mothers cannot be alone during the skin-to-skin contact. The mother needs someone helping the mother with the skin-to-skin contact. And the skin-to-skin contact is possible also in the C-section and with very low birth weight infants. And you have to start the kangaroo mother care very quickly in the NICU with the very low birth weight infants and with all the infants. And it's very important to have a training program for the parents from the first day of life related to kangaroo mother care and related also to another areas. Thank you very much for your attention. Here you can see this mother with her baby in kangaroo care, and the father is reading a story to the baby. Thank you.
Thank you, Palas, for this excellent lecture and also demonstrating the actual way to do it with pictures. I think it was very, very accomplished, complete lecture. My only point is you'll be very happy to know that in India, there are a lot of centers who are doing skin-to-skin to the extent that some of them are delaying the cord clamping. They are focusing more on skin-to-skin care. And a work published from India showed that the oxygen saturations were better in the newborn if they did care. So thank you very much. And with this, I would request Professor, thank you, ma'am, Professor Pejavat for conducting the next two sessions. Very important in this. Sir.
Thank you, Dr. Arun Singh. We have had brilliant lectures the first half of this session. We are well in time. I'm glad to say that. And we have two more lectures. The first one by our own Ruchi Nanavati from Mumbai. She's one of the most active persons as far as KMC is concerned. She's mentored, taught, and guided so many of the PGs and DM students. And she's very, very active in the National Neonatology Forum. And she will be speaking on the science and evidence. She has published a lot of papers on KMC, and she's the apt person to speak on the science and evidence of KMC and neurodevelopment. Over to you, Dr. Ruchi Nanavati.
Am I audible?
Yes, you are audible.
And the screen is seen?
Yes, it's visible.
Okay. Good morning. Greetings from Kangaroo Mother Care Center of St. GS Medical College and KEM Hospital. At the outset, I would like to thank and salute Kangaroo Mother Care Foundation of India and organizing team of KMCCON 2021 for organizing this wonderful conference during the very, very difficult times of Corona pandemic. And I thank them for inviting me to share my thoughts on neurodevelopment. To share my thoughts on kangaroo mother care and neurodevelopment, science and evidence. Now, as we know, the second half of gestation and neonatal period, that is between 20 to 45 weeks, are the most important periods for the formation of cerebral pathways and cerebral development. During this time, the cerebral surface area triples because of gyrification, and cerebellum also shows 5-fold increase in the volume between 24 and 40 weeks of gestation. Now, from 24 weeks to 32 weeks is the most crucial developmental period for CNS development because it neurogenesis, proliferation of axons, development of astrocytes, microglia, synaptogenesis, myelination takes place during this important period. And the preterm birth, which comes as a tsunami, alters this normal sequential development. And when we look at these babies who are born preterm at 29 weeks, the brain volume of this baby is just 1/3 as compared to that of term infant. And many times when we manage 35 weekers, we are relatively comfortable, but this brain volume of this baby is 2/3 as compared to the term infants. And what happens to these babies? They land up in neonatal intensive care unit, and neonatal intensive care unit too takes care of physical environment, professional staff, equipments, evidence-based guidelines. It is still a very poor substitute for mother's womb. And we were fortunate to listen to Dr. Bergman. And we know and we have realized now that the maternal neonatal separation is a source of toxic stress. And these poor babies are starting their life with the toxic stress. So as a result of this, we have experienced that these preterm survivors, almost 40 to 60% of them born less than 28 weeks of gestation, have moderate to severe neurodevelopmental impairment. They're at increased risk of cognitive impairment, emotional disturbances, social adaptive behavioral disorders as far as the long-term neurological development is concerned. And in spite of advances in neonatal care, the overall incidence of neurodevelopmental impairment per preterm encephalopathy has not significantly decreased over the decades. Now, if we look at what happens subsequently, this decreased brain volume persists throughout the childhood and correlates with measures of intelligence and executive functioning. It is also important to note that the prefrontal cortex governing the executive function matures during the last 2 months of gestation. And that's why the preterm babies are particularly vulnerable to the deficits in this executive control, which is responsible for cognitive performance, behavior, emotional control, and social interaction. Now, when this baby lands up in NICU, it lands up and starts the life with separation from the mother. There are, in addition, sensory deprivation. In certain aspect, there is sensory overstimulation. We know that NICU at times looks like this even in the middle of the night, so there are sleep disturbances. And all this give rise to the stress in newborn babies, parents, neonatal caregivers, and this is what we have in NICU environment. And this immature, small, preterm sick baby's brain is not equipped to process these stimuli. Now, research tells us and has proved that the species' typical brain development relies on a fairly narrow range of biologically expected, moderately strong, but orderly sensory stimulation. And if we look at NICU, intrauterine experiences are multisensory and interactive, while stimuli in NICU are unrelated to each other and are totally unrelated to the baby. So what happens to this child? Since the life starts with a toxic stress, the mother-infant separation prevents these critical neuronal processes taking place physiologically, and it also channels the development into an alternative developmental strategy, which leads to permanently elevated stress systems that negatively impact the physical and mental health on a long-term basis. So as Dr. Bergman has described, this is the developmental origin of health and disease. Now, we have experienced that the parents of a preterm infants have higher rates of stress, anxiety, depression. And this particular study published in Acta Pediatrica in 2008 looked at the parent-child early relational assessment method, and it showed that the postpartum depression symptoms were associated negatively with the quality of maternal interaction with preterm infants born less than 32 weeks of gestation. The poor psychological functioning was responsible for the long-term impact on child behavior and development. And the cortisol levels were higher in preterm infants when they were cared by the depressed mothers, suggesting that maternal stress, which mother experiences, also influences the stress of the infant. When we look at the sensory adversity in NICU, we know that sensory adverse stimuli negatively influence neurodevelopmental outcomes. And research has shown that the sensory environment of young infant has an important influence on the development of sensory system, development of brain, and subsequent behavioral aspects of the baby. Now, coming to stress, the repetitive stress affects the structural trajectory of preterm infant's brain development, influences subsequent neurodevelopmental outcome through abnormal production and release of neurohormones. Now, the greater neonatal pain which this baby is experiencing in NICU, and all of us know that how many painful stimulus they undergo during the day, is associated with altered functional connectivity, decreased subcortical white matter and also gray matter, not only at term equivalency, but also thinner cortex seen at the middle childhood in preterms who were born less than 32 weeks of gestation. So this infant stress and the maternal stress, this thing also has a long-term implications, and there are studies which shows that how the long-term implications are affected in this particular babies. Coming to the sleep disturbances, we know that the preterm infants exhibit disorganized sleep-wake pattern because of brain immaturity and unestablished circadian rhythm. And this sleep deprivation in fetus and neonate has profound effect on the early sensory development and creation of permanent neural circuits for the primary sensory systems. And this is because quiet sleep is crucial for creation of long-term memories and learning, while the active sleep is a critical component associated with development of sensory systems, and sleep cycles are required for the preservation of brain plasticity. So how does the kangaroo mother care help these babies? And this slide is very special to me because this is my sister's daughter who delivered a preterm child at 32 weeks of gestation. The baby was admitted in one of the corporate hospitals in Mumbai, and it was 32 weeks, required ventilation, required surfactant, remained in NICU for 4 weeks, and was given kangaroo mother care at the private hospital. Now, this all is possible because of theory of brain plasticity, which tells us that the newborn brain can reorganize and develop in response to the changes in environmental stimuli. And the mechanism is by stimulating the release of neurochemicals, guiding formation, strengthening or deletion of synaptic connections, either directly or indirectly through influencing the gene expression. Now we have to know that the plasticity is most robust in the first year of life, when neural circuitry is undifferentiated and formation and deletion of synapses are occurring at a rapid rate. And that's why the preterm neurodevelopment may be modifiable by altering NICU experience. And then we have to decide as a neonatal caregivers that what type of the experiences we are providing to our babies in NICU. Now, kangaroo mother care reestablishes the synchrony between the mother and fetus, which was interrupted by preterm birth. And application of KMC coincides with the third trimester induction of genetically programmed myelination and sensory-driven functional connectivity. And that's why the kangaroo mother care is something very beautiful for the baby. Now, kangaroo mother care is actually a normal biology for human. And the brain development is only normal in the normal place, and that is skin-to-skin contact with the mother. So actually, we should be studying and describing the harm to normal brain development caused by the toxic stress that follows maternal and infant separation. And we should not be doing maternal and infant separation. We had a fortune to listen to Dr. Bergman, and the neuroscience of birth tells us that the maternal sensory inputs regulate the physiology of newborn, and that is newborn homeostasis, and skin-to-skin contact is biologically normal. The mother chest is a normal place for the baby's development, and it is true even for the smallest preterm baby, and we have experienced it in the previous lecture also. The theory of maternal-infant attachment described by Dr. Shore, which tells us that the positive maternal-infant interactions have potential to change neurobiological processes, shape the development of infants' response to stress, and influence brain structure and function. Cortisol levels are higher in preterm infants when cared for by the depressed mother, suggesting that the maternal stress influences the stress of the infant. And we know that KMC, is so beautiful and so nice for the baby because it satisfies all 5 senses of the baby. If we look at kangaroo position, the kangaroo position also supports the physiologic stability and motor development. The supine position is not the optimal and conducive position for the infants, and the kangaroo position helps the infant to acquire motor milestones earlier and helps preventing asymmetrical posture in addition to all the benefits which are described here. So as far as the stress is concerned, of course, it is an undisputed effect of kangaroo mother care that it reduces the stress. Within 20 minutes of initiation of kangaroo mother care, the serum cortisol level dropped almost more than 65%. 4 days of intermittent kangaroo care sessions have cumulative effects on the reduction of stress in most of the infants. And even one session of kangaroo mother care significantly reduces stress level and have much lower cortisol level as compared to the infants which are cared in the incubator. Now, this particular study, which looked at stress and the effect of kangaroo mother care, which was done in the babies between 29 to 34 weeks of gestation, showed that the physiological stress signals and the behavioral stress response, and showed us that saturation and heart rate improved, breathing was more regular, and the truncal, arching, hyperextension, splaying of fingers, contraction of face muscles, apnea, irritability, exaggerated and sustained limb extension, which are suggestive of stress response, were significantly decreased in the babies who got kangaroo mother care. Coming to the sleep, the kangaroo mother care promotes sleep. The kangaroo care induces the sleep for longer duration of quiet sleep, shorter duration of active sleeps, decrease arousal from the sleep, and completion of sleep cycles better than the infants which are cared in incubator. The studies have shown that during REM sleep, the visual cortex is stimulated by spontaneous waves of activity transmitted from retina that are understood to influence the organization of visual cortex. So sleep enhances the plasticity in the developmental visual cortex.
Ma'am, 2 minutes left, ma'am.
So the best sleep for all infants is a quiet sleep. And when we observe the infant sleeping in kangaroo care, we know that it is a real respite for the baby from all NICU environment. Now, this particular study, which looked at the neurophysiological assessment of brain maturation, studied 8 infants at 32 and 40 weeks of postmenstrual age, who were given kangaroo care for 1.5 hours per day for 8 weeks. And they showed accelerated sleep state organization and maturation as compared to the infants which had not received kangaroo mother care. The concentration of hormones influencing synaptic plasticity, such as brain growth promoting factor and oxytocin, were increased in the preterm infants who received the care. This is an interesting study which looked at the impact of kangaroo mother care on cerebral blood flow to evaluate the changes in cerebral blood flow in the middle cerebral artery before and after 30 minutes of application of kangaroo mother care. And the study proved that kangaroo mother care improves cerebral blood flow, and it might influence the structure and promote the development of premature infant's brain. So neurophysiologically, this is very, very important slide. The neurophysiologically, it shows that the preterm infants who received kangaroo mother care from 32 to 40 weeks of postmenstrual age had better brain maturation in all measures of complexity. The brain maturation was better compared to the preemies who did not receive kangaroo mother care, and maturation was even better in the babies who compared to the full-term infants. And thus the conclusion of the study was that based on the hypothesis that ECG-derived complexity increases the neurophysiological maturation, it was shown that skin-to-skin contact accelerates brain maturation in healthy preterm infants as compared to the similar non-skin-to-skin contact control group. So kangaroo mother care promotes neurodevelopment through multiple modalities, that is skin-to-skin contact, exclusive breastfeeding. We have heard about mom yesterday, decrease infant and maternal stress, and regulation of physiological parameters and sleep-wake cycles. Now, I want to stress about breastfeeding, that breastfeeding infants, irrespective of gestational age, have higher white matter in the prefrontal cortex and increased cortical thickness as compared to the bottle-fed infants. And of course, they have higher intellectual quotient in addition to the other advantages which are described here. So this early kangaroo care influences neural corrections and epigenetic pathways to such a degree that the patterns established in the newborn period during the period of neuronal plasticity are sustained beyond newborn period into the childhood. And this is again study done by Dr. Nathalie Charpak, which we will be listening to subsequently, has shown that the adults who were born preterm and had received kangaroo mother care had faster conduction and inhibition as compared to those who had not received kangaroo mother care. And this speed of conduction was directly associated with amount of days in kangaroo care, suggesting a dose-response relationship. And the breastfeeding rates were similar. Breastfeeding rates were similar between kangaroo group and control group, suggests that the kangaroo care, apart from breastfeeding, is responsible for the cognitive differences. And the conclusion of the study was that the enhanced synchronization, conduction times, connectivity of cerebral motor pathways in the KMC group suggested that the influences of the cerebral motor function in very premature at birth adolescents were even evident at a later age. And this is, my own child, that now the baby is almost 5 years old and he's absolutely normal neurodevelopmentally, and think that its response, what is done is by the kangaroo mother care. So the take home message is that the kangaroo mother care is an appropriate strategy for improvement neurodevelopmental outcome, because evidence suggests that early environmental conditions affect neurodevelopment, and KMC is introduced early in life when the neural plasticity is most robust. The positive maternal infant attachment and healthier physiological parameters promote neural formation and connectivity. The KMC modifies stress of extrauterine environment to minimize the impact of adverse stimuli on the preterm infant's developing brain. And KMC induces better, more organized sleep and better sleep-wake cycles. And that's how kangaroo mother care helps in the neural development. Now, of course, as we say that kangaroo mother care is the mother's baby's right and it's a mother's delight. And I think upscaling of KMC across the globe is responsibility of each and every one of us. Thank you very much.
Thank you, Dr. Ruchi Nanavati. That was a brilliant talk. You gave us an insight into all the studies and the ongoing research on KMC and brain development, neurodevelopment. Thank you very much. Now, the last talk of the session is another very interesting talk, I'm sure, that tells us about the long-term outcomes of babies who have received kangaroo mother care. This is talk by Dr. Nathalie Charpak, a doyen of KMC care. She will be speaking on long outcomes of Bogota cohort. Over to you, Dr. Nathalie Charpak. You have 20 minutes.
So thank you very much for the invitation. I will try to present you some of the long-term outcomes of the Bogota cohort from cradle to adulthood at 20 years. We published some results, but it was from a subsample of baby less than 1.8 kilo. So you know that research is very important for the Kangaroo Foundation. No? We are, for us, it was a unique way to modify the original kangaroo mother care method in a method based on evidence as it is now. So for this research, we recuperate a cohort of our randomized control trial we did between 1993 and 1996. And we wanted to look at the long-term impact of kangaroo mother care. And with the support of Grand Challenge Canada, we were able to do this beautiful study. And I have to say that the database is so big, it's so interesting that I have data to analyze up to, I will not tell you. So the first study was an experimental study. We included 746 infants weighted less than 2 kg, and they were randomly assigned according to birth weight. It's very important because it allows us, for example, to analyze only the baby less than 1.8, and there was it was the result we published in Pediatrics. So this time I'm going to show you the overall results and some results on neuroimaging. This RCT, initial RCT, showed that morbidity, mortality, growth, development, and other outcomes as hospital stay, bonding, and brain protection were at least as good or better in the kangaroo group than in traditional care. The first study was done because of that. I mean, it was 18,000 delivery per year, and baby were separated, nosocomial infection was terrible. So for this reason, we did the first study showing that sending home a baby in kangaroo mother care, you will not kill the baby. So really this first study in 94 was special. Here, I will insist on the definition of kangaroo, because the kangaroo method is kangaroo position. We are agree as soon as possible, as long as possible, kangaroo nutrition based on breastfeeding, but it is to the home discharge in kangaroo position and the early home discharge with a very strict follow-up up to 40 weeks or and from 40 weeks up to 1 year. Why I'm saying that? Because I think that part of the results are coming from this component of kangaroo mother care. In this time, 30 years ago, or well, in 94, the kangaroo, when the baby was eligible, he was discharged immediately at home in the randomized control trial. So our original sample was 746 infants. 30 baby died during the first year, so we did have 716, and up to 20 years 3, so we did have 713, and we were able to recuperate 70% of the sample. From them, 11% were living outside Colombia or outside Bogota, and 39 refused to participate. So we did have 441 infants, and we did have 50 infants as reference, term infant without any risk. What we did, a complete neuropsychological battery of tests to see attention, motricity, quality of care, laterality, depression, attachment. We really try to do everything. Yes, memory, visual motor integration. We did ophthalmological and audiometric evaluation, a full clinical and neurological exam, and we did neuroimaging with anatomical, functional, and DTI. I have to say that to clean this database, it took us more than 2 years. That's true. It is a reality. We did TMS for everybody, interview of the best friend, domiciliary visit and home test, and socioeconomic evaluation and educational survey. So you can imagine, I mean, the data is beautiful and open to people interested in doing a project or sending us a project. We build one fragility index, one severity index. I don't have time to explain you how we did that, but it was very important for us to be sure that it was possible to compare kangaroo and control in the re-enrolled cohort. Of course, it's important. So mortality, I will go very fast here. Mortality, we show that up to 20 years, you have the same protector effect. And when you are looking at the baby less than 1.8, it was a very important effect of kangaroo mother care as a protector against mortality. We look at the developmental and environmental outcome. We look at the IQ and the home. What we wanted to see if the result we did have at 1 year were persisting up to 20 years. So I think that this one is better. We did repeated measure and we showed that in the same, at 1 year, we use neurological exam at 6 months has a fragility index. So here we use the same neurological exam to look if the result was the same, and yes, and it was significant for the home test and for the IQ. Here you can see it better. Here is the kangaroo group who did have at 20 years IQ, and they did have a neurological exam, transitory or abnormal at 6 months. And here you have the control group. You can see that the babies were protected in the kangaroo group. And we look at the sustained attention also, and you can see that we have the same result in the kangaroo group in relation with the control group. Here we have 2 new papers who are going to be published. It's really interesting because you can see that kangaroo mother kangaroo babies had more years of preschool, less dropout, and they did have more money per hour than the control group. And there were more kangaroo young people working at 20 years than in the control group. We did have some mathematics international exam. Mathematics course was lower in the kangaroo, but you must remember something. I'm speaking about a survivor cohort because I have less kangaroo infant who died in the kangaroo group. So I have a small disbalance in fragility, in severity in the kangaroo group because I have a little bit more of these fragile infants. But anyway, when you look at this result, we did have more infants with discapacity who went to the national exam. So that's very important. They were feeling they did have more support from the family. Here it's very important, and it shows you the importance of the high-risk follow-up. You have here the weight during the first year, the weight and the head perimeter, and you can see the impact on the IQ at 20 years to have less than 90 or more than 90. You can see the head circumference at 1 year, the impact on this IQ, the mother feeling of competence, who was different between the kangaroo group or the control group at 41 weeks or 1 year, and you can see the impact also, the maternal feeling of stress, and the home test that we did at the end of the first year of coveted age, and you can see the impact on the IQ. all this is high-risk follow-up. I think it's very important. It is for the future of the infant. I know it's difficult to organize, but it is very important. So here we look at the hyperactivity and aggressivity score at 20 years, and we did have a difference according to the level of education of the mother. That's hyperactivity and that the aggressivity. We have these differences. Here you have the internalization and the externalization. There are sequels. There are sequels of the prematurity, or I will say they are more frequent in premature infant at 20 years, according to mother education. And you can see here also that you have a difference, and it is significant. Here, I don't have time to explain exactly all the graphic. I mean, it's impossible. Here you have something very interesting, which was antisocial behavior according to gestational age between the kangaroo group and the control group. And it was less in the kangaroo group at 20 years. Yes, and here I will show you the impact. It's really an impact of the high-risk follow-up, because here you have kangaroo control together, and here you have young people from Bogota, and we compare the number, the rate of studies, and we discover that all infants who went through the high-risk follow-up, you have the double of this infant studying more than secondary. And it was done with a national survey. We compared to a national survey who was done in Bogota in 2013. So now I'm going to show you some results of neuroimage. We did have around 200 neuroimage, functional RMI, anatomical RMI, and DTI. So we are just beginning with that. So I will show you. Sorry, I have to do like this because I cannot see with this. I will put it down. Okay. Presentation. Okay. So here we look at the fraction of anisotropic, no, this one. We looked at the gray matter, and we did have a difference between kangaroo and control. More gray matter, more cortical gray matter in the kangaroo group, and we looked, and especially we did have more subcortical gray matter. So that's the nucleus of the base of the brain. And what was interesting, first we looked just according to the severity index and the kangaroo position. And you can see here that more kangaroo position, more volume, less severity, more volume. And we look at two of the nucleus. The one is a caudate nucleus, who is in relation with motricity, and you can see that when we put the test of motricity is shorter when you have a bigger volume and less severe and more kangaroo position. And we look at the striatum. The striatum is caudate, putamen, and pallidum, and another one I forget. And we look with the high Q. The high Q is higher when you have a bigger volume, and according to the severity index, and more kangaroo. We look at the white matter. The white matter organization, the anisotropy fraction, and you can see here that it's the same according to the severity and the duration of kangaroo. And we look with a motor test, and it gives us the same. Shorter the test, better the organization. And we look at the number of fiber, white matter, and you can see that more fiber, better high Q. And here you have the severity index and the kangaroo position, duration of the kangaroo position. This one is just to show you, I wanted to show you this one is the best kangaroo, and this one fragility, and this one is the worst. And here's the control. They look the same, but it's not for this reason that I'm showing it to you. That's the anisotropy fraction, that's the length of fiber, and this one is a cuerpo calloso, terrible. What I am showing you is at 20 years, what we are doing in the neonatal unit, that's the results. So for this reason, I am showing you this. I mean, nothing is no harm. I mean, it's everything can harm this brain, and at 20 years we can see that. We can see the results. So I can see that I'm at 16 minutes, so I will go very quickly because I believe that I'm a little bit late. The result, I show you these results. I really believe that we were able to establish the short and medium term effect of kangaroo and the persistence of the protective effect. And kangaroo help to compensate for the disadvantageous environment, for the cognitive and academic development of these fragile infants. So now we have to understand the articulation between the perinatal event and the cognitive, academic, behavioral development. I believe that we all database, we will be able to explore that. So I believe that we have to do kangaroo in each step when we manage a baby. Resuscitation, we can do kangaroo. The baby, if he is well, he can go with his mother, then home discharge and follow up. You can do kangaroo in intensive care, intermediate care, and kangaroo. The kangaroo word is just something that you can add here if it helps you, but it's not only that kangaroo mother care. You must do more than that. I mean, kangaroo, it's in all the steps, and we are responsible of these. That's the preterm brain of 25. That's one is a term, and that's a term brain. So look at that. I mean, we have to work on that to be able to protect this brain. So I will just finish. I will not say that because Dr. Naravati explained that. I will just say that it takes a long time to transform new idea into reality. And that really we have to work to do the best technology and in the same time to do kangaroo and to introduce kangaroo as a routine since the beginning to protect the brain of this fragile infant. And I hope that we are going to work more on the image we have, and we are, I mean, we must continue to diffuse and to give access to kangaroo mother care to the 100% of infants who need it. Thank you very much. I don't know if you have questions.
Thank you, Dr. Sherpak. You are well on time. And Suman will be very happy that we have finished the session at 11:30 exactly. And thank you very much, Dr. Sherpak, for a very, very informative and information which spans over several decades, the experience and the research which spans over several decades and not just 1 or 2 years. That was great. Thank you once again.
So we have 2 minutes for questions.
Okay. It's there in the, where are the, it's an open question, is it?
Yes, sir.
Okay, we have just 2 more minutes. After that, we are going to start the inaugural session. If anybody has a pressing question, please come forward, raise your hands, and you'll be allowed to ask the question. We in India, we have a great difficulty in long-term follow-up, Dr. Sherpak, you must be knowing already. And we have that weakness that we can't follow for long periods of time due to various reasons. And it is fascinating to see that you have followed up the cohort for decades together. It's fantastic.
But I have to say that we have 53 kangaroo mother care program ambulatory in Colombia, and we are following the baby up to 1 year. I have 50,000 infants in my database now of 3 excellent center, and it can give you data to manage the nutrition, the neurodevelopment. I mean, it's very important to follow the baby because it's a unique way we have. I know you do it in Mumbai. I know you do it in Mumbai up, I don't know, up to 1 year, but it's a unique way we have to evaluate the neonatal practice. And if we want to better each time our neonatal practice, we must follow. We must try to follow the baby at least the first year, or the 2 years will be better.
You use the word data. That's another thing. We have to record the data, collect the data, and analyze. A lot of these speakers here who are from India have expressed that, because we have to have something to show, and we have to have something to tell us that whether we are doing the right thing in the right way. And lot of emphasis has to be put on QI, I feel. Even in KMC, QI is the way forward, I think. What do you say, Dr. Ruchi?
Yeah, yes, of course. We are doing QI studies in KMC, and one of our studies published, the other studies are this, but I think the way forward for us is to find out where do we lack, what do we require to do further, and do more and more QI studies and generate data from our own country, which is for a long-term follow-up.
I'm sure Dr. Vinod Paul also will shed some light during his talk in the next session. So I think with that, we come to an end of a very informative and very good session. Thanks to all the speakers. They were excellent and they have covered their talks in a beautiful manner, and they have kept the time. Thank you, Dr. Bergman, Dr. Alonso, Dr. Ruchi Nanavati, and Dr. Natalia Cherpa. Thank you very much.
Thank you. Thank you, Arun sir and Ranjan sir, for taking us through this theme symposium, which was fantastic. I think the foundation for early childhood development has been here in this conference. Excellent. Thank you very much. Now we are well on time for the inaugural ceremony. I know we called it the inauguration earlier on, but we are into the second half almost of the program. So Shashi Vani ma'am has told us this is the plenary, the most important session of the conference, and we have none other than Professor Vinod Paul, who has set the stage for kangaroo mother care more than 2 decades ago in India for this. So I am honored to welcome everyone, and to start off, I would invite Dr. Nikhil Karod sir to welcome everyone. And meanwhile, since this is a virtual conference, unfortunately, we can't escort you to the stage, but we request all dignitaries of this inaugural function to turn on their video if their bandwidth will permit, so that the audience on this platform and also the audience on a digital platform and on YouTube will have the honor of seeing you all. Thank you very much. And I hand over to Dr. Nikhil Karod to do the welcome address.
Thank you. Listening to the stalwarts like Niels Bergman and Nathalie, I'm reminded of a strota in Sanskrit language, which goes something like this. Agnana timirandasya nananjana salakaya chaksurun militam yena tasmai Shri Gurave Namaha. It means that salutations to the Guru, whose knowledge opens the eyes of ignorant to higher lights. And this is a journey towards higher light, moving from the stress that we have been creating for the newborn by separating babies from the mothers. We are learning something fantastic, something new, and very sound physiological basis from the stalwarts that we have heard so far, and also the pioneers of kangaroo mother care in our country. I'm very happy that Dr. Shashi Vani has also been able to join in spite of the health issues in our family. And Dr. Vinod Paul has also arrived. And this fifth national conference, KMCCON 21, could take place in spite of all the difficulties in this pandemic time. I think it reflects the resilience that we have all acquired because of the nurturing effect of kangaroo mother care, which we are trying to pass on to our newborn. But in the process, we have also learned the resilience, and therefore it could all happen. So with these few words, I hand over to Dr. Suman Rao, the organizing committee chairman, to welcome all the dignitaries. Thank you.
Thank you, Nikhil, sir. Thank you very much. And it's indeed my honor to give the second welcome address on behalf of the organizing committee, St. John's Medical College, Vani Vilas Hospital, Bangalore Medical College, National Neonatology Forum, Karnataka chapter, to Professor Vinod Paul, all our eminent faculty, all our eminent chairpersons, and the delegates who are passionate to have joined on a virtual conference from morning till evening, yesterday and today. Mother is indeed the center of a baby's universe, and it is our duty and responsibility to restore her to this rightful place, especially among the vulnerable preterm and low birth weights, and that is kangaroo mother care. And here today, with this conference, we hope to increase the awareness of kangaroo mother care, reignite the enthusiasm for promotion of kangaroo mother care so that we can meet the SDG goals. And especially during this COVID pandemic, I do hope that this conference will sort of restore the faith in keeping baby and mother together, even during these difficult times. I welcome each one of you all, and I hope this feast of learning would really enhance and support kangaroo mother care. Thank you very much. And now I invite you all to a virtual lamp lighting. And I would like all the dignitaries to be part of this virtual lamp lighting. With this, we go to the next agenda on our program, that is the reading of the annual report by the Secretary of the KMC Foundation, Dr. Somshekhar Nimbalkar. Over to you, Somshekhar.
Good morning, dignitaries on the screen, all the participants who have joined and the faculties who have put their effort for the last 4 days in bringing this together. It's an honor and a privilege to have so many people of international repute on one platform. While because of COVID, we were not able to have a physical conference, But in a way, as Dr. Vishwajit said in the morning, it's a blessing in disguise because we are having a lot of international faculty which we would not have otherwise. So I'm just going to be talking about how the KMC Foundation has worked throughout the last year in these difficult times. So coming to the KMC Foundation per se, it is a voluntary non-profit service organization with coverage of activities all over India with a permanent central office at Gujarat. This was founded subsequent to the International KMC conference that was held in 2012 at Ahmedabad by a group of KMC champions. Following this conference, we felt that we had to do something more after just holding the conference, and hence we went on to establish the KMC Foundation India. The mission of the KMC Foundation is to make the mother's chest the best place for newborn care, as we have been learning throughout the last three, four days. The mother's milk is the best food for the newborn, and that there should be zero separation of mother and her baby. To make kangaroo mother care as a part of routine care of all the newborns, especially the raw-birthed infants, and it is not considered as an extra special intervention. So we have been careful to make sure that it is not something extra, but part of newborn care, and our activities are mainly to ensure that this care is performed in a better manner and in a better quality. One of the main objectives is to support government programs to be part of the system and achieve our mission, and also independent innovative activities. Try and do advocacy and demand generation in public and policymakers. Ensure that training and capacity building is done for KMC and essential newborn care for all categories. So that includes our various training programs such as master trainers, provider training programs, and training programs for community healthcare workers. So we try and train the entire spectrum of healthcare workers. We try and do relevant research studies and also put in our efforts for improving acceleration of KMC as well as quality improvement. There have been multiple innovative activities that have had impact. You can see many of these pictures that you see on the photographs that are distributed during all conferences. And whenever we do workshops, we try and ensure that all of these equipment kind of reaches all the people who participate in our conferences. Since 2017, we have been having theme-based annual conferences. The first ever was done in Hyderabad in 2017, where it was quality and coverage of KMC. We went on to Lucknow in 2018, and then further north in 2019, with themes of continuation of KMC with quality from facility to community. Came down to Jaipur in quality, equity and dignity, and we wanted to go south, and so this year we wanted to do it in Bangalore. The conference was initially supposed to be a hybrid one or a physical one, but in the last 3 weeks or so, with the surge, we rapidly moved to having it in an online fashion, and definitely also we are able to change the program comfortably. We were able to get more. Am I muted? Okay, we were. Can I know if I'm muted?
You're audible.
Okay,
Somsekhar, you're audible.
You're audible. Okay, thanks. So then the foundation of early childhood development is the theme of this particular conference, and we have had a very good conference over the last 3 days, 4 days, and we have had more than 500 registrations. And at any point of time, like yesterday, we had at least 240 participants at the end of the day in the conference. So it's a large amount of participation, and these participants were from not only from India, but from across various parts of the world. And we have had people from Lebanon joining in for the conference. So it's an international conference in many ways. We try to strive for a joint commitment for KMC promotion by all leading professional organizations that involve neonatologists, pediatricians, obstetricians, nurses, midwives, and other doctors. So you can see on the screen that not only we have the 2 big organizations in India, the National Neonatology Forum and Indian Academy of Pediatrics, and also the Federation of Obstetrics and Gynecologists, but also other smaller, very focused organizations that look at, say neonatal nursing, midwives, preventive and social medicine. So we have tried and involved all the various organizations and have recruited the support for promotion of KMC, and we would try and invite many more organizations who are interested in doing this. We also look for ensuring that young doctors and nurses are awarded for various small KMC studies that they can do. And we give certificates of appreciation. And even as you'll see during the inauguration, we have awards for research programs, studies that were conducted. We have a specific sticker that people can ask us and we can send it to them. That can be posted on the discharge notices so that everyone knows that this baby received KMC. And we also had developed TV programs and training videos for KMC. We have done extensive coverage across most of India with all the 3 programs. We also have also released a quarterly newsletter, and you can write to us for with articles and photographs if you want it to be included in the quarterly newsletter. We also celebrate various KMC awareness days, the KMC Awareness Day, Breastfeeding Week, and Newborn Week. We also involve laypersons in our activities and have always performed KMC exhibitions at every conference. It is one of the highlights of our conference that we have a KMC exhibition, often almost always organized by our nursing colleagues. This year we are missing the KMC exhibition quite badly. And one of the strengths of our foundation is that we strengthen home-based KMC through our community health network. We also participate in the Asia Oceanic Network of KMC Foundation. And as Dr. Suki mentioned, we will be leading the network over the next 3 years through Dr. Shashi Vani. KMCF was invited as chief consultant and faculty for TOTs in other South Asian countries, and we have been regularly attending KMC conferences. In fact, the 2012 KMC conference that we hosted was subsequent to the 2010 International KMC conference that I think 4 or 5 of us from India attended, at which Dr. Natali asked us whether we can hold the next conference, and we gladly accepted it. And so it is an outcome of, so in other ways, interacting and building collaborations is the way forward for all of us. In 2019, we began the RH Udani, Dr. Rekha Udani Oration, which was first delivered by Professor Ashok Devrari from AIIMS. In Jaipur last year, we had Professor Siddharth Ramji delivering the oration. And as soon as this plenary session gets over, we'll have Professor J. Kumuta delivering the oration. We have had various activities. And so beginning with, this was the KMCF conference last year. It was inaugurated by the Honorable Health Minister of Rajasthan. There was a lot of, because it was a minister who inaugurated the conference, there was a lot of press coverage and interviews and videos. So it received a lot of attention. And so we are thankful to the SMS Medical College Jaipur and NNF Rajasthan for creating a lot of activity around this particular event. So as you can see, a lot of activity in newspapers and videos and even Facebook and social media. Professor Siddharth Ramji delivering the Dr. Rekha Udani oration. And subsequent to that, we had the COVID setting in, but we did not stop. We went ahead and ensured that we tried and provide an appeal for KMC, continuation of KMC in COVID-19. You'll listen to this in a bit towards the end of the inauguration. We had International KMC Awareness Day on 15th May, where we worked with various organizations in India. So this is one with National Neurology Forum, Gujarat. Then we had with the Indian Academy of Pediatrics, where we ensured that we worked at the importance of kangaroo mother care in the COVID-19 situation. And we also had an event with the Karnataka NNF, who helped us on these issues as well. At the end of the day, we had actually a public engagement where we spoke to a lot of mothers and parents. And so the focus of this interaction was actually parents talking about the experience giving kangaroo mother care. So this was interesting, and the videos are still available on YouTube. Subsequent to that, we have had success in formulating a kangaroo mother care support group at our institution in Pramukh Swami Medical College. It was done through various lectures by Professor Shashi Vani and Professor Kharod and Dr. Reshma Pujara who was pivotal in forming this particular Kangaroo Mother support group. So this support group received online lectures, and we had a physical meeting too. And subsequent to that, many of the mothers who have given KMC and their leaders in their kind of local leaders who have worked in peripheral areas of our town and worked with mothers and kind of promoted Kangaroo Mother care. So this is kind of the thing that has happened. They also received certificates for forming the mother support group, and it also received press coverage locally. Coming to the Kangaroo Mother Care, the Newborn Week and the International Prematurity Day, we had an international webinar where Dr. Natali Charpak, Dr. Niels Bergman, and Dr. Rekha Udani and Dr. Ruchina Navati also spoke. And we had government representation from Dr. Sumita Ghosh during that day. So this was something that we did, and this was a very well-attended webinar across, and we had participants from various countries too on this day. Subsequent to that, as a part of the Newborn Care Week, we also focused on having Kangaroo Mother Care in private practice. In 2020, we have not had much physical meetings, but in 2019, subsequent to a grant from Nutritional International, we did a lot of contact programs with private practitioners. We wanted to ensure that Kangaroo Mother Care is not seen only as a government program or a public health program or for the public sector, but also in private practice. And we continue to do this activity. And we had a lot of people from India who spoke on Kangaroo Mother Care in private practice. Just before the COVID-19 situation set in, we, in the first 3 months of 2020, we had TOTs where as part of the state support program, along with government of Gujarat, we had KMC TOTs at Vadodara and Gandhinagar. And because COVID was just setting in, some of the lectures were done through the Zoom platform. And we also had a TOT on home-based newborn care at Tribhuvandas Foundation. We also conducted webinars after March or April when it became difficult to hold physical meetings. And many of these lectures were online and delivered by various members of the Kangaroo Mother Care Foundation. Of note is in February 2021, Professor Shashi Vani delivered a webinar on the Healthy Newborn Network during their Care of Small and Sick Newborns sessions. Towards the end of 2020, you must have seen in yesterday's session, Dr. Ashwini Mahajan presenting on KMC in the community. So that work was also supported or helped by development of a manual of home-based KMC, which was developed by the Kangaroo Mother Care Foundation and delivered to them in December 2020. In preparation for this particular conference in March 2021, we had guideline preparation about which you will listen at 3 p.m. today. We had a lot of participation. Again, here there was international participation from many of the speakers you have heard today also and yesterday. And we will discuss this in detail later on in the evening. But we are preparing guidelines for KMC transport, which will be submitted to the government in some time. These are a few pictures from the online webinar on transport or the guidelines preparations for transport. And so overall, we have, despite COVID, we have had a very busy year, and I must thank the seniors in a foundation, Professor Shashi Vani and Professor Nikhil Karot, for ensuring that a lot of this works together. Many of my friends in the foundation, Dr. Ashish Mehta, Dr. Parag Dagli, Dr. Jatin Mistry, Dr. Ravi Parikh, Dr. Anuj, and others have been actively helping out. And we have been receiving a lot of support, like I said yesterday morning, from various parts of the country in ensuring that we are able to do these activities quite in detail. So with that, I would like to end my annual report with special gratitude to Dr. Vani, because despite several health issues in her family and sudden, she has still joined the session, and we hope to hear from her later during this session. Thank you.
Thank you, Somshekhar, for the annual report of the KMC Foundation India. Now we move on to brief messages from professional organizations. We have almost all the important professional organization dignitaries here. We start with Dr. Swarnarekha Bhatt, who is the patron of this KMC conference 2021. Over to you, madam.
Thank you, Suman. Good morning, everybody. Friends, colleagues, dignitaries, faculty, both national and international, and students. It's a pleasure to welcome you all to the inaugural plenary function of this 5th KMC conference in India. I have been fortunate to be involved in and have seen the evolution of KMC in India over the last couple of decades. Starting from when Dr. Nirmala Kesri first showed me her canvas KMC bag, and to the first presentation in the 1999 NNF conference by Dr. Shashi Vani's group, to the great work done by the KEM, all the faculty starting with Rekha Udani and her proteges. And it became a movement with the involvement of All India Institute, Delhi. But I think the biggest impetus to KMC in our country has been the involvement of the government in this program. And I really wish to take this opportunity to thank those who made this happen. We now have the evidence, and both from our country and from global, that it is useful and it is implementable in any situation. I think it's up to us now to take it forward to make sure that this is a norm and it becomes a norm for all our newborns, particularly the low birth weight neonates. And I'm sure this will happen with the continued efforts of KMC Foundation of India, all the other academic bodies that Somshekhar mentioned, and all of us who are passionate about making sure this happens. Thank you so much for this opportunity, and best wishes to everybody and all of you to stay safe too. Thank you.
Thank you, ma'am. Now we invite Dr. Ranjan Pejawar, President of the National Neonatology Forum India, to deliver his message.
Thank you, Dr. Suman. First, let me congratulate the KMC Foundation of India, led by none other than Dr. Shashi Vani. And I'm so happy that she has joined the meeting today in spite of all the difficulties she is going through. That is great. And KMC Foundation and also the team here in Bangalore, led by the organizing chairperson, Dr. Suman Rao from St. John's Medical College. I'm proud because St. John's is my alumni institution. And I bring greetings from Neonatology Forum of India. Now, we must make sure that KMC care becomes a standard of practice and norm, not only in institutions and medical colleges, but in all the small NICUs which are looking after the newborns, may it be government or private. Lot of hand-holding is required for private institutions to join in this movement. And it should happen now in the community. That is the other challenge we have got. This should happen in the community too. I was listening keenly to the report read by Professor Somshekhar. Fantastic, great work is being done because the members of the foundation are passionate about it. Wherever passion is there, there will be success is guaranteed. It's only a matter of time. Yes, the government has given a lot of support to promote KMC, and we should be grateful to the government of India too. So I end by saying National Neonatology Forum is actually committed to the KMC care. We are going to celebrate KMC Awareness Week this year in earnestness and promote all our state chapters to spread the message of KMC care in the institution and in the community. A lot of activities are being planned. Our own Professor Somshekhar will be leading it. And I'm looking forward to the next month that is going to happen. I would like to end my few words by saying, in affluence, KMC is a useful addition to infant care. In financial constraint, it is a precious gift. But in poverty, it may be the only means of survival. So that just explains that KMC is relevant to all strata of society and all the babies irrespective of whatever differences perceived by us. Thank you very much for giving me this opportunity.
Thank you, sir. Thank you very much for your inspiring message. Now we invite Dr. G.V. Baswaraj, Secretary General of the Indian Academy of Pediatrics, to deliver the message from the IAP.
Thank you, Dr. Suman Rao. I bring a greeting from prestigious Indian Academy of Pediatrics. Let me congratulate KMC Foundation led by Professor Shashi Vani Madam, Professor Swarnareka Bhatt, St. John's Medical College, Professor Suman Rao, Bangalore Medical College, Professor Sahna Devdas, for organizing this in an excellent, creating an excellent awareness, bringing in all the professional organization into the single forum, including Government of India, which is represented by none other than Professor Vinod Kumar Pal and Dr. Shamik Ghosh Madam. As we are all aware, early childhood development is one of the dream project of Indian Academy of Pediatrics. KMC is one of the part of it, as we rightly mentioned by Professor Ranjan. So it is in one of the economically, especially developing countries like India, where it will be in a part of a nurturing and routine care in the newborn. Of course, the WHO, UNICEF, and IAP, NNF, and IAP Neonatology Forum, all the things are coming across to deliver and creating an awareness of the KMCs is something unique. It is taking in a movement shape. Once again, I congratulate, wish you all the best for all these things. Thank you. Over to Suman.
Thank you so much, Dr. Baswaraj. Now we invite Dr. Naveen Bajaj, Chairperson of the IAP Neonatology Chapter, to deliver the message from IAP Neonatology Chapter.
Thank you, Dr. Suman. It is my honor to be a part of this conference and share stage with the stalwarts and pioneers of KMC in India, like Dr. Paul, Sir, Dr. Madam Shashi Vani, and my teacher, Dr. Rekha Udani, Madam Swarnareka Bhatt, who not only initiated KMC, but also has been on the forefront in spreading the awareness among all of us when we were students at that time, and when the KMC was started in India, among doctors, among nurses, among healthcare workers also. And on behalf of chapters, I really appreciate their efforts, and I must congratulate KMC Foundation led by Dr. Shashi Vani, Dr. Suman Rao, Dr. Som Shekhar in conducting this sort of conference, even the hard times of this pandemic year. And we all wish them all the best. And on behalf of the chapter, from all the chapter members as well as the office bearer, I assure them full support of any kind. If there is any program, participation is needed, we are all there, and we will support to this cause of KMC, and we will support the awareness which is being spread by the KMC Foundation and this conference. Thank you.
Thank you, Dr. Naveen Bajaj. Thank you very much. We had Dr. Alpesh Gandhi, President of Foxy, with us. A short, is there?
Yeah, I just spoke to him. He's actually making a presentation at this point of time. So he has conveyed his regards, and he said that Foxy fully supports Kangaroo Mother Care Foundation, and whatever that needs to be done from their side, he's very much ready to go ahead and do it. He had joined, but he has his presentation right now in another place. So at this point of time, he's not there. So he said sorry, but he said his society definitely supports Kangaroo Mother Care Foundation and will promote Kangaroo Mother Care in whatever way is possible. Thank you.
Thank you, Som Shekhar, for bringing the message from Dr. Alpesh Gandhi and Foxy. Now I invite Dr. Roy K. George, President of TNAI, to deliver the message from this important organization.
Thank you, Dr. Suman, and a very warm good afternoon to all the dignitaries. I bring the warm greetings from the Trained Nurses Association of India to the Kangaroo Mother Care Foundation. It was really exciting to hear the detailed report of the activities of Kangaroo Mother Care Foundation by Dr. Somasekhar in this fine morning. Actually, Trained Nurses Association of India, a 4 lakh plus member association of nurses in India, of with 113 years of history, was always associated with forums like Indian Academy of Pediatrics, Indian Neonatology Forum, Neonatal Nurses Forum, in promoting mother and child health. We have involved in various activities throughout our career. Moreover, as a professional organization which represents nurses, the largest majority health professional among all health professionals, and which consists of more than 90% of female population, we have a specific responsibility in promoting maternal and child health, and we admit that. Though it is a largely a women's association, unfortunately the current president is a male, myself, but we are committed to our root objectives, and we will be always happy to associate with Kangaroo Mother Care Foundation in bringing awareness to the grassroots level, because we nurses are there with the mothers and children, more time with mothers and children other than compared to other health professionals. So we identify our role and we commit to the cause of Kangaroo Mother Care. It is definitely it will be nice to work along with Kangaroo Mother Care Foundation for bringing the message to each and every corner of this great country. And I'm very happy to learn that Kangaroo Mother Care Foundation has organized this conference in such a splendid way, bringing all international experts and the people like Dr. V.K. Paul and the government of India, other dignitaries, to promote this cause of Kangaroo Mother Care Foundation. So once again, thank you very much for this opportunity, and I take this occasion to declare our unconditional support to any movement of Kangaroo Mother Care Foundation in bringing better health for children and infants and mothers in our large country. Thank you very much.
Thank you, sir, for your unconditional support to this cause. And we all know that nurses are the backbone of any neonatal unit. So thank you very much. And now we invite Dr. Parul Datta, the Vice President of the Indian Association of Neonatal Nurses, to deliver the message of IANN. Over to you, Dr. Parul.
Thank you, Dr. Shumon. Good morning to one and all. Thanks a lot to the organizing committee for giving me this opportunity to share my views and commitments towards Kangaroo Mother Care for preterm and low birth weight neonates on behalf of Indian Association of Neonatal Nurses. Many thanks to Kangaroo Mother Care Foundation and all the national and international faculties and all the participants and colleagues. So we all know that number of preterm birth is increasing due to lifestyle changes. And for intact survival of the small infants, KMC is a very significant and easy to practice multimodal support care approach. With the neonatal nurses, we believe that it is our significant responsibility to promote the quality Kangaroo Mother Care for the intact survival of the small infants with no harm principles. We have to bear this responsibility because neonatal nurses are the backbone of neonatal care. We hope that all neonatal nurses working in all levels of neonatal care should provide Kangaroo Mother Care confidently and competently, remembering their responsibilities. We have to do the counseling for the mothers and the KMC providers and the family members. We have to initiate Kangaroo Mother Care to the stable neonates, and we have to assist and support during the Kangaroo Mother Care procedure. And for their therapeutic effect, we have to monitor the baby during the Kangaroo Mother Care, and also we have to teach that monitoring procedure or monitoring process to the mother and the KMC providers. We have to ensure the exclusive breastfeeding. It is one of our important responsibility. And we have to emphasize on the feeding with the mother's own milk, and that is continuation of the development and nutritional support to the newborns. Another responsibility for the neonatal nurses is to maintain the KMC records for the further reference and for the reporting of that findings. And another most important responsibility is to motivate to continue the Kangaroo Mother Care after discharge from the hospital or the facility, to continue it at home, and also for the follow-up care, effective follow-up care for the effective growth and development of the newborns baby, especially the small infants. And that's why the discharge counseling is also another important responsibilities of the nursing professionals. I think neonatal nurses, those are working for the newborns in all levels, in the private sector or in the government sector, in the facility or in the community, they will take this challenge, and I think they will fulfill this commitment towards the better survival and intact survival of the neonates. Thanks, Kangaroo Care Foundation and the organizing committee of this conference for giving us this opportunity. On behalf of Indian Association of Neonatal Nurses, I think we will be able to take this challenge in future. Thank you again to everybody. Thanks.
Thank you, Dr. Parul. Thank you so much for rising up to this challenge and expressing your support. Now we wait and invite Dr. Shashi Vani, the Managing Trustee of KMC Foundation India, to address the gathering. Madam, for the past 2 days, everyone has been waiting for you because they have missed you so much. And we truly appreciate your commitment to this cause. We all know how difficult it has been for you. And over to you, ma'am.
Thank you very much. I especially came to this meeting mainly to convey my gratitude to each and every one of you for doing such a wonderful work. And Dr. Vinod Paul, Dr. Swarnarekha, Dr. Ranjan Pejawar, Dr. Basavaraj, and all the people, each and every one of you have been great well-wishers and patrons for our child health and newborn care health. And you have taken a lot of time to address this meeting. I'm really very thankful to all of you. And here from Kangaroo Mother Care Foundation, you would have noticed that we are of very small capacity, but still have a big dream in our eyes. And that is how we are trying in our own small way to promote Kangaroo Mother Care as a part of newborn care, which is a part of child health care in India. So from that angle, we are trying to promote it. We have come a long way. I do appreciate, but still our dreams are not full. 55% coverage. We will not achieve all the benefits that we are claiming from Kangaroo Mother Care, including reduction of neonatal mortality to almost 25 to 30%. So unless all of us are going to work much more proactively, we will not achieve that objective. And that is why I plead each and every one of us that we are not to be satisfied with what we have achieved, but we have to keep the goal, what we still remain to achieve. We have to expand the scope to the community, even in the remote resource restricted regions, and to the best of the tertiary care units also, and also in neonatal transport and so many other points which already have been told. So we have to achieve our motto, which we have said, that Kangaroo Care is the best place. That is, mother's chest is the best place for the newborn care, whether it is term baby, preterm baby, sick baby, normal baby, but it should become a part of our routine care. Mother's milk is the best food and zero separation. And it should become a part of every newborn routine care part, it should become. And that is why we have so many other things to fulfill. Improve our record system, improve our definitions, improve our coverage, improve our knowledge and attitudes, and so many unfulfilled things are there, a long way to go. And I'm sure with the enthusiasm people are showing now, we will achieve it. And our special thanks to all our members of the Bangalore team with leadership from Suman Rao, patronage from so many senior professors, including Dr. Maya, Dr. Swarnarekha, Dr. Asha Benakappa and others, and Dr. Koturesha, Dr. Bharti and so many people. We have had an excellent program in spite of so many difficult things, and all the international and national faculty members who have taken time for this subject. So in the end, I just quote, in Bhagavad Gita scripture, we say, Nimitta matram bhavasavya sachin. That is, you just be an excuse to start the program and it will have a catalyzing effect. So I am really glad to see this, and thank you one and all, including the participants, including the helpers and everyone. And excuse me for not mentioning any one of you, but it is really heartening to see that this Kangaroo Care movement is gaining a lot of momentum in our country, and it will spread, and I'm sure we will achieve the final end. Thank you one and all.
Thank you very much, ma'am. Now I think all delegates and all participants, including faculty, will go away from this conference satisfied for having heard a message from you. I know you probably are doing it from the hospital. Thank you very much, ma'am. And now we go over to Dr. Chandrakala, DDCH Karnataka. Dr. Arunjati Chandrasekhar, our MD NHM, is unable to join because she's in a meeting to devise programs on how to battle COVID. But Dr. Chandrakala has ably stepped in. And over to you, madam, Dr. Chandrakala, for a brief message from NHM.
Namaste. Namaste, everybody, friends, dignitaries, and participants, and also the organizers who have taken great effort for this organizing this program. So actually, our MD NHM she is very much interested in participating in this, and she is unable to come since she is very busy in our COVID work. So she has asked me to join here. I think I'll just brief up what all the government facilities, what all the help we are doing from government in order to strengthen this SNCU, KMC, and also in order to reach the SDG goal, SDG goal 3. So, as you all know, kangaroo mother care is a simple method of care for low birth weight infants that includes early and prolonged skin-to-skin contact with the mother or a substitute caretaker, and exclusive and frequent breastfeeding. Also, this has to be linked up with MA program, Mother's Absolute Affection. So KMC is, and also in this exclusive and breastfeeding is also very much important. And it has been classified based on the duration given as like it starting from 4 hours to 12 hours. It can be extended per day. So benefits to the newborn in this KMC is like it stabilizes body temperatures, decreases morbidities, and better neurodevelopment, and early discharge also it helps so that they can go home early, and promotes breastfeeding, prevents infection, and encourages bonding in mother and child. However, during this workshop and conferences, you will be cleared on topics like how to give KMC and which babies require KMC, and also the benefits of KMC, position and optimal breastfeeding also. So KMC can be provided by mother, father, and other adult also in the family, like who is willing, and only thing is healthy with basic standards of hygiene thing. They have to they have to follow certain hygienic practices also. So KMC development plan, like KMC unit of 8 to 10 beds recommended for every hospital with SNCUs. And KMC must be the integral part of the existing new upcoming SNCUs and MCH wings, postnatal wards, and NBSUs. Whichever newly now we are suggesting for SNCUs, there and all it is a mandatory. So the neonatal unit at all medical colleges to be strengthened to provide appropriate newborn care, including KMCs. So with this plan, we have conducted KMC state level TOT trainings workshops during 2018 also, and in which we had 210 participants, including RCHOs, SNCU staff nurses, and SNCU pediatricians, and labor room staff nurses from each districts we had. So with this workshop, we are able to roll out KMC successfully to all districts. At present, we have 40 KMC wards established in all districts, like where all we have SNCUs, and only in 2 taluka SNCUs, like we have to just, it will be done soon, since they were newly started SNCUs. So we are now it has to be, KMC has to be started now, to provide supportive services to low birth weight preterm babies to improve survival rate also. So which will be done soon. Support for infrastructure like HR and consumables and maintenance of maintenance cost for KMC is also provided through NHM. Like 2 to 4 staff nurses will be given to each KMC and KMC unit in all the districts, depending upon the beds, like how, if it is, if you have more beds, KMC, I mean more infants are there, like more staff nurse also can be given from NHM. So usually 1 lakh per annum is provided for each KMC ward, so that they can utilize it for maintenance and consumables. And even depending if they want any HR support also, it can be given. So since KMC is very important, we, as like in all SNCUs, we have KMC wards, so we give much preference to this KMC, and also this help us in initiating early initiation of breastfeeding also. So that also the staff nurses will train them. So not only KMC, like giving skin to skin contact from this program, even early initiation of breastfeeding also can be promoted. So it is what to say, like linkage between early like breastfeeding and also initiation of breastfeeding, and also we can bring down the morbidity of the infant. So
thank you, ma'am. Thank you very much for the message. And I think it is very important to realize that KMC is a stepping stone for linkage for better development of the baby. I don't know whether Dr. Vinod Paul has other commitments at 12:30, but we will continue our program now and invite Dr. Rajesh Mehta from WHO to deliver the message.
Thank you, Suman. Do you see this poster at my background? This zero separation policy was adopted in 2018 WHO regional meeting in presence of the national governments, the researchers. There were multiple research teams. Suman was there, Professor Vani was there, Dr. Chilani was there, Nil and Jill Bergman, and all of these people were there. Bjorn was also there. But we soon realized that this was one of the easier initial steps. A lot of work would still be required. And Professor Vani in that meeting reminded us that this, is a very familiar intervention package about which the science is very clear. The most challenge has been how to implement at scale. And we realized that we have to bring all the stakeholders together, researchers, the policymakers, the implementers, and the beneficiaries of this intervention together. And therefore, it is highly commendable of this organization committee, the KMC Foundation, to have assembled all the experts and stakeholders together once again. The efforts are required to bring it to scale at population level. While some centers of excellence have shown it is completely feasible and possible with all the benefits which accrue for us, but the challenge would remain to take it to population level. So it is our pleasure to support such efforts. My WHO and our sister agency UNICEF, who is also there in the meeting, and other partners are always committed and convey our appreciation as well as support to such activities in the countries, in India as well as in the region. And we are so eagerly looking forward to another stalwart, Professor Vinod Paul, to hear his words of wisdom. He is an illustrious expert, as you know, from the region and globally renowned. So we look forward to him. And congratulations, Professor Vani, for your long-standing work and the organization committee to have brought us all together. Thank you.
Thank you, sir. Thank you for your message. Now we invite Dr. Luigi Aquino for the message from UNICEF.
Hello, good afternoon, everyone. And I realize I'm probably one of the few separating the audience from the address of Dr. Paul. So let me try to be as fast as possible. First of all, thank you on behalf of UNICEF for organizing this event. I realize, and I think we need to realize as we go, that as much as this pandemic is wiping the world, babies keep coming to life. And we cannot leave the agenda of maternal and newborn and child health behind. So thank you so much for this collective reminder and for amplifying this voice of not forgetting about our children during this pandemic. I have just 2 or 3 reflections to make. The first, you will see this diagram at the back of my back. This is the WHO Global Framework for Primary Health Care. And if I hear about kangaroo mother care, I think of primary health care. And if I think of primary health care at its best, one thing that I believe all of us, or many of us collectively tend to forget, is that at the center of this diagram or of the concept of primary health care, there is community empowerment, community awareness, community engagement. So before we look into the health system as such, let us please consider that this is a simple, free of cost intervention as much as breastfeeding is, and that therefore the best we can do to reach out to communities through all the institutions that are alive within communities to make them aware of this is a great and beneficial added value to the agenda of KMC and of child health in general. The second is a message I want to pass is on the health system side. We have reached, I think, nearly universal skill health delivery in India. We have SNCUs across virtually all districts. So we are set. There is no excuse not to reach coverage with quality. It's just about investing. And in that, if we have to fight the battles, let us start from unpacking the bottlenecks. We have aspirational districts as a starting platform to look at, and not the only, but a starting platform. Let us focus the attention of all the partners. Many of you are, or the critical one are here. Professor Vani, you said we are small. None of us alone will reach anywhere. And if there is one thing that COVID has taught us is that we can work together effectively. So I think let's focus efforts against certain bottlenecks on both the demand and the supply side. And finally, and I'll stop it there, let's use data to measure progress or non-progress. We have HMIS, we have the SNCU's MIS online, we have the RCH portal. We need to triangulate this data and see where progress is happening and where not. With that said, thanks a lot, and really congratulations on behalf of UNICEF. Our doors are open across 14 offices in India. Please do not hesitate to knock at our doors. We are there.
Thank you, Dr. Aquino. Thank you very much. And now I invite Dr. Sumita Ghosh to give a brief message. Madam, may I request you to keep your message brief, because I'm so worried that Professor Paul may have to jump off to another meeting and we might not listen to him. Yeah.
Sure. Good afternoon, Professor Paul and all the dignitaries who are here for this very important conclave. ECD as well as kangaroo mother care, both of them are so interrelated and so very important. I am very happy to be a part of it. I'll just make few quick points, realizing the immediate survival benefits of these small newborns and the long-term, long-term, intermediate term, immediate benefits. Government of India has already committed to an integral approach at to integrate KMC in all kind of newborn care. In 2014 guidelines, we have committed to it. I'll tell about only very 3 important points now. Now we have around 914 SNCUs, and we have started this MNCU concept. We have MNCUs now, and they zero separation, promoting kangaroo mother care, zero separation in hemodynamically stable, small newborns. And last year, 2020, we came out with the NBSU guidelines. We did not have any separate training guidelines, training manuals for NBSU. So the thirst is on strengthening these block level, CHC level, FRU level institutes, which can take care of the, not so sick low birth weight babies who are stable, who can be managed, who can take out the load of SNCU. So large scale capacity building, with this is in line this year. We have given, we have heard from the state just now how, support is being provided for capacity building, as well as for, small kind of infrastructural required changes, as well as for other IC having some separate, area for with privacy, and some furnitures for KMC, promotion of KMC. So all these are being supported, and this year all these 2,500 plus in CHC level facilities we have strengthened in a big way this year. So this is one step I think will promote kangaroo mother care very well across the country. Another this thing which is coming up is the facility-based certification, where we have made KMC compliance as one of the major criteria, and we would like to have not certify any facility, even if it is for sick newborns and all, not to have unless they promote it. The community part, again, the follow-up SNCU discharges are being followed up, and through our HBNC visits. And the major challenge is data, of course, because kangaroo mother care, I believe, yes, no is not the answer. That started not given, because we need to have more contact, more, a maximum possible interaction of the mother, zero separation between the mother and the baby. So all these issues are being handled, and our data and NBSU data also we have combined with our SN. We are trying to have that online with our SNCU. So I believe with these steps, the real spirit of this kangaroo mother care, the Bogota declaration should be realized, that it should be the right of all small babies, as well as the ECD SDG 4.2, that early childhood development should be the, it should be have right of all born in India. So we are moving towards it and seek cooperation for all those who are very much involved, the foundation, all our partners, all the private sector, because government sector, private sector together, this should be a movement which should spread, and it should be the normal routine care of our small babies who need it all the more. Thank you very much for this opportunity here.
Thank you, ma'am. Thank you very much. And now we move on to the most awaited talk by Professor Vinod Paul. I invite him to first release the ardent appeal prepared by the Kangaroo Mother Care Foundation of how important it is to promote, support kangaroo mother care even during this COVID-19 pandemic. We will be sending out this ardent appeal by email to all the delegates of this conference. So Professor Paul, I now invite you to deliver the address and address our gathering. I do hope, being a Sunday, you can spare another 10 minutes to continue being with us, though I know we are top of time. Over to you, Professor Paul.
Thank you, Dr. Rao. Good morning. Most respected Dr. Shashi Vani ji, Dr. Natali Charpak, President NNF, Dr. Ranjan Pejawar ji, Dr. Baswaraj ji, distinguished leadership of TNAI, Dr. Roy George of IANN, Jyoti Sareen not being there, but great friend, and Dr. Parul, thank you for that wonderful statement that you made. Distinguished officers of the Government of India and Government of Karnataka, my friend Luigi, Rajesh Mehta, distinguished partners of esteemed UN organizations, and my very dear friend, Dr. Swarna Rekha Bhattji, soldier and arm partner in arm for a long time, and truly the entire fraternity of Neonatal Forum, neonatology, stakeholders of neonatology, newborn care. I've been missing you all for a long time, and it's such a pleasure to get back to the circle of friends that we grew with. So thank you for this opportunity, Suman. And thank you, team Bangalore, team Karnataka, for setting up such a very well organized, very impressive virtual meeting. Very nicely done. Thank you so much. Well, I think first and foremost, the recurring statement that you all have made, I like to start there by saying that today, kangaroo mother care is a standard of care for newborn babies. Standard of care. The babies who are eligible for kangaroo mother care, for them, it must be delivered. It must be delivered in every facility, every home, as per the protocols. It's to be delivered globally. Rich nations, poor nations, urban settings, rural settings, everywhere. So in that sense, we have come a very long way. I congratulate the leadership in this area, and of course, starting with none other than Dr. Vani. I do recall way back in early 90s, Dr. Vani started this work, and very early. It was with the help of WHO, Dr. Shah, who was reproductive health focal point in Geneva. That was the first project, and I had the opportunity to witness the very early work. And it looked complicated, but with time we gained experience. We found how to do it very, very well. And at a very opportune moment came inputs from Dr. Nathalie, came inputs from Save the Children, and a number of pediatricians, neonatologists, and colleagues started to examine kangaroo mother care in a more systematic way, with an open mind, with the willingness to make a difference, to adapt it to Indian conditions. And that I salute all those people, all the researchers, residents, nurses, students, and faculty of various institutions and consultants of various private institutions who made this possible. So first and foremost, truly we can take pride in 2021 that kangaroo care in our country has come a long way. Work of over 2 decades, but we have come a long way. And to hear statements from the government of Karnataka, impressive work, it's a standard part of the care in all the SNCUs in Karnataka. You made it possible, you made it accountable. Extremely impressed. Also from Dr. Ghosh, with all the passion that you are stating, that it is to be seen, to be implemented in every SNCU as a part of NHM, shows the commitment, and shows how the advocacy effort, the science effort, mobilization effort, capacity development effort put by the stakeholders over a period of time has led to this kind of a momentum. So it's a very satisfying day. And Dr. Vani, you should be very happy today with the task that has been achieved, truly. So that's the first reflection. And also conceptually, linking it to ECD, early childhood development, I think is a very smart idea. Scientifically valid, but also in terms of the future of KMC to link with ECD, I think truly smart, and I appreciate that. And I'll come back to that in a minute. But let me say that when we began this journey, the idea used to be, we started with giving warmth. It is a way to provide warmth. It is a replacement of incubator. And then came the knowledge that, well, it promotes breastfeeding. Well, fair enough. Then came knowledge and experience and became visible. Infections. Then came evidence, a very strong evidence, to which AIMS contributed, was that infection rates are low I think that was in a way a game changer for the global community, for the scientific community to start looking at this as a survival intervention, not just a promotive intervention, so to say, in a way, because that would then demonstrate that you can demonstrate reduction in mortality. In the MDGs era, the reduction in mortality was the key, and therefore I think from feeding to warmth, and to say it reduces infection, reduces thereby deaths, I think was an inflection point in our learning about this great modality of care. And now moving onwards, we learned it is bonding, it is about neural networks, it's about so much more. And that then puts it in a very totally different league for any intervention for perinates. But I think truly that if we are making it as the lever and the fulcrum for early childhood development for the at-risk babies, small babies, it's strategically appropriate and it is very timely. Because in our country, the national education policy, the so-called new education policy, looks at ECD as a very pertinent area of work. And in that discourse, I want to, and Lucy is here, and Rajesh, you are also aware. See, when it is ECD in the parlance of policy, often it is post 3 years at times. It is seen as post 3 years because that's how you did your ICDS. Anganwadi, that you come there, you learn and you develop, and it's a preschool moving into schooling. Believe me, this is the way it is taken for the time being. But we as pediatricians know that ECD is about the first year, the first few weeks, the first 6 months. We always knew it. First 3 years, first 1,000 days. So our paradigm coming from biology and coming from the growth of the brain and the pure experience of childhood, watching children grow, we know that the critical part is ECD. Now you think about it in our policy framework. The ECD dimension, if it is to cover the first 3 years, particularly the first 6 months, particularly the first year, it is home, it is mother. And there, for small babies, to use kangaroo mother care and the skin to skin and mother's chest as the start of ECD promotion is absolutely rational and absolutely essential. So positioning this in the paradigm of ECD, in addition to other interventions, I think is extremely valuable. And you are backed by science, you are backed by biology, you are backed by research in this regard. And therefore, I think we should take it up in the paradigm of learning as well. School, people who are talking about development and not just people like us who were obsessed with survival. And I'm saying this also from a policy analysis, the young people should know. Much of the 90s and till the 2000 first decade and little more than that, the whole focus was on survival. You're looking at mortality reduction for newborns, for infants, for children. Mortality. Reduce mortality. And we reduce mortality, but using the interventions that help reduce mortality did not do justice to two aspects optimal. One is brain development, but we were concerned intact survival, we would say. So we gave a second priority to this. But the third priority that we overlooked was nutrition. So we got babies who were undernourished. We got babies whose brain growth may have been compromised in a way because of nutrition, not because of infarcts and intraventricular hemorrhages. So the point that I'm now making here is that from moving from the paradigm pre-MDG or MDG paradigm or even NHM paradigm of survival, we are now not only looking at intact survival, which we would talk because we will feel guilty finding babies who are not doing well in terms of developmental milestones, but we never optimize their nutrition. And I don't think we optimize their development in the holistic sensory development, which is also linked to nutrition, not just only macro, but micro. So the thought that I'm plugging here, which some of you may already be concerned with, is that for us neonatologists, pediatricians, it is time that we bring in the dimension of holistic and successful nutrition, holistic and successful early childhood development, and not just gross intact survival. So we are pushing the frontier, and there have using kangaroo mother care as an enabling intervention, which provides us all of these, is a great reason for us to march forward with greater vigor for kangaroo mother care. So I endorse your view on this, and thank you for bringing that aspect up, and let's make it into a debate. Let's make it into part of our strategic framework. I'm very impressed with the report read by Som Shekhar has read a report for a foundation which is of a very modest means, but clearly driven by passionate team. To achieve this much in a year, and that also a year of great difficulties because of COVID, I think it's remarkable. I would not know many institutions of this size who would contribute this much over a period of 1 year. What I like very much, ma'am, Dr. Vani, with your team and the entire foundation, is the fact that you have built strong bridges with other institutions and other organizations and professional organizations, which is a stamp of the way you work, which means reaching out to people, connecting, bonding. And that, I think, is a great lesson for this foundation, for others of this foundation, for others to follow. So saluting you for the partners you got together, being, modest, but wonderful team you have. It's actually a salute to your team. Let me now throw and share some ideas as I heard and as I see the scene broadly, and what are the areas where we can think about more effort as much as possible as we can put. So firstly, it's not in a particular order. Firstly, I'm looking at, let's remember how kangaroo mother care actually became from an idea, a movement. It happened because we started doing a lot of training. We enabled people to do and to conduct and to operationalize this particular intervention. Of course, there was a parallel strand of research which helped, and the global research and also India's research. But I think ultimately it was moving forward because we had more and more people who were familiar, who would try, who would practice in nurseries and in SNCUs. So I think more of that is better. Remembering that training to the cohort of providers today doesn't mean that tomorrow's trainee is also trained. The point I'm making is it's a moving agenda. There are more people, fresh nurses, fresh doctors. So this can never be enough. And therefore, my request is that we continue to intensify training of nurses in particular, but also, so therefore, one criteria, Dr. Ghosh, you must have is every nurse in the SNCU exposed to training for kangaroo mother care. We cannot expect kangaroo mother care unless you are formally trained. And now we know that trainings can happen in a hybrid mode, to say the least. And therefore, it is possible to use the platforms such as ECHO, which I saw, and other platforms to do it. So training can be now accelerated by these means because there are some people who are trained who can do the demo and build. So a speed of training can be faster because I'm sure we are inducting new nurses all the time in all our units. Therefore, never forget that it picked up because we trained a lot of people. Of course, one lighter vein, one big problem that we had in the beginning was a mindset problem, that of the doctors, but then that we looked after way back, very much way back. So now it is to move, and a lot of training should happen. Also, I think, Dr. Ghosh, training of ASHAs. You see, we made the home-based newborn care module largely based on, again, the survival paradigm. You just go back, it's culturally model survival. But optimality of feeding and having appropriate nutritional outcomes and sensory motor outcomes and development outcomes was really on the side. Because as I said, much of our life was spent on, trying to work towards survival, and therefore it doesn't optimally reflect in that particular module. That's the point I'm making, that the training that the ASHA workers have received and are receiving today, if any, does not have this particular skill optimally reflected in terms of practice, in terms of orientation. So this is a gap that we can plug. And again, know that there is a turnover of ASHAs. The ones you trained them way back may not necessarily be active. And so be mindful of this aspect. And I think the energy and vigor with which you are taking forward for you to plug in this as part of the program and reminding them, then tracking it very well would be very useful. I would also request you to look at how the Health and Wellness Center paradigm can be connected to this through, for example, if somebody has difficulty feeding, difficulty latching, today from home also you can do a consult via the Health and Wellness Center with somebody who can guide better. So start placing this on the telemedicine platform of the Health and Wellness. Don't let the Health and Wellness Center, though it is a static entity in a way, but there is an outreach being done by the same ANM and the ASHA workers are a team. So use this new paradigm, lest we lose this. Because now we are putting up this center. We have done 75,000. Let everybody know that if a woman needs help and counseling, it can be done by the mid-level provider at the Health and Wellness Center as well. वहाँ जैसे हमारे पास आके दिखाते हैं बेबी को ये नहीं कर रहा, हम दिखाते हैं, वैसे वहाँ भी तो हो सकता है. हर एक चीज आउटरीच में घर में क्यों होनी है, उसको भी स्ट्रेंथन करो. और उसको हेल्थ होम वाले को स्ट्रेंथन करने के लिए यूजिंग the video clips on a smartphone is a great possibility. And by the way, that then connects to home care extended from higher doctor, mid-level provider, connected to home directly, holistically, and part of which being kangaroo mother care, which may not be optimally out there, is an opportunity. So you work for this, and also to get SNCU staff all the time refreshed on this point. My second suggestion is this challenge of private sector engagement. I would like Dr. Pidavar to think how well we are doing with the private sector, because there the resources are not an issue. The reaching out to them is not an issue. Can we make a difference, true difference in the private sector side of newborn care? It may already be very good, but can we talk about it? And can we use the resources of CII and corporate to create a parallel, like a resource for private sector engagement? Because I'm not sure how much we are doing on the private sector delivered baby front. I truly am not sure. I know there are champions. I know it's being done very well in places, but if it is a norm, why is the private sector, which is well resourced, is not following it to 90%? And if they are finding a 90%, we will celebrate. Next time, if you report that it's being done 80%, 75%, be happy to celebrate. And we can bring those positive stories to build the narrative further. My next suggestion is reaching out to the people directly. Reaching out to mothers. Do we have you may have some resources on your website for enabling mothers to do it themselves, self-care. Do we have that kind of so we can popularize this. So mothers can simply put the video on and take self-help. And then there could be a call center that they can call, bypassing the people who may then charge money, for example, right? So to a certain segment, the middle classes, why not? If this is the route that's workable, we can work with that kind of a route. And I think it is a very low resource and low intensity, but I think successful work that we can do. So I'm appealing therefore to you, use your website or the digital means of channels to directly reach the mothers. And that then is tied up to reaching young mothers through social media. So this is something which you as a foundation can crack, because it doesn't need 200 people. It is a product and you put that product on the platform. So can we invade social media and everybody, young people are on social media. Someday they'll be parents, and we should use that platform, use the influencers in that, use the events that you plan, preterm week, this, that, to get the influencers on the side of social media to be our converts. And therefore, that opportunity is available to us. Social media is using this opportunity to do many good things, many interesting things, and several foolish things. We can do our part to promote a great cause through social media. But that means that we have electronic resources, we have the way to communicate. And I think that, I'm sure here Rajesh, UNICEF and others can be helpful, but the corporate world can be helpful. So this is not a big ticket in terms of money. So think about this idea to be pursued. I would urge you in the same goal, look at the nursing curriculum, IANN and TNAI, that I hope the formal curricula of nursing, PSC, have this element right there. And if it is not, I'm sure we all can do it very fast, because then people are trained from the beginning. I'm sure by now we have cracked that. But certainly, if these curricula don't have it and the textbooks don't have it, can we make it happen? So that's the other suggestion. I also like to remind you that the Poshan Abhiyan and the Poshan Mah, which is September, and Poshan Pakwada, which is March, notwithstanding COVID issues and dislocation, is also an area, because there we position kangaroo mother care as nutrition and child development. The portion is about nutrition. And you have heard me, some of you may have heard, you see the recognition that children who are ultimately undernourished, stunted or wasted, a lot of them are small babies. And we don't recognize them to be targets or their families to be targets specifically, because it falls on the shoulders of the health department. So the nutrition side system, WCD, and corresponding departments in the state governments, because the first few weeks are health. So home care is health, right? So it is not recognized that a small baby is already wasted, stunted, or both. And you catch the wasted, stunted at 9 months and 6 months and 1.5 years and start working on that. This is a disconnect because of certain fragmentation in the system. The point that I'm making is, can we bridge it? And therefore, yes, the WCD system does talk about breastfeeding, but they talk about breastfeeding in such generic terms that the fellow who needs it the most and the fellow who fails the most is not on the radar screen. It's very generic. And therefore, bringing the feeding of small babies, which means express breast milk feeding, expression of milk, and kangaroo mother care, all together, low birth weight feeding plus kangaroo mother care, or kangaroo mother care must be brought center stage. And the opportunity for you to do are several others, but certainly during Poshan Abhiyan. So be a partner in Poshan Abhiyan and say this is about small baby feeding and small baby care and small baby nutrition and so on. So use that opportunity, and states don't have to wait for the Poshan Abhiyan to come. If Karnataka government is so committed and so forward-looking, I have no doubt that if we have floated this idea today, we can work on this from tomorrow with the team, such a wonderful team that we have in Karnataka. And therefore, please position kangaroo mother care on the feeding, the child development side of our health system. We know it works. We know it as a pediatrician. But then that side is not active and doesn't know. And Luigi, I hope you are listening. And you know that I keep lamenting about this, and please do something about it. The other last point I wish to make is that, yes, all this will need resources. A foundation of the size and the means of the KMC Foundation India is definitely needs help. So I am very happy to endorse all the application of the foundation to Luigi and UNICEF India, WHO India, WHO CRO, with all my emphasis that please support them. So whatever check they ask for, you please give it, right? And now it is for the foundation to ask for more. There's so much work to be done. So whatever comes from you, you will just say it okay, and and Yasmin will sign. And also, Rajesh, you do your part, please, because this kind of a, straightforward goodness must flow. We are on a roll, but it is still away from being a daily norm. It's still away from being a mainstream dialogue. And I request, therefore, all stakeholders, the forum, the foundation, the FOXI, IAP, everybody, to get together around it. But truly a great satisfaction with the progress that you see and the future that beholds for this great boon of nature and science and driven to this level and accelerated to this level by great stakeholders and champions. Thank you very much. Jai Hind.
Thank you, sir. Thank you very much. You have given us the roadmap for each organization of how to take not only kangaroo mother care forward, but all that which is important. A big round of applause from everyone, although it is virtual. So thank you very, very much, sir. We now proceed on to the vote of thanks, which is being delivered by Dr. Somsekhar.
Thank you, Dr. Suman. Dr. Parag was supposed to do these honors, but he has fallen sick in this time. So I'll just be brief and short. I would like to thank Dr. Vinod Paul for this wonderful talk and the guidance that he gave, and all the other dignitaries that addressed the inaugural session today. We will have a very elaborate valedictory function, during which I will thank everyone in detail later. But for the time, because we are behind time quite a bit, I would like to make it a brief and thank all the people who joined the inaugural function, spoke at the inaugural function, and have been at the conference for the last 2 days. With that, Dr. Suman, I think we'll go on to the next program. Thank you very much, and God bless everyone.
Thank you, Somsekhar. At the end of this, we would like everyone to switch on their videos for a virtual photograph so that we do have documentation of these in these times. Thank you very much. So I hope all the, yes, please. Yeah, it's okay. Please do smile, even though it's behind your mask. Thank you, Professor Vinod Paul. We know how difficult it is to even sit for 1 hour, 1.5 hours during these difficult times with so many commitments. We appreciate each one of you all who have done this, because this is during this time where you're battling not only at a national level, but even at your own family levels at times. And despite this, so many of you all are here on this platform. So thank you. And we now proceed on to the very, very important Professor Rekha Udani Oration. And I would just like to tell our young researchers who have been waiting for the announcement of prizes, we want you to have your full limelight, and therefore we'll be doing it in the valedictory without any constraint of time. So please do wait for it. And over to Dr. Bharti to start off the procedure of the Rekha Udani, Professor Rekha Udani Oration.
Thank you, ma'am. I hand over this podium to Dr. Somsekhar for the proceedings of the Professor Rekha Udani KMC Oration.
Thank you, Dr. Bharti. It's a pleasure to be here along with Dr. Ashish Mehta and Dr. Vani for the oration. I would briefly talk about the oration, and then hand over to Dr. Ashish Mehta. We began this oration, as I said in the report, in 2019 in the name of Professor Rekha Udani. Dr. Rekha Udani is actually here with us on this platform and is listening to this. She passed her MBBS in 1970 and did MBBS in 1970 from Lady Hardinge Medical College. Thereafter, she has been working for most of her time in Mumbai at medical colleges. studying from Grants Medical College, Nair Hospital, KEM Hospital, and later on after retirement from government service at the D.Y. Patil University. It is in KEM Hospital that where she began most of her Kangaroo Mother Care work, and she had her KMC experience. So she initiated Kangaroo Mother Care in the KEM Hospital, and following that, she had developed this KEM Kangaroo Mother Care bag innovation, and it is where actually Dr. Suman did her DM and did a DM thesis on Kangaroo Mother Care, which is the RCT in KMC that you see in 2001. That research is actually very important because it shifted the evidence towards improving mortality in Kangaroo Mother Care. Systematic review in 2011. In 2003, she was deputed to Bogota for 3 weeks, where she worked and came back with a rich experience. And after coming back, she established the KMC Center of Excellence at KM Hospital, which is called as Shishugar, where they continue to follow up babies in Kangaroo Mother Care for ambulatory care. It's one of the first in kind in India, and it is currently being continued by who has also spoken at this conference. She was part of building the Kangaroo Mother Care India network in 2004 and has been an international consultant for the KMC Foundation and developed various materials for modules for Kangaroo Mother Care. And has more than 350 published papers and conducted a large number of workshops on KMC and breastfeeding. So the Kangaroo Mother Care Foundation felt that it was our privilege to begin an oration for this, and it is thanks to support of many of our students that we have been able to do this oration on a regular basis. So as we know, the mediocre teacher tells, a good teacher explains, a superior teacher demonstrates. And we have had the pleasure of many such teachers, and Professor Rega Odani is one of them, and who has been a very inspiring teacher. And we look forward to another teacher to give this Professor Rega Odani oration. Now I hand over to Dr. Ashish Mehta to introduce the oration speaker, Professor Kumuta.
Good afternoon, friends. I really feel privileged to introduce Professor J. Kumta. Who doesn't know her? Anyone who is in the field of neurology in this vast country would know her working at all levels, whether it's central NF, state NF, NRP training, FBSc training. She has worked everywhere and contributed in a big way. Currently, she is a professor and head of Department of Neurology at Swetha Medical College in Tamil Nadu. And she is also an expert advisor to NHM Tamil Nadu. But if you look at her contribution to neurology, it is vast. She was head and former profession head, Department of Neurology, Institute of Child Health, Madras Medical College. In fact, she established neural ICU and DM course there. She served as a professor of pediatric and postgraduate teacher for 28 years, long career. And during this tenure, she also established a DM course over there. Mind well, this is a course, this is an institute where you get large number of DM students each year across the country. She was DM teacher for 12 years. She has trained many DM students who are serving in the field of neurology across the country. She is NRP and FBNC and IYCF, Infant and Young Child Feeding Trainers. She received Active Pediatrician Award from Indian Academy of Pediatrics in 2001. She also received fellowship from Central NF in 2014. She was very much instrumental in establishing neonatal transport service in Tamil Nadu. In fact, this is the first state where incubators, transport neonatal incubators were available in emergency ambulance services across the state. And following this, she received an award from EMRI in 2012. She was also awarded Best Government Doctor Award in 2017. She established first human milk bank in the state of Tamil Nadu at the Institute of Child Health and first cooling therapy in the state. Obviously, the area of her interest, apart from intensive care, are neural transport, neural feeding, and human milk bank. And you can see her, she contributed in this area all through her career. May I request Professor Kumta to deliver this oration, please?
Thank you, Dr. Shashi.
Dr. Kumta, can you share your screen?
Yeah, yes, sir. Thank you, Dr. Ashish, for that introduction. And I'm really thanking Vani Madam on behalf of the KMC Foundation for giving me this opportunity to give the orations talk for the 5th National Conference on Kangaroo Mother Care. And I think this is one conference which has got such a specific interest on one topic, which is an important intervention which would influence the neonatal outcome. How to do it?
While they're sharing the screen, I would like to thank a few people there. While they're sharing the screen, I would like to thank a few people there with Dr. Kumata. We have Professor Arasa Srilar, former director and superintendent in Institute of Child Health, Chennai, Professor Emma Chandran, President NNF Tamil Nadu, and Professor Mangala Bharti, Professor and Head Neonatology, who will be doing the honors at the end of the oration. Thank you, ma'am. Please proceed.
Yeah. Can you see the screen, please?
Yes, ma'am. We can hear you.
Yeah. I thought today we would speak of how reaching every preterm and low birth weight infant with kangaroo care. And you can see the father giving kangaroo care at home. So this is the enthusiasm. If properly motivated, this kangaroo care can reach the baby at all levels, not only at the facility, but also at home, where we expect that to be continued. We know that as far as neonatal mortality as a country, we have still 23 per 1,000 live births. And our target, SDG target for the year 2030, as far as neonatal mortality is less than 12 globally. And India's target is even less, which is less than 10 neonatal deaths per live births. But if you look at the annual reduction rate of NMR, with the current reduction rate, we will be at 2030, be at 15.7 per 1,000 live births. But if we have to reach less than 10, then we have to accelerate our pedal and then do various interventions to improve our neonatal outcome. And definitely KMC is one of the important interventions if scaled up very fast and in a qualitative manner, and it will also produce reduction in neonatal mortality. If you look at the causes of neonatal death, we know that preterms contribute to 35% of the neonatal deaths. And of course, how are we going to save these preterms from this malady of not only mortality, but also morbidity? Let us see how we do it. So what do we do? All of us know that in every newborn action plan, care around birth and care of small and sick newborn contributes the most in reducing the neonatal mortality. Of course, care of this small or sick newborn starts from home, because still some home deliveries do occur, and some deliveries occur in the primary health center, some in the sub-district hospitals, some in district and medical colleges. So at all levels, these babies need to be taken care of and provided the essential service they require. So that is where we have to concentrate. And again, care of the small or sick newborn is very, very, very important. And again, our target set for our country. Again, coverage target is clearly specified. At least I should appreciate Government of India, Ministry of Health and Family Welfare has set in important goals for neonatal mortality. A lot of work has been done and there is so much commitment from the Government of India. And even last month there was a meeting on how to scale up the NSSK modified and NBSU. And in that, clearly the target coverage for NBSUs is LBW and preterm to be managed with KMC. At least the coverage should be about 90%. So that is the target. So we have set clearly the targets, but are we able to achieve these targets, or are we on the track of achieving these targets? We have to examine and how we have to do that. So as defined, all of us know, but since all the youngsters are here, I thought I will put in this definition so that we recapitulate what we have to do. It's early, prolonged, and continuous skin-to-skin contact between the mother and the infant. Whether it's a preterm baby or a low birth weight baby, both in the hospital and after discharge, until at least the 40th week of postnatal gestational age, and ideally with exclusive breastfeeding. In most of the circumstances, that is what we expect, and with a proper follow-up, not only during KMC period in the hospital, but at home also. So the impact of kangaroo mother care, all the other speakers would have spoken. To reiterate, it not only improves the survival by 40%, reduces infection by 44%, reduces hypothermia by 66%, and increases exclusive breastfeeding and bonding and brain development. So that is the theme of this conference, and that is what we have to achieve to have that as a goal. So definitely it's a well recognized as an excellent intervention for improving health and survival chances of premature and low birth weight infants. KMC coverage target, by 2020 it is 50%. We have to examine, but we have not reached that target. KMC coverage target 75% by 2025. So KMC should be started not only at the facility, but also at home also. So home KMC is equally important if you have to achieve the KMC as defined, at least up to 40 weeks of gestation. So if you see a mother who has delivered a preterm baby, she undergoes, or a low birth weight baby, she undergoes a cycle of severe stress. Even yesterday, we had a mother who's COVID positive delivering a set of twins at 27 weeks. See, she doesn't know whether to be bothered about her COVID status or whether to be bothered about her baby who were conceived by ICSI methodology of conception. So this is how she is there. So she undergoes a lot of trauma, stress, and sorrow. And it is that unless she gets the hope that we will save her babies and give those babies in a status, where they are developmentally okay. So we need to support them a lot, not only pre-pregnancy, during delivery, also immediate postnatal period also. And see that her baby also get cares. See, because her status itself is going to be, most of the mothers who are delivering preterm babies may have maternal morbidity and their own status is at a question. And so they undergo a lot of stress, and we need to have this support system, and this support area is the most important. I feel we have to concentrate if we have to take care of those sick babies and provide KMC and breastfeeding and go to the road of recovery. So this is the most important thing which we have to realize as a clinician, that the mother was. All the time we tend to say your baby needs KMC from day one, we will all support, but what is the status in which, emotional status in which that mother is there? So that is what we have to understand, and also the status of the family, so that we could support them and make them hopeful, and also make them come and give care as a family participatory care. So this is wherein I feel we have to spend a lot of time if we have to implement KMC at a very scalable effect. So for effective implementation of any program or any intervention we need, and this is definitely needed for KMC also. So we need these policy guidelines, training, monitoring and evaluation, funding, advocacy and research. And we will examine whether we have all this at government level or at Indian level, country level. But I'm going to talk our experience mostly what we did in Tamil Nadu to achieve all these goals to achieve scaling of KMs. So if you look at the NMR, as I told you earlier, it is 23 per 1,000 and Tamil Nadu is 10 per 1,000. You see across states, it is varying, and there are states which are having higher than even Indian state like India, Chhattisgarh, and there are states like Kerala which has got NMR to the tune of even IMR to the tune of 7 per 1,000. So we have across the country very heterogeneous status of neonatal care and mortality, and we have to iron out all this and then we give standard of care so that all the children in India get across the essential newborn care services, and more so for preterm and sick newborn infants. So if you look at Indian policy and guidelines, definitely Indian policy has taken notice of neonatal care, and KMC was included in the INAP, India Newborn Action Plan of 2014. And also in 2014, the guidelines was released on kangaroo mother care and optimal feeding of low birth weight by the Ministry of Health and Family Welfare, Child Health Division. And also priority was given for neonatal deaths in the National Health Policy. And also facility and community guidelines for KMC were included in all newborn training packages. Like if you take the first package which we started was IMNCI, then FIMNCI, then facility-based newborn care and NBSU. And early skin to skin contact is promoted in NSSK also. So there are also many new additions like National Collaborative Center, Regional Collaborative Centers, of which we were one of them in ICH, and state resource centers were formed for facility-based newborn care center, not only for capacity building, setting up of infrastructure in SNCUs, but also mentoring and monitoring and taking up operational research. So India has put the policy properly for neonatal health, and also KMC is included in that. And is it included to the fullest extent we want it? That we will examine, and guidelines have been released. Of course, it has been done in 2014. It needs to be again modified and re-released with the current concept and current evidences. Taking up what was happening in Tamil Nadu, the initial phase of implementation in 2002, it's all started in Institute of Obstetrics and Gynecology, where I have 2 friends or 3 friends who worked there, including in me there, Dr. Arasar and Dr. Mangalabharti and Dr. Rama. And 2-member team from IOG went there, Dr. Ashokan and Vijay Lakshmi, for a 4 weeks training to Bogota in Colombia. And they started working from 2002 November, December as Center of Excellence for KMC for scale up in Tamil Nadu. And the initial plan was train everyone in the hospital, not only in the hospital, train every hospital in Chennai. That was a logo when we jointly took up from IOG and NNF also as young member of NNF, Dr. Jayam, Dr. Gopal, along with one Dr. Saraswati, who was there in IOG, Dr. Ashokan, and everyone started this movement, train every hospital in the state and propagate the concept of KMC to the public, take it to the public by advocacy. That was the initial plan. I would say the initial plan to some extent, they disseminated, saw that the concept of KMC as a new intervention to small babies was taken, reached it. But how far the sustenance of that happened, that is what we have to see. And in 24 months in IOG itself, they had given this service to 1,200 odd mothers and baby had received, and they had a mean hours of KMC about 5 to 6 hours. We will see what all they went through in delivering this KMC. This is what we have to see. In November 2002, they did a lot of advocacy on KMC, both in Tamil and in English, when they started the KMC ward. And they started with all the rudimentary infrastructures which they had, or they did not have extra space also, but they started this with just a booklet on KMC prepared both in English, which was funded by UNICEF, and also a video presentation of both all the faculty there, like Ashok and Arasar, everybody contributed in each of this video. Though it was rudimentary, but it reached many of the mothers and many of the institutions. And KMC as a concept, as an intervention, got propagated and disseminated. When KMC providers, initially you can see all of them are sitting in the floor, sitting next to be as a group, supporting each other and giving. In fact, you can see one grandmother, even as early as 2002, they had used grandmothers as KMC providers because they got trained from Bogota. They had that confidence that not only mother, but the family also can give, and they started implementing it. And later it moved to a better chair, armchair, and then they designed a cot, which was a legacy of, in fact, a British people, which was left and bent. All these beds were changed for KMC. And that is how they started working. And we across an institute also learned a lot from them in implementation of KMC and gave this care to our babies in ICH also. So if you look at the scale up of Tamil Nadu in 2002, Madam Dr. Udani, Rekha Udani, she was the one first who came and did the state level workshops for us in IOG, and then also Dr. Shashi Madam came. So these are the two people who came and taught us how it is to be done. In fact, we thought initially KMC can be given only in the presence of Lycra. In fact, Rekha Muddani Madam used to go with her KMC bag everywhere and say even a small slip of cloth can be converted into a KMC bag, and then it can be taken. Again, Dr. Sashivani Madam, how she started doing it along with dyes, even at home, starting KMC for low birth weight babies. So that's how we got motivated, and then we started doing a lot of work on that. And many of the KMC workshops and CM we spent as breastfeeding and newborn celebrations, and NNF and IAP took that. In fact, those days, a lot of joint work was done by NNF and IAP. Even now it is being done, but earlier days we used to do a lot of work as a joint venture in all promoting KMC in many medical colleges. But monitoring was one issue, I would say. We did not concentrate because though we saw that the KMC was given, but we didn't look at whether it was started early, how long it was being done, was it being given continuously, like how we can overcome those problems. So that is, I think, that was the issue we had while we were implementing KMC. And there was no reporting or review not done at state level, because those days we only had RCH trainings and funding. And so we did not do reporting and review. Individual institutions used to do, but there was no state level reporting. The challenges faced in the initial phase of implementation of KMC was acceptance of this new intervention. number one. Now everyone has accepted this as an intervention, but again there is some hesitancy in the level of healthcare worker. They are worried because many of our babies are ventilated, madam. Many of our babies are on CPAP. Many of our babies on UAC, UVC or PICC. How can we give CPAP? So there are a lot of hesitations and perceived clinical problems that the baby would go for apnea or may go for sudden desaturations. Those are issues which they used to tell. And again, cesarean mothers were an important barrier in getting it started early. And then back pain. Mothers used to say, because if proper chair or reclining posture is not available, they used to go for a lot of pain. And in our Tamil Nadu, where we have a lot of heat, we had a lot of excessive sweating as one of our problem, because our earlier days, our nurseries were not air conditioned. So we had this problem. And also we had this local custom of not taking a bath. They would not take a bath for even 7 days, more so if they underwent cesarean section. And a shortage of staff nurses. Before SNCU came or FBNC came, we had a lot of shortage of nurses, and it was all state issue. Depending on how I would say Dr. Jayam, Dr. Gopal would get a lot of nurses, but other institutions may not get the nurse. So it's all dependent on how individually they could get the state to give them nurses. And data collection, monitoring and evaluation is totally lacking, as I told you earlier. And funding, no funding at all for any, even one single pie was not sanctioned anywhere, either in the state nor in the center. So, but most of the initiatives, as I told you, 2012 to 14, were mostly due to the increase in number of KMC champions identified both in public and private. Dr. Shanmugh Sundaram. There are so many people, I can keep telling their names. Those who got interested in doing it, mostly they were all self-driven individual units which started practicing during this period. And many of the workshops were done through NNF, reaching small district hospitals. And funding we got during this period, little bit between 2008 and all, from RCH training, IMNCA and UNICEF, and some NGOs like Lions Club, Rotary used to contribute, but that contribution was minimal. But we had some degree of funding from RCH, IMNCA. And in this, I would say, in scaling up, nurses played the key role. If we were able to convince the nurses of that unit, the importance or the significance or the advantages of KMC, how as an intervention, it is very, very useful for small and sick babies. Then we were able to get that unit started in implementing KMC very well. In fact, Dr. Arasar went to Dharmaburi and then started doing it very well. Before that, the KMC practice in that remote district, it was a district hospital and later turned to medical college, and then he was able to implement well. So it was all individuals who went and did many things. As a policy, did not take off very well because we did not put it as a policy. It was only taken as a new intervention, which is very useful for small and sick babies. So, but 2014 to 20, I would say it was all flurry of activity regarding KMC and facility-based newborn care across the country, and it also happened in Tamil Nadu. So once the guidelines, I know how Dr. Shashi Vani, for that release of guidelines, how she was behind the back of Ministry of Health at that time, and everyone. And it was a directive which came from NHM to all the states to organize SNCU, in SNCU KMC wards, and operational guidelines were given, which was disseminated to all SNCUs and NBSUs. And again, they had a separate briefing session and orientation to program managers of public health, because community KMC depended on them. and also academic bodies like IIP, NNF, and even IMA and Oxy got roped in, and they started promoting KMC in various platforms and forums. So that's how a lot of activity got initiated. Again, a training part, I will say the training part was taken up by IOG and ICH, and IMNCI cell was a very key place which was started by Dr. Sarda Suresh, the then director of ICH, and it is now taken up very well and everywhere now. Currently, Dr. Srinivasan is looking after it in such an efficient manner that it has played a key role in many of the child health strategies being implemented, more so neonatal strategy, and again KMC also. So KMC workshops were separately. See, initially KMC was being taught as part of IMNCI, FMNCI, FBNC, and all that. But later we realized the need for separate workshops for KMC and 2 days, and we had all these functionaries working in these SNCUs got trained in this, and currently we have 74 SNCUs, and we have 200 odd NBSUs where all the functionaries are trained by IMNCA and Regional Collaborative Center and between them IOG as a training state resource center. Not only Regional Collaborative Center has not only taken the capacity building of Tamil Nadu, but also Kerala, Andhra, which is undivided, Telangana, and Karnataka. So that is how, not only that, we had exposure, especially the nurses and doctors from the peripheral medical colleges to national and international conferences. Dr. Shashi knows, and Dr. Arasar personally took that team of doctors and nurses to those conferences where they really got motivated across how the national people and international people could implement KMC. So that was a very great boon for our nurses and doctors who had. Now Telangana has got a very good KMC at a district hospital. Same way Tamil Nadu has got in many of the district hospitals, not only district hospitals, NBSU, very good KMC wards. And then again, not only the people working in SNCUs, NBSU got a training. So we have 42 health unit districts in Tamil Nadu, and we had state level training of district maternal and child health officer. They are there, one for each health unit district, and we have what you call as at block level mentor nurses. So those block level mentor nurses also of these 42 health unit districts were totally trained in 2017. And not only that, they were also taught elements of monitoring of KMC there. And IOG and ICH took up the practical orientation. Again, Dr. Arasar as a IOG HOD was involved in that. So the training for community KMC again was taken up on a very large scale in 2017. And again, like we had provided infrastructure to all the KMC wards of SNC. So we ensured, or we said that insisted that 24/7 access to the mothers and the family for KMC should be given. The grandfather, grandmother, or aunt, uncle will be allowed into the SNCUs 24/7 to provide KMC. This was single intervention, I feel, which has improved our KMC implementation. Apart from giving infrastructure and trained nurse, again, trained nurses training was a lot of input, as I told you had happened, and a lot of educational material. Many of the SNCU doctors, our nodal officers, made their own material. I would have put all those materials, but for want of time, I have not put that any one of them. But they prepared their own educational material, rigging in funds from locally everywhere. It is not only NHM which gave the funds. We have a Chief Minister's comprehensive Chief Minister's Health Insurance Scheme. That also CMCHIS is also the source of fund. JSSK funds were used very judiciously, and they also get a lot of funds from MLA, MP funds and NGOs. So a lot of innovation and I would say motivation from all the nodal officers of these 74 SNCUs and NBSU contributed to whatever the neonatal status in our state today. So you saw what I showed IOG initially when they started. Now you see, look at the KMC wards at our medical colleges, a big space. Now we have a lot of growing preterms who are survivors less than 1,500, and they are happily giving KMC, where the mother has got the provision of a bed for herself and a reclining chair. But we are also looking at the adding Fowler's cot in all our KMC wards. That will be the next stage of implementation. And even in sick newborn units, not only in stable units, sick newborn units, mothers coming and giving KMC during period of early period where early KMC is being given, and so babies on CPAP, and that would be there. Then establishment of KMC wards in 42 NBSU centers. Not only in 74 SNCUs we have another 42 and 2 in MCH Corporation Center in Chennai at an expenditure of 1.5 lakhs per center. And we have provided 3 dedicated staff nurses and equipment required for KMC provision in 2016. So that is another addition of KMC wards in our sub-district and maternal and child health centers. And another important event I feel which has been done in Tamil Nadu is having this early child development and mothering helpline. See, KMC and neurodevelopment is the current thought and current theme of this conference. And so we have started 1 or 2 call center for early child development. Here, the main objective of this scheme or program is educating beneficiaries about good practices in mother and child care. So the mothers will be starting consultation with these call centers right from conception up to 2000 days. So that is the concept. We have 1000 days, sorry, first 1000 days is a concept, and they will be picked up from Pick Me line. It is not a helpline which says that a call will come, they will attend. No, they will take the mother's addresses and then they will start calling them and providing this information and education about that. And also they will validate the MCT portal also, and they will also do the follow-up of SNCU graduates based on the HBYC guidelines. So this is one initiative where this is a call center which will work proactively and not just merely attending calls that are being received. So they will make the calls. So they are called as health advisory officers. We have 10 in number. They are basically registered nurses diploma or basic. Why we have kept this health advisory officers designation is, if you put it as nurses, we would have a problem of having this consolidated pay converted into permanent. So that is our technical issue which we have taken. So they are called as health advisory officers. They work in 3 shifts, and it would be an extended services to the community health services. So they will be conception to first 2 years, that is 1000 days. And we have started only just 3 months, and we have also created monthly reporting system. And then this might improve the MCH services in the field. And we have given these call center people 50 to 75 calls per day, and each person covers about 4 to 5 health unit district. And also what they have to talk, what messages they have to give, depending on first trimester, second trimester, third trimester, intrapartum preparedness for birth, and then normal babies and small and sick babies and babies discharged from SNCUs. These are the 3 categories in which they will be working. What they will be talking about for low birth weight and preterm babies will be first important thing they will be ensuring is kangaroo mother care, then exclusive breast milk feeding, either direct or expressed, and then early identification of danger signs and so that they come to the ward. They also produce a link for consultation. So if any mother says that she has some problem, immediately they will arrange which hospital they have to go. And they being in 1 or 2 call center, which is also part of the EMRI, that is emergency medical transport. So they will be easily linking this person with a 108 neonatal transport. So that is a basic advantage of having this ECD or early development, child development call center. I hope this would work really wonders, because we are hand-holding them from NHM every month and finding out. In fact, they are just next door to NHM office, so we keep popping in every day and finding out what they are handling every day. Then there's another community link project which I want to say is one of our DM graduates from Institute of Child who is currently working in Trichy Medical College SNCU, Dr. Sendil Kumar. He has done a wonderful project called Chella Pillai from January 21, which is linking ICDS with the SNCUs. Of course, there is a link already, but he has directly linked them and brought them to the hospital to do some work along with ACOM. So the key elements would be of this project would be motivation and training of ICDS functionaries involved in pre-discharge counseling. You can see some of the Anganwadi workers coming to the SNCU to see how these babies are being taken care of, how precious they are, and how there is a need for community care and especially KMC. So involved in pre-discharge counseling, and they have discharge list shared by the SNCU, and they will do the home visit HBNC and HBYC, because home-based M-child care is currently being implemented in our state because we have only 8,000 ASHAs. So one district only has in the implementing district ASHAs. So other places we are depending on the Anganwadi worker, and she gets an incentive for HBYC when she does the home visit, and they report to SNCU, and it is periodically reviewed. See, you can see the training under those ICDS functionaries. It is not only the Anganwadi worker who undergoes training. It is the CDPO, the supervisory cadre, district project officer, and there is another person called as a district program manager, DPM. All of them undergo training, and they come and do in the postnatal ward pre-discharge counseling. You can see them approaching not only the mothers and also the other family members. So because they have our community workers, they do really connect with them very promptly, much better than even our staff nurses. Because locally, some of them might know even those mothers or the family, and so they're connect with these mothers in the postnatal ward and the family is so great, and they keep coming and telling them that they are there in each Anganwadi. They tell, depending on the location where they have to go, seek services, and not only that, they give all this take-home ration, how it can be prepared. They come and give all this kolkata and those small little food which is made, they come and distribute and tell them how to make it, because the take-home ration of supplementary feeding is given to lactating mothers also. So that concept of getting the community services is oriented to these postnatal mothers in the postnatal ward in the hospital, not in the community, but in the hospital. And so also they work through this Chella Pillai WhatsApp group. First, once the SNCU sends the discharge list, they verify through phone calls where their location is, and the first house visit is done by the CDPO, not by the Anganwadi worker. She is the program manager, topmost official for ICDS. She does the first house visit, and periodic visits are later scheduled and done by the supervisor, BPM and Anganwadi worker. And also they link to the referral services of health. And also they are very happy to do it because they have mandate of following all these babies for up to 2 years, and they have to collect through for Poshan Abhiyan breastfeeding indicators like when it was started, early initiation, exclusive breastfeeding, complementary feeding. They have to put it online in the Poshan Abhiyan website. So having this link with the SNCU, it is easier for them to work, and their work also gets easier, and they are happy to do it. And these are the mandated visits which they will be undertaking. You can see those mothers doing the house visits, and then in this form they fill it up and send it through the mobile app to the SNCU data entry operator. So the postnatal counseling in these 3 months, they have nearly covered 1,200 mothers, both postnatal wards and SNCU mothers. And in fact, 6 deaths were reported. See, even without the VHN, it is going to the AN. Deaths have been reported. They have picked up. Many a time, many of the home deaths were not being picked up. Our infant death was under-reporting, but with this program, they had tracked nearly 93% of the SNCU graduates, and they all advise for the sick and preterm low birth weight babies. So I feel this is an excellent project, and we are looking forward whether it is scalable to other districts also. Currently, it is being done in Trichy, and Dr. Sendil, who is the nodal officer for Trichy Medical College, SNCU, he's taken initiative along with ICDS, and they are currently implementing it. Some of the observations made during that time is 80% of them are following whatever counseling is being done, but they say support system gets withdrawn once they go home. So mothers are happy for these Anganwadi workers to come and connecting it. They were connecting earlier, but they say with this connectivity of mobile app, and the mothers feel nice because they've been contacted even before discharge. And increase of household work as in fact is one of the important reasons for KMC being on the taken a back seat at home. So how long should KMC to be continued? So they do the reinforcement, tell the family members how they can relieve the mother for KMC, or they can themselves provide KMC. And breastfeeding problems have been picked up, and weight gain, how much is satisfactory. All those interactions from the mothers are coming up, and so that will go a long way in getting the project done. And again, if you look at the SSU online data, what is the coverage of KMC in Tamil Nadu? Like we have nearly a lakh and odd admission every year, and we have nearly 10,000 less than 34 weeks, and nearly 20,000 low birth weight, not low birth weight, babies less than 2,000 grams. But we have fair implementation of that. See, except for year 2016, from 2017 onwards, our provision of KMC, at least getting recorded in SNCU online data, is good. But I don't know about how early it was started, what was the mean hours given per day, like whether it is being continued at home. So those data we lack. See, that is what I feel in SNCU online. It is only KMC is just captured as whether it is provided, yes or no. But I think SNCU online, which we have been pushing in with the Ministry of Health also, that these data, like when it was started, mean time at which it is started, or mean hours, and also how it is being continued at home. So those 3 data we have to pick up. And monitoring and evaluation as far as KMC is being done. In fact, KMC charts have been done where monitoring with mother, baby diet in each center. RSR also contributed in that. And monthly data generated from SNCU online, we look at KMC. And currently, regional weekly reviews of SNCUs and NBSUs are being conducted by the RCC, Dr. Vijay Kumar and Srinivasan, and the NHM is also part of it. doing it, and this is a very good workshop review where we have 33 practice indicators which we have to review, and definitely KMC is part of it. And in quarterly reviews also we take not only coverage, we look at the quality of KMC coverage, and not only in SNCU, NBSUs where it is implementing, it is being done, it is also done in the review of, that is, district officials like health officers, deputy directors, joint directors, and deans review also KMC is being done. So they know that such a thing has to be practiced in the institution, and if it is not being practiced properly, either in their district or institution, that should be taken care of. And yearly state report is done for planning for PIP also. But qualitative data of KMC is not collected at the state level because we don't have not put it in the part of SNCU online thing as of now. Like we in Savita Medical College also is doing a IIT funded project, not only in Savita, IOG, ICH, Chengalpattu Medical College and JIPMA, for tracking of low birth weight babies through affordable technology. We have started it, and I'll tell you about a case report where we have done it, but results are not yet. We are just in the process of starting. And the important concepts which are practiced in KMC's early initiation with the family member. Even if the mother is unable to come for various reasons, then we introduce a family member, babies on CPAP, PICC lines done. We target at least 12 hours in a day, and then intense feeding support. See, what we have realized is if we want to get them to direct feeding, they need intense support. And then the daily review of KMC chart. Like what is happening to the KMC, all the parameters and the hours of KMC, along with weight gain. That is also one thing which is really helped us in implementing. And we are doing through this IIT also follow-up of home KMC, how long home KMC is being given. Like our results as of now is mean time of initiation is 5 days, and mean hours of KMC is 11.5 hours. Average weight gain is nearly 27 grams per day, and exclusive breastfeeding rates 98%, and continuation of KMC till 40 weeks gestation age is 70%. Like this baby is actually a baby term baby, in fact, but a low birth weight of 1.6 kg, who had a peri-Robin sequence, very difficult airway, difficult to intubate also. And this baby went in for bilateral pneumothorax. We had to handle that with ICD, and child had to undergo lip addition surgery for welling secretions and airway blockages. And child stayed with us for 61 days. Out of that, 51 days we were able to give KMC at least 10 hours a day. And you should know the mother was the most motivated person, and she taught me how, even in such a difficult peri-Robin sequence, how we can go for exclusive breastfeeding. We did not use any device. And this mother, I tried mother supine, prone and all for feeding, but that did not work. In fact, she sidelined and then taught me how breastfeeding could be done, direct breastfeeding. But because the weight gain was not good, we sent this baby on tube feeds, and she is still continuing home KMC 20 days, and currently that baby is 3.5 kg in 20 days, showing a weight gain of 690 grams. So this is one lesson I think all mothers, teachers, babies, teachers, that we think, okay, peri-Robin sequence, I have to go for all devices, I have to have this, that, but they are the ones in nature which teaches that they can do a lot. You will see how the mother is happy mother when she came for follow-up. The tube, and you can see the pulse oximeter. We have given that mobile pulse oximeter multi-site probe where she monitors at home also. And she has a capacity to put tube, and she is only giving express breast milk through the tube and directly also feeding this baby. In fact, I am planning to remove the tube and leave the baby on direct feeding completely. See, this is how she is monitored, how wrote and brought, how long she gave KMC every day. Okay, so this is how each mother teaches how it is very, very important. Then next important thing is MNCU. This is another strategy of Government of India which we are implementing at IOG at a cost of 30 lakhs. This year we have been sanctioned this. This is having 20 to 30 beds of mother's cot where the mother will be treated in that MNCU unit, bed, diet, treatment, and obstetric rounds would be done. And babies without IV or oxygen who require admission in the hospital for phototherapy, antibiotic continuation, or feeding support will be admitted in this. And I feel this is, in fact, Government of India has given a guideline that new units, which SNCUs which are being designed also should have a component of MNCU as a component. Or existing SNCUs can merge the step down and the KMC ward into an MNCU unit. And we will know implementing in IOG how it is practical and useful. And again, we are talking about KMC champions. I feel these are our true champions. See, this is my 28 weeker, 640 grams. How she's boasting with all her medals in school. Very nice to see. And again, a happy family, 900 grammer. And this is the third photograph which you see with a team of nurses. This mother abandoned this child, wrote and gave it to us. And many of our nurses gave faster KMC. In fact, I have a doctor who used to give KMC for all the babies there when she was on duty. And this baby was on KMC, and this is when we handed over this baby with very heavy heart to the orphanage. And again, now COVID times, this Lancet article has told us that continuing KMC uninterrupted is one of the most important things which we have to do. And as of now, India would be the one which would get benefited. The highest benefit you can see in this graph that India would be benefited. So what is our thinking that we should not interrupt, and what are we doing? We are giving uninterrupted KMC with precautions, and family members are providing if mother is too sick to come to the unit. Stable mothers stay with the baby in the COVID wards, and breastfeeding is 100% promoted as before. And this is, I think I have come to the last slide. KMC and BFHI integration needs to be done with a new BFHI, which we have forgotten. And KMC has to be integrated as one because breastfeeding is an important component of BFHI. KMC, I think Madam Shashi should take important role in pushing GOI in integrating KMC services along with BFHI. So the need of our hour is, I think our government is very motivated and they've given us what we want. I think even health workers are motivated, but what we have to do without apprehension is early KMC, continuous and prolonged KMC. That is what is important. And then we have to add quality of KMC, monitoring and providing quality KMC through our national NQAS or state NQAS. That important quality component should be added in our KMC practice. I think that will go a long way in improving our neonatal survival. So I think if we were to say, Gandhiji has told us that we should be the change. And I think each one of us should be that change so that we would be converting one mother or one caregiver or one family member every day towards quality practice of KMC. I think that's my last slide. Thank you very much. I think I had crossed my time limit, but I always, when we talk about KMC or breastfeeding, we become very emotional. And I thank KMC Foundation, Dr. Shashi Madam, Dr. Suman for organizing such a wonderful conference in very difficult times, and all the KMC champions like Dr. Rekha Udani Madam, Ruchi, where it all started everywhere. and my friends in the country and Tamil Nadu. And in this COVID situation also, three of my friends are here to handhold and support me. I'm really thankful to that. And all the mothers and their newborns of this country and whom I've crossed. Thank you very much. Thank you. Thank you.
Thank you, Professor Kumutha, for the elegant oration, and I would like to thank you for accepting it from our describing the journey of KMC over the last 2 decades. With that, I request Professor Arasar, Professor Rema, and Professor Mangalavarti to please honor the Professor Kumta with a shawl and a plaque from the KMC. Thank you very much for I would like everyone to give a standing ovation to Dr. Kumutha, and we are very pleased to have you accept the invitation. And can we just click a photograph? Dr. Suman, can we have a photograph taken of this? So just a minute.
It can happen over there in person also. If someone
Yeah, thank you. Thank you very much. And regards from KMC Foundation. I couldn't click the photograph. If somebody else can click it.
Please take a photograph.
I couldn't take the photograph.
Yeah, taken.
I could taken. Yeah, thank you. Thank you, ma'am. And thank you very much. And we look forward to having you again in
Thank you. Thank you, madam. Thank you for the wonderful oration and the inspiring way you have led Tamil Nadu to single-digit NMR. Yes, this oration is also virtual, but KMC Foundation has promised us that there will be an honoring in person on KMC Awareness Day. And I do hope that all of us can at least see that virtually when it's being done. And I must thank Rama Madam, Dr. Mangalabarti and Arasar Sir for going there personally and doing the honors. So through you, we are there with you all. And now we actually come to the very, very important keynote address by none other than Professor Joy Lawn. And for this, we have eminent chairpersons, Professor Ashok Devrari and Dr. Rajesh Mehta. I just spoke to Joy and she said that it is unfair to do it on an empty stomach. So we are just going to break for just, I think, for around maybe 10 minutes for you all to grab your lunch and either eat it or come back to the computer. And we start exactly at 2:15. I hope, Professor Devrari, is that okay with you and Dr. Rajesh Mehta?
See, I have no problem. Joy has to give permission. Joy Lawn has to give permission. It's early morning for her.
My friends, just like you have to feed your babies at the right time, I think you have worked hard. So please, that's fine. 15 minutes is fine.
Thank you. Thank you, Joy.
I look forward to it.
Thank you, Joy, for this. We will just come back and we'll restart at 2:15 exactly. Thank you. Good afternoon and welcome back. I'm sure people have had either a quick bite or got their lunch to the table. And now we are very, very eager to listen to Professor Joy Lon. I hand it over to Dr. Bharti to introduce our very eminent chairpersons, who will then invite Professor Joy Lon.
So the next session is the keynote address. So I would begin to say that change is the only constant in life. So we have had 4 decades of KMC. Where to next? So to chair this session, I invite Professor Diorari, a dynamic teacher and professor and head of Department of Pediatrics at AIIMS. He never ceases to innovate, reinvent, and always continues to inspire all of us. I also invite Dr. Rajesh Mehta, Regional Advisor of the WHO and the Fellow of IAP. It is an honor to have such eminent chairpersons among us to chair this session. I hand over the podium to the chairpersons.
Ashok, you are muted. Ashok.
Okay.
Yeah.
Thank you, Suman and the organizing team, KMC Foundation of India, National Neonatal Forum of India, for organizing such a wonderful conference on kangaroo mother care. And I'm so delighted that with me, Dr. Rajesh Mehta, who is the advisor for newborn, child and adolescent health at WHO CRO, is chairing this session. And I am all the more pleased that the speaker for the keynote address is Joy Lon. Joy Lon, her name is Joy Elizabeth John. She is a missionary born in Ghana, and her mother was a teacher teaching there. And she moved to Nottingham for doing her graduation, and then returned again back to Ghana to work in a teaching hospital. And what made her heart change and to work for was what she saw in the teaching hospital. Newborn babies dying due to infection and due to lack of nursing staff, which was changing. And the data was not getting collected and accounted for. And that moved her to move to CDC Atlanta for working on metrics. She worked with leaders who worked at Atlanta CDC, and then completed her PhD from University College of London in 2009. And I can tell you, whatever you people are doing for improving newborn health, maternal health, and decreasing stillbirth, each one of those have an imprint which is coming from Joy Lon's work, which she has worked in depth. I still remember the Lancet Newborn Survival Series of 2005, and then a follow-up series of 2014, which told us what are the interventions which will decrease the maternal deaths, newborn deaths, by focusing on delivery room care. And in 2005, the policy document which she was associated with led to the opening of the SNCUs. We are talking of SNCUs in the country, which are more than 800. And Joy, your work of 2005 with your team of Lancet series opened the mind of all policymakers that investment for newborn health has to be on top priority. You did not stop at that point of time. I have followed you for the last 8 years, and I met you for the first time in 2014 in Vancouver SPR meeting where you invited me. And then your Lancet series on maternal health. And now your late passion for small and sick newborn babies survive, thrive, and transform. We worked together in 2018 with UNICEF and WHO. So most of the work, WHO documents are coming. You have imprint on it. And we are so privileged that we are going to listen to you on this keynote address. With these words, I'm not reading what your CV is. People can go to Wikipedia and Google search it, and they will be amazed to meet you and get inspired from your talk. Over to you, Joyla.
Yeah, so while Joy pulls together her slides, one observation from me, you know, we have seen her doing both measurement. We thought she was the queen of measurement, but going by the saying, which is famous, by measuring again and again, you cannot fatten the cat. So you have to feed the cat. So now we also see more and more guidance coming from the measurement, taking data for action. So we see her both contributions. So it's marvelous to have her here today for a noble cause. So over to you, Joy.
Well, thank you so much, friends. Honestly, Ashok and Rajesh both has heroes for newborn care across the whole of India and also for the whole of CRO. It's just such a privilege to be here with you and with just so many others I have admired. Over the last year, I have been really delighted to work with Suman, such a woman of action. And there are so many giants in India. Dr. Vinod Paul has been a friend and a hero for me since the first Lancet neonatal series. But what I know too, and it's such an honor to be speaking to this audience, is that you are full of people who not just admire the problem, but you do. You are people who act. So in the time I have with you now, I want to think about how to act. We always learn how to go faster if we look back and learn from our history. So we are 4 decades into kangaroo mother care. I want to come with that 4 decades summarized quickly, most of which actually has been much bigger in the last 1 decade. And then say, what are the 4 big challenges now and 4 big shifts? 4 decades, 4 big challenges, 4 shifts. But I want to start first by acknowledging why we're on Zoom. Of course, I would love to be with you face to face. I was in Delhi for the PMNCH Congress in December 2018. And the reason I love to come to those congresses, not just to hear your Prime Minister speak and to hear people talk, but I went to some facilities and some SNCUs and I just learned so much. So the reason we are on Zoom is because of this pandemic. It has affected each of us. It affects how we live. Many of us have lost friends or relatives, but it has also transformed our world. Our world now values global health in a way it never has before. We have seen just a total disruption in how we measure deaths and data. So this chart shows yesterday's update on our world in data, how many cases, and very sadly, we crossed the milestone yesterday of more than 3 million known deaths. But even in that transformation, where we're getting data coming all the time, we're getting a speed of change, we've got testing kits that are out there, we have selective equity affected gaps. So if we look at the data here, for sure, this is not the truth in Africa. And I know that you also in India and all of us are seeing every day the realities of this. So that is a problem, but it has also been a transformation for data and science. Not just the epi data, as Dr. Rajesh has said, but also the action. So if you feel like you're living in a tsunami of publications, we are. So in just about 1 year, about 115,000 publications in PubMed and many more beyond PubMed. A transformation in how those data are seen. So it used to be maybe 4% were open access. This has driven open access. Why? It's because politicians and the general public actually want to read these data. There's a demand. There's also been this huge transformation in generation of testing and remarkably of vaccines. And yet within that, there's still a huge inequality in vaccines. Dr. Tedros has said that this is the issue of our time. And as we look at that and we meet today, how much of that has looked at newborns? So there are about 1,700 papers in this time period that mention newborn or neonatal. And quite remarkably, actually, I found almost 500 that actually specifically mention kangaroo care. So kangaroo care is disproportionately represented within the newborn part, but the newborn part is really just, as usual, unfortunately, a very, very tiny slice, despite the big burden. So here we are today. We wouldn't choose to be in this pandemic, but every threat, every challenge also has an opportunity. How do we learn? How do we go faster? How do we seize opportunities to change things for newborns and also for maternal, newborn and child health around the world? Well, in contrast, we have each year still 300,000 women dying, mainly still reliant on estimates. We have 5.1 million children dying after their first month of life. And as you well know, shockingly, we still have 2.5 million dying in their first month and around 2 million who are stillborn in the last 3 months of pregnancy. So this is 10 million deaths every year with limited data and not enough innovation and maybe not enough ambition. And this may be getting worse, not better, under COVID. And the time is particularly related to the time of birth. And India has a giant in the world, has an unenviable #1 of newborn deaths, but a very enviable #1 for the level of ambition to address those. And I salute you for that. I learn all the time from you. So that's the picture of where we are, the pandemic, and where we are for women's and children's health, the contrast. And if we zoom in a little bit more on child deaths, this is the latest cause of death pie chart from the UN estimates. And if we look at 1 year of deaths, now globally, if you count the neonatal causes of death that happen after the neonatal period, pretty much half of global deaths are in the neonatal period. And within India and many South Asian settings, it is more than half. And yet investment still lives in a pie chart from the past, still a lot focused on infections. And it's not that we should stop working on child's infections. Pneumonia is a shocking tragedy that really should not be killing children today. Chronic diseases are coming up. But if we look at the global burden of disease for 2019, the top condition, not just in child's time period and not just in low-income countries, but the top condition for the whole world is neonatal conditions. 7.3% of all DALYs. And it was also the top condition in 2019. So in the whole time period, we've been doing the global, in 1990. So in the whole time period that the global burden of disease has been running, neonatal conditions have remained the top condition, more than cancer DALYs, more than others. And yet, we still have not seen the amount of investment either in program change or in research. Critical that we recognize that this issue that we're talking about today, kangaroo mother care, is addressing not just newborn deaths, not just child deaths, but actually a very big global burden condition. And then when we think of these vulnerable babies that we're applying kangaroo mother care to, yes, we use a simplistic cutoff of weight, partly because we struggle with not good enough gestational age data. But often the babies that are smallest are both born too soon and born too small. And we need to move forward to be able to combine those together. And if we look at preterm birth, the highest rates are generally in Africa. And if we look at small for gestational age, the highest rates are generally in South Asia. Both of these result in an increased risk of death. And in fact, 80% of the world's 2.5 newborn deaths are small babies. 2/3 of those are preterm because that particularly drives the deaths, and about 1/3 are term small for gestational age. So as we think of our clinical care for preterm birth, we also need to think of this bigger picture where we've really failed on prevention. Yes, we must do better on care, but we need to drive that prevention, primary prevention agenda. And to do that, we need to measure better. Not just measuring birth weight and gestational age, but also small for gestational age and looking at more specific phenotypes. And there's some very exciting work on that linked to the Lancet Vulnerable Newborn series. So as we think about the ways to reduce this burden around the world, and particularly in India, this is about addressing both deaths, and as your theme for this 5th Congress shows, it's also about optimizing child development potential. How do we do this? We need to reduce rates of preterm birth and also of term small for gestational age. And then we need to reduce deaths among babies who are born preterm or too small. So those are the two pathways. The prevention pathway is critical. And we do have WHO recommended packages and interventions that we should be implementing. And I know that India has really managed to do this with a huge shift at scale. The unfortunate thing is, at the moment, we don't have a lot in our menu that dramatically changes rates of preterm birth or low birth weight. It's not just about feeding pregnant women. So we need much more work, especially on the research side, of how we put this together and understand the mechanisms. But the good news is that on the care side, we have an amazingly effective set of interventions with kangaroo mother care at the heart of that. And then not forgetting that optimizing management during labor and in the delivery room, so the obstetric side with antenatal corticosteroids and so on, but also that immediate newborn care is really critical for managing that start, because as we know, these babies die within minutes. So the biggest gap that we have where we can address quickly is this gap in survival amongst babies who are born too small or too soon. And at the moment, if you are less than 28 weeks, more than 90% of these babies will survive in high-income countries. In fact, probably more than 95%, even down to kind of the 24, 25-week threshold. But if you're born in a low and middle-income country, less than 10%. And in the lowest income settings, less than 5%. So a huge equity gap, despite the potential for impact. So having set the scene with that, the imperative and the opportunity for saving 3/4 of a million lives every year for newborns, I want to say, here we are particularly focused on KMC. Where have we come from in 4 decades of this? Where are we now and where to next? So where have we come from in 4 decades? Well, in the audience, we have people who are amazing aficionados on this history. I'm not going to take you through the history in detail. This is one slide of really trying to give us that trajectory of where we've come from and where we go to. And if you look at these 4 decades, what I've done actually is the first 3 decades are in half of the slide, because those first 3 decades really were about getting going. Skin to skin first being looked at, first being tested in Colombia, kangaroo mother care being defined, the first WHO guide led by Adriana Cattaneo and others, and the first Cochrane reviews. Importantly, those Cochrane reviews did not show any mortality benefit. Then, if we look at what changed, having mortality benefit was really fundamental to a flip and an imperative, particularly for low and middle income countries. So this meta-analysis that I was involved with, and then the shift in the Cochrane really changed that. And that led to, so the evidence is summarized below the line and the policy uptake. The Born Too Soon report, which got media coverage all over the world and huge trajectory, including in India, front page of New York Times in the US, and major uptake because of parent power. And that is a really critical message. Parents have a voice, and often in our settings, they don't have enough voice, especially the women who are most affected. But if we can amplify that voice, it changes our political trajectory. The Every Newborn Action Plan with WHO resolution really was transformative. And I salute India for your very ambitious India Newborn Action Plan with the 1-digit target, and Tamil Nadu for having already met that. WHO guidelines, and then a more focus in on this issue of small and sick newborns, again with fantastic leadership from WHO and innovation in India. So Dr. Shamala and her team with the community KMC trial and other ways that we can innovate. So in the first 3 decades, there was less progress. We were building evidence, building the case, and then the imperative for lives saved changes things. So if we look at the rate of global scale up, so this is a slide from Gary Darmstadt's paper in the 2014 Lancet Neonatal series, looking at a typical drug launch, taking maybe 5 years to get to high scale, and then looking at the trajectory for other interventions over time. And unfortunately, we don't have good coverage data on KMC, so this was illustrative coverage data for both antenatal steroids and KMC. And both of these interventions, despite having significant mortality evidence, had failed to get trajectory. And we ask ourselves why. In fact, if we were to repeat this graph now, the COVID vaccine would be here probably at 2 years, I hope, with COVAX and with the important leadership from India in manufacturing and so on. You know, things are going even faster for some conditions. So why do some things scale up fast and some do not? Well, it's about political priority. My friends, we love our evidence, we love our clinical practice, but in fact, what drives more rapid scale up is political priority and also industry gain. So for us with kangaroo mother care, we don't have an industry gain. We're starting maybe to get some political priority, and I would say India has done that probably better than any other country that I'm aware of. But how do we do better? We need to think about the narrative, not just the evidence, but is it doable? And how does that link to action? We need to think about the voices, and that includes really elevating the voices of women. And we need to think about the context. How do we link onto opportunities? So for example, commitments to the SDGs and to newborn targets, and how do we deal with challenges? So the very real fact of a pandemic. So moving forward into that narrative for kangaroo mother care, a pivot point was showing major mortality change, because that is the critical driver for us in high mortality settings. These deaths are unacceptable. We need to not just measure them, but do something about it. And so this very marked mortality gain from kangaroo mother care, particularly if started early, was a pivot point. And very importantly, studies that are ongoing, so the exciting WHO's IKMC study with, and I know that Suman has really played a lead role in that, will be coming out soon, and other ongoing similar trials in 2 sites in East and West Africa. And then if we look at some of the pathways whereby this has an effect, so the nosocomial infections, breastfeeding, absolutely fundamental, and hypothermia. What this shows us is we only get the mortality benefit if we also have the quality of implementation, enough duration, the real care on infection prevention, and proper support for breastfeeding. Otherwise, that mortality gain will not be realized. So if we look at the narrative, a shift on mortality evidence was critical, but also on child development outcomes. So in lower mortality settings, their big concern is about brain injury and long-term child development. And then also, very importantly, about how the mother feels, respectful care, bonding, and the family. So unfortunately, in the Cochrane, still no significant evidence as of 2016. I hope that when they repeat, some of the other trials that have been done will come in. But I think this very influential study by the amazing Natalie Charpak, looking at 20-year follow-up after KMC in Colombia and also brain scans, has been important. And I throw out a challenge to any of you who can do both the follow-up studies, but also bring in brain scans so that we can pivot this evidence. This is evidence we need, not just for the sake of publishing papers, but to make the case. And also the maternal side. So for kangaroo mother care, sometimes so importantly, we pay attention to the baby, but we must never treat the woman just as part of an intervention. She's a person in her own right. We need to do better on measuring her well-being, both at the time and longer term. This is fundamental and will have more influence all around the world, but particularly in moderate or lower mortality settings, which of course Tamil Nadu is now moving towards. So changing this narrative over time, how do we do this? And how do we look at what we have learned? Well, some of it, as well as the evidence, is the image. What pictures are shown? So if you think back to the beginning of kangaroo mother care, it was an alternative to incubators, sometimes portrayed as a poor person's solution. When we came to around 2010, really focused on poorer settings, sometimes portrayed as something that you do if you haven't got technology. And that was a myth and an error that maybe actually impeded some of the uptake. And I think India has done a remarkable job on pivoting that to include kangaroo mother care, so that it's not this false dichotomy of something for poor people, but is for everybody. This should be a standard of care, a right for every newborn everywhere. And really importantly, using images. So I quite often now use images from high-income countries so that people realize that this is not just for poor people. And I know you had a fantastic talk yesterday from Bjorn Westrop about neonatal couplet care. I think we need to be careful about changing terms too much, learning from the maternal health community. If you change your term every 5 years, people get confused. But whether we change the term, we definitely need to change how we do this. So this is an intervention for every baby, everywhere, in all settings, should be integrated into preterm care, change how we do neonatal care, family-centered care, and really importantly, think about how we do this at home as well. So the current guidelines from WHO, and Rajesh will maybe be able to guide us on the change of the guidelines that is upcoming. But the current guidelines are that stable newborns who are less than or equal to 2,000 grams would get KMC, and that the intervention includes prolonged skin-to-skin breastfeeding, results in reduced infections, and results in earlier discharge. So follow-up is critical. That we're looking for continuous and early KMC. Intermittent is less well defined. And then we'll have this important shift with KMC prior to stability, what we do at home, and possibly going for bigger babies. So that is briefly where we are over the last 4 decades. I now want to say, where are we now? So where are we now? We have about 140 million births each year, and India carries 25 million of those births. Worldwide, as we saw in the Survive, Thrive, Transform report, about 30 million babies need some type of small and sick newborn care. And in many cases, that includes a need for kangaroo mother care. But we're not in an equitable world. Just like with the COVID vaccines, newborn care is very inequitable. If you're born into a high-income country, you will be very likely to have full neonatal intensive care. Of course, there are still some high-income countries where that may bankrupt you. I don't know if you realize that in the US, having a preterm baby is one of the most common causes of bankruptcy for families. So this also is a shocking problem in high-income countries. And then if we look at the rest of the world, India has graduated into being a middle-income country. And in many middle-income countries, actually, we struggle with over-medicalization, an epidemic of C-sections, which really affects all of our newborn care, particularly preterm care, and makes immediate skin-to-skin breastfeeding and really crucial aspects of newborn care much more complicated. And then in low and middle income countries, we still have this unseen world of 44 million births at home. We have a huge shift into facilities, but with a big gap in quality of care. Newborn units so jammed that it's hard even to fit the newborns in, let alone mothers to do care. And in many ways, India has all of these 4 levels of care in your one continent. So how do we join this up? At the moment, this is driven often by inequalities. And wherever you work, you need to know what is the context I'm in and how can I change things now, but also how do I move forward? And then I really want to underline that moving forward is not just going from home into a busy facility, into over-medicalization, into an awful lot of machines that may also leave out the family. But there are ways to learn both ways. And I think kangaroo mother care is a fantastic example of that it should be two-way learning, an innovation that has come from the Southern Hemisphere that is now transforming family-centered care around the world. So I want to move forward from the world on one slide, or India also on one slide, to say, what are the challenges now? So this slide summarizes a very large exercise undertaken with WHO and UNICEF around the time of developing the Every Newborn Action Plan, looking at health system bottlenecks in the highest burden countries. So these 12 countries, which included India, 60% of the world's newborn deaths. A very large exercise saying, what are the bottlenecks? And that was to inform the Every Newborn Action Plan. We didn't just want it to come from the EPI, we wanted to come from how do we change the health system? And so with the information out of that, for each country, we looked at the health system bottlenecks for a number of interventions, including kangaroo mother care. And there's this more detailed paper with Linda Vessel on it. There's also a paper for small and sick newborn care with which Ashok was a key partner on. So for kangaroo mother care, if we look across all the WHO health system building blocks, what you can see, so these are the health system building blocks as rows, and these are different types of countries as columns. The most striking thing for kangaroo mother care was that actually countries in Asia had lower bottlenecks generally for most things, where moving faster and further than high burden countries generally, and then countries in Africa. But for kangaroo mother care, it was an outlier. So at the point of this analysis, about 2014 or 2013, countries in Asia reported every single health system building block as a problem for kangaroo mother care, as opposed to countries in Africa that were actually at that stage feeling more confident about kangaroo mother care and less confident about small and sick newborn care, where you were probably ahead. And I believe that if we were to repeat this, that, you know, the amazing progress, and I salute your kangaroo mother care group and the fantastic depth of what you're doing, has probably changed this now in India. It would be interesting to know. But if we look at each of the building blocks that are a problem, particularly like to highlight leadership, which links to finance and workforce, data, and community uptake. So these are three important areas. If we don't address these, we will fail to scale up. We can talk about things, we can change policy, but we will fail to implement at large scale. What do women think? How does it work for women? Are they able to be there? Are they able to do this? Are they supported by their family? The leadership and governance, and the data for change. And interestingly, there are now quite a few more papers. There's an excellent one from Maggie Kinshella recently looking at bottlenecks for KMC across Africa, and a very interesting one from Canada looking at bottlenecks there. And they both found fairly similar findings, as well as this recent paper in WHO Bulletin. And then I would like to add a fourth challenge here, COVID. So to walk through these four challenges, first of all, the community uptake and a woman's perspective. Now, in your meeting here, honestly, the talks have really been such high quality, showing how much you listen to women and to the people who determine their decisions, because sometimes a woman alone does not have autonomy over her decisions. Maybe it's the mother-in-law, maybe it's the husband, you know, whoever the other people are who may determine that. And we need to be so thoughtful about enabling the woman. The woman is not just there as an intervention for the baby. How does this work? Is it respectful for her? Does she have washrooms? Is she able to stay? How can she be fed? And yes, we need to bring in men and other female caregivers to help. One of my PhD students, Dr. Helen Brotherton, has just written a very nice paper looking at the insights of other female caregivers and their role that they can play. But at the end of the day, it's still asking a lot of women. And we need to really think about how we do this. We need to empower and listen and enable our frontline workers who are working with the women to support on all fronts, not just the KMC positioning, but also feeding. And then also the staff perspective. What is the perspective of staff? If they're talking to policymakers or to managers or to women, are we portraying this kangaroo mother care in a way that is both compelling and doable? And how do we make that work? How do we communicate evidence well? And how do we deal with the challenges? So if we look at one of the challenges on community uptake, and I've seen this in, you know, more familiar with multi-country uptake across about 20 countries in Africa. But if we don't prepare people for the fact that there will be deaths of babies in kangaroo mother care because these babies are vulnerable, then when a death occurs, we can go backwards. So we need to practically face these issues and prepare staff for them, because it's distressing for us and for staff. Second bottleneck, leadership and governance. So this is necessary to transform what happens. We can't just put kangaroo mother care in a tiny, tiny little space, especially if we're moving forward to kangaroo mother care for babies prior to stability. We need more design and funding and thoughtfulness, because otherwise we're setting ourselves up to fail. What infrastructure do we need? What space do we need? We must have respectful settings for women with privacy and bathrooms, places to express breast milk, fridges, places where they can cater. So this is really critical. We also need more respect for nurses. So it's stressful for nurses working on newborn care. It's harder work, you're on your feet, it's hotter, you don't get breaks. It's worse during COVID. So thinking about how we make this work, the team environment, the mentoring, and I really salute Ashok and his team for amazing innovations in how to think about team and support. And importantly, keeping families at the center. So how do we plan well? And actually, there's very little useful data on either small and sick newborn care or kangaroo mother care, especially as we start to bring the mother into the neonatal unit. It's quite expensive. We might need to triple the size of neonatal units to do this. We need to think about the staff costs, not just do it and try and make do with the staff we have. What are the ratios we need? How do we get norms and standards? How do we give the right planning tools? Because otherwise we will start and it won't be safe. It's one thing to do it in a trial. How do we implement in a way that is able to be safe? And then the third critical health system data challenge is data. We drive blind at the moment. We don't have coverage data. We don't have quality data. This is such an important gap. If you look at anything that is scaled up, immunization, HIV programs, they were ambitious about the data, but also realistic. We need to start with the simplest possible coverage measurement. We need to add other things as we go forward, and we need to design our systems. And I really salute the amazing progress that you have made in India with your SNCU data set, with the follow-up data systems. And there is work coming out on validation, the Every Newborn Birth Study, and other ways that we can take this forward. But this is urgent. We can't make it complicated and take years. We need to move on the data. And then the fourth challenge is the pandemic. And I saw in the talks already that these papers have come up several times, and Suman has been such a wonderful leader in this work. And I think one of the big messages out of these papers on kangaroo mother care in a time of COVID is that, yes, we need to do kangaroo mother care more now than ever, but also really important, we were not doing well enough before the pandemic. Coverage was too low, and every country can do better. And India actually stands the most to gain. And I saw that slide with our colleague who was honored just before the break. We need to really take this moment to say, when we come back from the pandemic, we need to do more. And then if we look at what's happening in the pandemic, and Suman and colleagues who led this survey with more than 1,000 respondents, many from India, showing that, in fact, newborn care was still newborn on the agenda before the pandemic. Newborns are vulnerable at an individual level, and newborn care is vulnerable at a systems level. We need to really pay extra attention to protecting. And one particular threat is oxygen systems. So, looking at the data in India at the moment on oxygen use, and also in Brazil, with the risk of running out of oxygen, one of the shocking things in this survey was that oxygen is sometimes being taken off newborn wards. We need to intentionally enable our staff to protect newborns and to protect small and sick newborn care, both keeping mothers and babies together, looking after workers, and looking after that environment. And so that was KMC over 4 decades, 4 challenges now. And I want to move to the future, 4 shifts. What are the things that we must do over the next 5 to 10 years so that we maximize the impact of kangaroo mother care? First of all, we need to implement at scale, not just get to scale, but it needs to be high quality. We need to integrate with small and sick newborn care and families at the center. Fundamental. We've started with kangaroo mother care in some places as a separate entity. We need to bring that together. We need to start now, and I know India is already doing this, on neonatal follow-up for KMC, yes, but also for all newborns at risk. And then we need to transform our information systems. We need to start with coverage and add more. So talking first about implementation at scale. To do this, we have to make a pivot. So kangaroo mother care had to start as a standalone. It links with breastfeeding, it links with small and sick newborn care. We have champions, we have centers of excellence, and we need to use that to distribute within small and sick newborn care and a systems approach. So if we're going to transform infrastructure for small and sick newborn care, we need to keep kangaroo mother care in that, just as India has with your design of your small and sick newborn units. We would love to learn from that. And so I'm excited to share with you that with UNICEF and particularly with the leadership of Gagan and linked to NEST 360, we're joining up a small and sick newborn implementation toolkit. It will be free online, and the idea is to promote WHO guidelines and bring in learning from around the world. And India has exceptional learning. So Prof. Dirari is joining us in this endeavor, and we welcome all of you. I can share with you afterwards how you can join. There are a number of working groups for each of these health system building blocks. How do we join together to learn from India and also to learn from what's happening in Africa and in Europe and in Latin America and make that go faster together? I know that you heard from Anne-Marie Berg about implementation and stages of implementation. This is such an important framework. We start, of course, with creating awareness, champions, centers of excellence. We move to implement, and then we move into a wider system. And to do that, we must systematize the standards, pre-service training, data, and so on. And I know that she has published many papers in this area, including evaluation in India across facilities on moving kangaroo mother care to scale. And I know that many of you also have deep learning on how to move to scale. We need to understand what works, but also what does not work, which people tend to not publish actually, and is important for others. So that's the first thing, implement. The second shift is to integrate. So kangaroo mother care in many ways started in separate rooms, sometimes with separate champions, separate ways of doing things. But actually, it really belongs within small and sick newborn care and within the WHO levels of care. How do we promote that skin to skin for all babies at the bottom, then moving through the different levels of KMC and achieving that, and noting that the more we go up this pathway, higher levels have more impact, but they also have more complexity. We need more workers, more space, and more systems. And this is the WHO levels of care. Very important to recognize that we will fail if we haven't done the basics well. We need to have breastfeeding and resuscitation. Then we add this special newborn care. We add the CPAP in the transition, and then we go up to intensive care. And so important that in fact, this every newborn coverage target, the fourth every newborn coverage target, was really guided by the ambition of India. So I salute you. I have learned so much from this work. For within 1 decade, as Ashok outlined, you have gone from 10 special care newborn units to more than 800. And more importantly than that, in each of those, you have data to track what is going on. You know about the quality and the coverage, and you've added follow-up. This is remarkable, but it's still hard for other people to know what is happening. People can't all come and walk around your special care neonatal units. So I would really ask and appeal that those of you who are involved with this join the implementation toolkit and share your learning, share what worked and also what did not work, so that other countries can go more quickly. And we need to go more quickly, but also more systematically and carefully, because we can't just do one intervention at a time. Kangaroo mother care, if done well, will mean that we then want to do CPAP. And I know that Queen Dubé said this yesterday. Once we start doing kangaroo mother care well, babies survive. And then we have to bring in the other parts of the package. And so there are ways to do that systematically, bringing together a health systems package. And this is one example with the Nest 360 group, now working with 4 African governments and 16 different institutions, mostly in Africa, bringing this health systems package, and within that, working with the technologies, because the technologies often break or don't serve us well. So technologies alone are not a solution, but if we're moving to small and sick newborn care, as well as the policy and the workers and the place, we need to make sure that our devices are there and work. So in that baby that you saw a couple of slides ago who was struggling to breathe, Chikon Jetso, he had a chance to survive because people believed that he could survive. He was a conqueror, and that conqueror been able to go on to have his child development follow-up. And so the third challenge that I want to leave with you is making sure we do follow-up. And I know that India has done remarkable progress on this. And this is something that many would like to learn from. Your retinopathy work, which Ashok and others have led across the country. This is so important. Otherwise, we risk repeating an epidemic of blindness, which we cannot do. It's unacceptable. Quality care is also safe care, but we will only know that if we measure and follow up and think very carefully about that. And the final challenge I want to leave you with is information systems. So through the Every Newborn Action Plan, now 90 countries are tracking progress. Some are doing more than others. India's ambition is remarkable. 78 countries have set targets, but we still don't really know what's happening for KMC. 29 countries say they have a policy. 25 countries more say they're developing it. 18 countries say they have indicators, but actually the indicators are all different. So kangaroo mother coverage may be low, but actually we don't know. We urgently need indicators, and indicators that can be simple enough to work in every country's system. And to those indicators, we need to add effective coverage. So we measure quality at scale, duration, feeding, and so on. And WHO and UNICEF with the London School are working on this at the moment, and several of you are in different groups looking at these indicators. The only validation study to date is the Every Newborn Birth Study. And this paper from Nahia Salim just came online a couple of weeks ago in BMC, Pregnancy and Childbirth. So this study looked at 23,000 births in 3 countries and looked at mother-baby pairs who were observed with timestamp data to compare what happened in truth, what was recorded in a register, and what women could recall in a survey. It looked at a simple indicator of initiation with different denominators, 2,000, 2,500, and also effective coverage. How much duration, position correctness, feeding, supportive environment. I haven't got time to go through this paper, but here's the bottom line. Coverage is actually remarkably accurate in HMIS, at least for initiation. We need to add the rest afterwards. It's also very accurate in surveys, but whether we can do this in surveys or not probably depends on sample size. And then the big challenge will be effective coverage. How do we measure this and how do we make it work? But if we don't start with the simple part in HMIS, we can never add this part. So this is necessary but not sufficient. But if we start here, we will never get this part. And so we need to be much more ambitious about transforming measurement systems. You in India have been ambitious both about clinical provision and about measurement systems. How do we get the information that we need instead of just complaining about it? We always complain about our bad data. But if we want to transform measurement systems, we need also to be integrated, because we'll never be able to do measurement systems vertically. It's not possible. So this Every Newborn Action Plan, set out several years ago with a number of partners, has helped us to be ambitious. And it's being updated by WHO now. And this, I think, is fundamental for change, for kangaroo mother care, and for small and sick newborn care. We won't get more investment. We won't know where we are. We won't know our equity gaps if we don't measure at scale. So I want to end by saying, I salute you in India. You are like this baby. You are ready to act. We are the generation that can change survival and development of the world's newborns. Here are 4 challenges that we throw out as shifts for going forward. These can change India's next generation of babies, but also give great opportunities for you as clinicians, research leaders, quality improvement leaders. And importantly, you can really contribute so much to the world. I have enjoyed learning from you. I hope to learn more, and I hope we can work together around the world. Thank you so much.
Thank you, Joy, for giving a real, complete, holistic picture. How do we get KMC implementation done? What the challenges are and what the shifts are. So with me is Rajesh Mehta, who is working in all the CRO countries. So may I ask Rajesh Mehta to say something about implementation challenges, barriers, and even the shifts which we have to do in the CRO region. Over to you, Rajesh.
Yeah, thank you, Joy. It is always a joy to listen to you because you give so much pragmatic advice as well, as much as the data itself needs a lot of support and quality and all those issues. So what we did in 2018, we did a survey among our countries, the high burden countries, including India. And we found the setting is very clear. The science is clear, everyone agrees. The policy, guidelines, training, everything is in place. But it's the implementation challenges which you mentioned, which are actually emerging from both sides, from the service provision side, as much as from the demand side. So there have been, continuous problems, especially related to infrastructure. As you said, the bottleneck analysis does reveal that. The infrastructure, if you unpack a little bit more, Joy, even the basics which look, sometimes we take it for granted. For example, are we able to do in sub-district setting in India, even identification of the eligible babies and mothers? Is there a good weighing scale available to that basic level? And it is horrendous to see even that is not possible in some sub-district levels. And then KMC itself, we talked about the room and the baggage and the lockers and the couch and the bathrooms. But what about that KMC binder or the garment? And the napkin which each baby should have. Do we have that in sub-district settings to make the mother comfortable? And then a lot of socio-behavioral, as you mentioned, in terms of whether our health workers themselves are convinced. Many times they are not convinced. And that conviction doesn't translate into convincing the mother or the family. And on the other side, there are socio-behavioral issues within the family. So although the new evidence you suggested, we do have the evidence which would be shaped into new guidelines now. And those evidences would further make a strong case of taking it to scale even more, with more conviction and comfort. For example, it is clear by now that in the facilities, it was proven through these research that you could do it as a standard of care to all babies. So even in facilities, if the coverage is languishing at 5–10% of reasonable duration KMC, there are ways to take it to scale. And Ashok Darari, we do a lot of point of care quality improvement work. And even the POCI, improving the processes at the place of work, improves compliance to KMC provision. The second study revealed that in the community for 2000 to 2005 grammars, it is possible and it saves lives if you initiate in community and if you follow KMC in graduates of SNCUs when they are back home. So we need a lot of support for the woman itself. The whole family has to gear around. It's easy to say that you please do this, and it is not possible. As it is not possible for a nurse in the duty in NICU in All India Institute of Medical Sciences, unless the whole team is supporting her. So both sides, at the facilities and in the homes, we need a lot of supportive structure beyond the physical infrastructure. So with all that, clearly available, and then the third study, which is partly these findings are out, immediate KMC, as you were mentioning, and Dr. Chilani was there yesterday from one of the sites. It is possible to provide even if the babies are not clinically stable. It is safe, it saves life, and it is feasible to get the mother inside and give that kind of KMC even when the baby is on CPAP. So with that, all that evidence, which will soon, we will follow the grade process and take the guideline out, it should enable the systems to deliver. But I was so happy to see, or actually depressed to see, the Gary Darmstadt's analysis of scaled up. For maternal health, we have taken so many years to reach. Immunization, we are fond of quoting immunization. After 40 years, where we have reached the third dose, the essential immunization, in my region, the average is just 65%. After so much investment, essential immunization at national average, we have done pretty well with some, but still, ORS is simple intervention, languishing at 50–60%. Breastfeeding is such a social disaster that so much you do, and then science is very clear, same for KMC. So we are kind of, getting a little bit anxious, and we are a little bit impatient that why this science proven, intervention package cannot be taken to scale. So your talk was very illustrative and also giving us a little bit of optimism that we can do it. And the whole group which is listening to us, we heard them, through several interventions, and Vinod Paul's, or the speech also tells us system is getting ready. We are just there. We just have to reach the tipping point in India, and then nobody can stop us. But we must agree with your opening slide. It is the COVID pandemic which has pulled us back. But with people like Shashi, Vani, who is there, and these champions, I think we should be able to build it back better. We're doing something good, but I think this opportunity will be there to even make it better.
Thank you.
So that's the kind of corollary to your presentation, and there are a lot of food for thought. But we are so much happy to have you and tell us those 4 big shifts which are required, and the 4 barriers which we just saw. Thank you so much.
Thank you, Joy, for giving a real inspirational talk. We are all motivated. And it is always listening to you, like an electrifying person, you get motivated for next 4, 5 months or 6 months. So all the clinicians who have listened to you, they know now we need to have family on board. We need to have data. We need to have leadership. We need to take managers on board and make a dent in the policy, like people who make the policy. And then finances we need. And data is what will make us sure that KMC is getting implemented. And the follow-up rates of KMC, which is going to be done, and the 4 shifts which you mentioned. I think great learning for us, and we will work on those things. Thank you once again, and God bless everyone to be safe during this time of pandemic. Thank you, Rajesh. Enjoy.
If Joy has the last word, Suman can allow that probably.
Yeah, okay. Over to you, Joy.
Yeah, I just to say, I know that I will learn more from you, and what I would hope, you know, I throw out the ambition back to you,
Yes.
because I know you will run with it, but I also appeal to you. I was born in Uganda. I've lived in many African countries. You know, we want to learn together with you. So if you can join us in the small and sick newborn implementation work, bring your learning in, bring your fantastic point of care and innovations, please, so that together we can go faster in India and beyond.
Sure. We will all do it together. We'll do it together. Sure.
Thank you.
And have a lovely rest of meeting. I excuse myself now. I have to go and do some family duties.
Thank you so much.
Thank you so much, Joy.
Thank you, Suman.
Thank you. It was so motivating. The challenges have been very well accepted, and the shifts are something that we are going to do. I think Shashi, Shashivani madam, I think would like to say something. I can see her there. Ma'am, do you want to say anything? No. Okay. Thank you, ma'am. And we thank you for the roadmap that you have created for Scale Up. And I must say that when we said we want to invite Professor Joylon, people were wondering whether you will have the time for us, but you returned the email acceptance in less than 10 minutes. Thanks so much, Joy, and it was pure joy to have you here. Thank you, and we now move on, and I thank the chairpersons, Professor Deorari and Dr. Rajesh Mehta, for the wonderful discussion around this, and hand it over back to Bharti to call on for the next session.
So we have food for thought and work to do for the next few months to make the shift happen. Thank you, ma'am, and thank you, chairpersons, for such a wonderful session. The next, I invite upon Dr. Anuj Grover, consultant neonatologist in Ahmedabad from the KMC Foundation, to present to us KMC and Transport, a consensus statement. He is also joined by Ms. Dr. Daisy Evangeline Garcia. Over to Dr. Anuj.
Thanks a lot, Bharti. We'll start off this session with Dr. Daisy from Philippines. She's going to present her data regarding kangaroo mother care transport from Philippines. Thereafter, I will present our discussions, a summary of our discussions from the kangaroo mother care transport virtual meeting that we had in March last month. Over to you, Dr. Daisy. Can you unmute yourself?
Okay, thank you, Anuj, Dr. Anuj, and thank you, Dr. Suman.
Thank you, Anuj, Dr. Anuj, and thank you, Dr. Suman.
Is there an echo, or are you hearing it?
Is there an echo, or are you hearing it?
Hello?
You have opened a virtual platform on 2 devices.
You have opened the virtual platform on 2 devices.
I think I'm not so techy, but my son-in-law, he said it's
I'm not so techy, but my son-in-law, he said it's the
translation. Anyway, I'm happy to be here.
Anyway.
Thank you for inviting me.
I'm happy to be here and for inviting me.
I never thought that the very brief
I never thought that
Shashi Vani
very brief
would lead to another meeting with her again twice, virtually actually. So I will now share my slides. Okay. So just briefly, we know that the practice of kangaroo mother care started in 1978 in Colombia, and thereafter it reached the Philippines through our very own Dr. Suki, and it has been like 20 years ago, 2 decades ago. Since 1978, when it was first introduced, there were a lot of skeptics that the kangaroo mother care will not work. But what was considered a revolutionary care at the time is now considered a standard newborn care all over the world. And since its introduction, it has gained a lot of flavors. It has gained its practice even in the sick newborn infants. And today I'm going to talk on another flavor. I'm sorry. Which is, can you remove this? The transport of the small infant. And as I always say, no kangaroo was harmed in making this presentation, just to lighten up. All right, so this is our idea of kangaroo mother, baby transport. I know you're familiar with this, but we know it's not just the availability of a transport incubator, but we know that it's unstable. So it's very hard. So even if you have a transport incubator, it has to be anchored securely in the ambulance or whatever transport system that you have. And then the baby is, so the baby is not adequately secured in the incubator. Studies have shown that there is an increased incidence of intraventricular hemorrhage in babies who are transported through transport incubator. And then there's the separation of the mother and the baby. So the bonding of the baby and the mother is disrupted. It is very costly. In the Philippines, it will cost us around like $1 million, which is what, 50,000 US dollars for us to be able to afford one. And the other problem is it's not always available. We don't have it in our area, in our center. So this is the study that I've seen the first time in the literature of a KMC transport in Belgium, 2004, where the mother is semi-seated 60 degrees, restrained to a gurney with 2 seat belts, as you can see, and faces the rear back of the vehicle. And the baby is in a frog-like position in kangaroo transport and restrained by an elastic feeded tube, which is what we use also in our area. So this is the study that I said. There were like 2,000, sorry, I have to go back. Sorry. It shows my age. Anyway, so this is how they did it back in Belgium in 2004, where There was a mother who transported the baby, and the longest distance was 400 kilometers, and the father transported the baby, did the kangaroo mother care transport. So the first study done in the Philippines was from our very own Dr. Tita Uy, who is with us now, and her fellow at that time, Dr. Wayne Ignacio. I agree that really most of the studies are done just to comply, but with the requirements of fellowship or even residency. But look at how these studies have become as we present them to you. And the first study was a kangaroo care transport versus transport incubator in transporting stable preterm neonates from the delivery room to the neonatal intensive care unit. And the comparator here was the transport incubator. And in this study, they showed no difference between the physiologic parameters measured, like the heart rate, respiration, temperature, and the oxygen saturation of the baby. So this is from the delivery room to the neonatal intensive care unit in a tertiary hospital. Now, the second study is our very own, where we look at the efficacy and safety of KMC mother care as an alternative means of transport of preterm, small for gestational age infants, which is a randomized controlled trial by my resident at the time, 2017. Just to make you familiar with the Philippines, you'll know the Philippines is composed of 3 big islands. And I think there are 7,000, more than 7,000 islands in the Philippines. And the blue one is the Luzon, the yellow is Visayas, and the red one is Mindanao. As you can see, this is where Suki is in Manila. And this is where I am, right 300 kilometers away from Manila. So the geographic location of each area is such that transport is really a problem in our country. So the main objective of our study was to determine the efficacy, safety of KMC in the transport of preterm and term SGA infants. Mainly, we wanted to look at the temperature of infants transported by conventional, which I will show you later on, versus the KMC method. And we look at other parameters like distance, gestational age, the sex, the birth weight, and Apgar score to determine the impact on the transport. So the study population, we enrolled physiologically stable neonates with Apgar scores of more than 7, birth weight between 1,200 to 1,800 grams, not needing ventilatory support, and no congenital anomalies. Before we started this study, we had conducted KMC training courses in the participating hospital centers, and we did didactic lectures, and thereafter we did a return demo after like a day or 2 sessions. So we distributed interventional kits. It has to be the same so that to remove any variability. So we distributed a bonnet and a blanket for the conventional method, and we gave bonnet and blanket and a tube blouse like this, and a pulse oximeter and a digital thermometer in all the participating centers. This is the conventional transport. Sorry. Conventional transport. So the neonate is just done with a cap or a bonnet, a cotton clothing, and wrapped with a blanket and placed in a bassinet or a crib. As against our KMC transport, which is like so. You can see the tube blouse, which is expandable, and the baby is placed on a kangaroo, I mean a frog-like position. Now, before we place the baby on the mother or any relative, the tube blouse is still first worn up to the hips and then rolled over to cover up to the shoulders of the baby. And the head is covered with a bonnet or a cap. So that's the KMC transport that we did. So just to show you how our tube blouse look like, because during the last time that I presented this in the same, like to another group in India, they asked me how our tube blouse looks like, and this is how it is. This is, of course, in our neonatal intensive care unit, but you can see how that we use the tube blouse. And this is another one. So it's actually one baby can fit, and then it can expand to accommodate twins, not triplets. So we monitored the following parameters: the temperature, respiratory rate, cardiac rate, and oxygen saturation prior to transport, midway of transport, and upon arrival. So we had 10 referring centers with a distance of 3 to 49 kilometers. The 3 was just nearby, and we used, I don't know whether you're familiar with our tricycle here. It's just like tok-tok, I think, in Thailand. In the Manila Jeep, we use it sometimes to transport our babies. And of course, we have the car, and if the center has it, the babies were transported through ambulance. There were 31 neonates who participated, 15 from the KMC and 16 in the conventional group. And this is the, in the interest of time, I'll just give the summary. The mean temperature between the groups prior, midway, and after the transport or upon arrival at the ER. So as you can see, there's a big difference, which can be seen in this risk-based estimate and 95 confidence interval between the kangaroo mother care transport and the conventional transport. So there were 8, none of the babies on the KMC transport developed hypothermia, whereas there were 8 infants who developed hypothermia during the transport. So this had a risk ratio of 0.06, 0.026 risk ratio. So these are the other parameters that we measured. I mentioned about the temperature. And as early as during transport, we can see that there is a significant difference between the KMC and the swaddle or conventional transport as far as the temperature is concerned. The heart rate was significant, statistically significant, but if you look at it clinically, 146 and 151, we considered it as not a clinical clinically significant for us. But there, so with the respiration, but at the end, after when the babies arrived at the emergency room, that it was not clinically significant. And so with the oxygen saturation of the infant. So again, I'd like to emphasize the difference in temperature with the risk reduction of relative risk remaining of 0.06. So KMC transport, we know that KMC actually reduces hypothermia, but it's just sad to say that we end up just doing these studies. The study showed that there is a 93.75% reduction in the risk of hypothermia with the confidence interval of like this. So we concluded that KMC transport is safe and efficacious. It's always available, especially again in our resource limited areas where transportation is a problem, where parents or even the relatives or even the healthcare worker, they have to walk a mile or so, kilometers or so, just to get to a higher center or to get to an ambulance or a transportation. So it's very safe. It can be started immediately during transport and with low cost and very minimal cost. I like the screen presented by Dr. Joy and Professor Joy. So what if it decreases? There's a 93.75% reduction in the risk of hypothermia. I like it because in there it decreases. The relative risk is 0.28%. in relation to mortality. That's the impact of hypothermia in relation to mortality. So KMC transport is safe and efficacious. Thank you. Can I add, hello, Anuj?
Yes, ma'am, you're audible.
Yes. Although this started as a study, because in our center, most of our patients received already hypothermia. So it was a problem, and we did not even, our center just started it. It did not even take our neonatal society to do it. So we just started it. And I did not imagine that the impact will be this much. Like, I have actually presented this already twice in our country, and I think this is the second time for India. So from a little thing that I did not imagine it's going to be this, the impact will be like this. Thank you. Over to you, Anuj.
Thanks a lot, Daisy. That was great to listen to the presentation again. I'm sure with the wider audience, we'll have a better. Are you able to hear me?
Yes.
Thank you very much for your presentation. Really liked your data. It's kind of one of the first or the only RCTs to look at the KMC transport versus the conventional transport, and hence the importance of showing that it's not only safe and efficacious, but also reducing the chances of hypothermia significantly. That's really a very good achievement. Thank you so much.
You're welcome.
Can I now present some of the discussions that we had?
You just tell Anuj that is in.
Just tell Anuj that is. Can you see my screen?
Yes, sir, but your internet bandwidth up. So you can turn off the video.
Okay.
And you seem to be logged on to from your side.
No, I'm on logged in only on one device.
Now it appears to be.
Am I audible, Bharti?
Yes, sir. Yes.
Okay. Right. So I'm going to talk a little bit about kangaroo mother care transport of the newborn babies, and why is neonatal transport important? You look at the number of total births in India, 25 million live births, and we have almost 0.75 million neonatal deaths per year. And we know that the mortality is higher in babies who are transported rather than babies who are born in a tertiary unit, inborn in a tertiary unit. The majority of these babies succumb immediately after reaching the hospital or in the 24 hours prior. We know that the best form of neonatal transport is the in utero transport. If we can transport the mother, it is always better for a better outcome of the babies. But in cases where we are not able to transport the mother and the baby's delivery happens in a sort of a smaller center, then we have to arrange for neonatal transport appropriately. Now, the current status in India is very varying. Some states may have well-developed transport systems. Some private hospitals have got excellent transport facilities, but a lot of the places, it's not very well organized. It can range from a full-fledged transport kit to just a baby being wheeled in the stretcher to just being carried in the tray with very little in terms of thermal protection. There's an interesting study from Delhi where we looked at 220 transfers into a tertiary unit in Delhi. And of these, 77% were by a private vehicle and only 23% by an ambulance. Only 40% of the ambulance transfers had access to heating or oxygen, and only 20 newborns were accompanied by a doctor. So less than 10% babies were accompanied by a medic. And not surprisingly, we had high incidence of hypothermia, hypoxia, and hypoglycemia in these babies. A lot of these babies required assisted ventilation, and almost 10% of these babies died. If we compare that to the Western world, the transport system there is much better organized and well. The communication is the key thing. They have neonatal networks in place. They have a dedicated transport team for interfacility transport. The trolley looks something like this, which is fairly expensive and not possible everywhere in the country here. So if we look at the reasons why the transport service in terms of newborns has been poorly developed, is either lack of awareness, resources, appropriate training, the equipments, but a lot of it also to do with poor coordination and poor communication. Hardly any transfer into a tertiary unit happens with a prior communication. Babies are just wheeled in, and obviously in a poor condition, so that's why the outcomes are much worse. Now, we all know that the kangaroo mother care is helpful for the babies, not only for preventing or reducing hypothermia, but also for better neurodevelopmental outcomes, as we have looked at into the entire conference. Now, the question is, can KMC be used as a means of neonatal transport in the immediate newborn period and provide the same benefits? So if we looked at the data, the first of these studies was from Sondhemer, which Daisy has already quoted. 31 stable babies were transported, and they concluded that it was a safe, effective, and inexpensive method of transport. We've seen the data from Sondhemer already. We've seen these slides, so I'll just go through. The second was this trial from Philippines, which Daisy has discussed in detail, and it clearly showed that the babies had much less hypothermia and much less hypoglycemia, and babies tended to do much better in the transport care group compared to the conventional care group. There's already an ongoing study, the immediate KMC study. Dr. Harish Chelani, Suman, and a lot of others are involved in this study, and we are eagerly awaiting the data. This study is looking at the impact of continuous immediate KMC started immediately after birth, compared to a KMC state is initiated after stabilization. And this is happening across the world in lower resource settings in India, Malawi, Ghana, Nigeria, and Tanzania. The concept is skin to skin starts at birth, immediate KMC. The baby is transported to the unit also in a KMC position, and then remains in the mother and neonatal intensive care unit and the KMC ward, and thereafter finally discharged home and doing home KMC as well. Now, from Harish Chelani's experience, personal experience that he's told us, the initial findings show that the KMC transport is not only safe, and there is no increase in rates of apneas, desaturations, or respiratory distress. The incidence of sepsis is actually less in babies where the immediate KMC was initiated. However, a lot of the transports were done using surrogates instead of the mothers themselves. But we look forward to the full data in the next few months to come. So we know that from these studies that the KMC transport is low cost, is easily available, no special equipment needed, is clinically effective, safe, and avoids the separation of mother and baby. The scope of KMC transport in India is tremendous, with the view of the poor resources and inadequate training. KMC could be the most efficient way of neonatal transport in India, whether it be from community to hospital or interfacility transfers, certainly back transfer to home, and it will help in reducing the maternal newborn separation, but we need to have proper guidelines and training. With the view of this, with the background of this, we initiated a kangaroo mother care transport virtual meeting, which was held on the 20th of March with the Zoom platform, and several dignitaries were there. We had national authorities as well as international faculty who gave their presentations and their views on how we can develop this kangaroo mother care transport system for the babies in here. And the recommendations for the KMT transfers, we agree that we should start initially with stable babies, like say going back, transferred to home from the unit. The babies that are going back home, they can be started with a kangaroo care position. Those who are coming from home to hospital for an OPD visit, they can have the KMC transport. Once we are comfortable with stable babies, then we move on to the babies who are more sick or unstable. We will need proper counseling of the mother and relatives, adequate training of the staff. We did discuss a lot in terms of consent for the KMC transport, and we agreed that for the intramural transport, we may not need consent, but for the extramural transports, we should take prior consent. In particular, if we're looking at the different types of scenarios, so a baby coming from the community to hospital or any facility like the SNCU, there wouldn't be the availability of proper neonatal transport is unlikely. And in this scenario, KMC is the preferred mode of transport for any infant living hospital. We would be able to keep the baby warm. NIC, one from one NIC. In ambulance with the monitoring, but unstable babies, say babies who are went.
Can you turn off?
We may have use KMC. Sorry.
You're losing your audio intermittently. Can you turn off your video?
Sorry. Are you able to hear me now?
Yes, sir.
So unstable babies will definitely, we can use KMC if the transport incubator is not available, but will need proper monitoring and trained nurse, doctors if available. We would need special training for the paramedics with the 108 staff and the nursings. This was one of the slides that I've taken from Vanessa's presentation from that day. This was kind of a flow chart that they had developed for keeping the babies warm during the KMC transport. We can obviously use this or a similar performer for our babies. We did discuss about limitations of kangaroo mother care transport. So far, most of the transports have been done in stable babies. So the evidence for KMC transport is limited in unstable babies. In babies who are hemodynamically unstable, either ventilated or in shock or extreme prematurity, if there is a suitable transport incubator available, that would be preferable. But if that's not available, then certainly KMC transport will be preferable to doing nothing. So suggestions or recommendations for scaling up the KMC transport, we need to formulate the national guidelines. We need to think about designing the labor rooms better with the adequate infrastructure for zero separation so that the KMC can start with, we can have immediate KMC from the birth, ensure the transport of in KMC position as much as possible, and important to have the teaching and training of nursing staff, paramedics, obstetric colleagues, and also the community health workers. And as a general thing, to increase the awareness in the general public about the KMC as well. Thank you.
Thank you, sir, for that extensive review. Review on KMC and transport. We now go to the final session, that is the valedictory. First, I now call upon to announce the prizes for the award paper and the free paper. We had around 21 papers of excellent quality. I congratulate all the presenters. Participation by itself makes you a winner. So when I call out your names, I request you to turn on your video. So for the prize for the award paper in the nurse category, the prize goes to Miss Monica Rita Hendricks on nurture intervention on neurodevelopmental outcomes of preterm infants. For the award paper in the doctor category, the prize goes to Dr. Sandeepan Sen, Impact of Quality Improvement Initiative for improving number of babies who receive quality kangaroo mother care for at least 6 hours a day in the postnatal ward. Dr. Sandeepan.
Hello, ma'am.
So congratulations, Dr. Sandeepan, and one more round of applause to you.
Thank you, ma'am. I will congratulate the whole organizing committee of KMCCON to organize such a con. I was there in the most of the session, and I will also thank my guide, Dr. Oration Kumar Mullik sir, and also my co-guide, Dr. Shravani Mandal ma'am, for their intense support, for which I was able to conduct the whole study, whole POCQI project, and it was quite a successful. And thank you everyone, ma'am. And I will like to participate such conference in further times and the recent future. Thank you, everyone.
Thank you, Sandeepan, and we wish you all the best for your future.
Thank you.
So, for the award in the free paper in the doctors category, the prize goes to Dr. Varun for effect of kangaroo mother care on skin microbiota of twin preterm neonates. Dr. Varun, in case Dr. Varun is not there, Sahana ma'am, can you come and speak on behalf of Dr. Varun?
Thank you so much, Bharti. I'm so happy on behalf, and Varun has done a wonderful work on this. Can I just call him up and take it up?
Yes, ma'am, sure.
He was calling me from morning, okay?
Sure, ma'am, sure.
Just a second, yes.
Yeah, we would wait.
Yeah.
So as we wait for Dr. Varun, I now announce the prize for the free paper in the nurses category. That goes to Miss Clarissa for effectiveness of video assisted on knowledge and practice of KMC among mothers of preterm neonates admitted in selected hospitals. Clarissa?
Yes, ma'am. Yes, ma'am.
You may speak a few words.
Yes, ma'am. I thank all the organizers of this conference for giving me an opportunity to present my paper. And also I thank all the faculty members and the teachers who guided me during my MSc nursing studies. And I'm very happy and glad that I could take up this study because I myself had this personal experience with KMC. And I'm very happy to put it into practice wherever I work. Thank you, one and all.
Thank you, Clarissa. We wish you all the best for your future. Once again.
Yes, ma'am. Thank you.
Now, I would again ask if Dr. Varun or Miss Monica is present. So, we would continue with the valedictory as they join. So, I would like to propose a vote of thanks to each and everyone involved. So I would start first with the KMC Foundation, Dr. Shashi Vani ma'am, for being the brainchild of this whole program and of everything which we have done and for giving us this opportunity. And other members of the KMC Foundation, including Dr. Somshekar, Dr. Nikhil Karod, Dr. Ashish Mehta, Dr. Parag Dagli, and Dr. Anuj Grover. Next, I go on to thank the NNF Karnataka dignitaries for their unconditional support to all our endeavors, to the President, Dr. Koturesha sir, and to other dignitaries, including Dr. Kishore Kumar sir, Dr. Dinakar Prithviraj sir, and Dr. Bidri sir. I also extend my heartfelt thanks to the UNICEF Karnataka, especially Dr. Sanjeev Upadhyay, for supporting us. Next, I thank the 4 workshop coordinators, Shashidhar sir for coordinating the provider virtual, Dr. Parag Dagli for the coordinating the trainer of trainer workshop, Dr. Binita Desai for and Dr. Nikhil Karod for the home-based KMC workshop, and Dr. Sri Krishna for the QI on KMC workshop. I also extend at this juncture a heartfelt thanks to Sahana ma'am, who meticulously planned a provider physical workshop, but unfortunately had to be cancelled because of the COVID pandemic. Next, I extend my heartfelt thanks to the Vani Vilas Hospital team, including Sahana Madam, Dr. Gayatri, Dr. Sujata, and Dr. Anita, who tirelessly worked for the last 1 month for this conference. Next, I come to our own team, where I first and foremost extend my heartfelt thanks to our professor and HOD, Chandrakala ma'am, for supporting this conference. I also extend my heartfelt thanks to all my colleagues, Dr. Shashidhar for tirelessly working for the workshop, Dr. Saudamini who worked for organizing the paper and the poster presentation, and Dr. Prashant in registrations and in coordinating the complete IT support and almost the entire program. Next, I extend my heartfelt thanks to all our residents who have every day sat through this program and helped us organize this completely. To name them, Dr. Nalina, the 3rd year senior resident, Dr. Rashmi, 2nd year, and Dr. Anjali, Dr. Vishwas, and Dr. Swapnik, and especially Dr. Aril and Dr. Fatima, who have worked in close coordination with me as the registration desk of this workshop. I also thank the nurses of our NICU, especially our nurse in charge, Sister Sophia, for helping us organize the workshop. I also extend my heartfelt thanks to other members, including Miss Monica Rita Hendricks for organizing the nursing CME credits, and also Miss Marianne and Miss Virgin for coming together with us, especially for the provider virtual at the last minute when they were called. I extend my heartfelt thanks to all the faculty and all the chairpersons who have agreed to us within almost 1 month of contacting them. I thank our virtual partner, Sim Global, to name them, Mr. Gautam Menon, Mr. Vignesh, and Mr. Rafiq, who have been sitting with us through the weekend and helping us for the smooth navigation of this program. I thank the St. John's management for providing us with a wonderful room and facilities to ensure smooth coordination of this workshop. And last but not the least, I thank all you delegates for almost 266 people who have sat throughout all these 2 days and made this program a great success. Last but not the least, I also thank the Almighty for ensuring that everything went well. So thank you all, and I now hand over the podium. Okay, so our 2 prize winners have come, I think. So the first one I would like to call upon is Miss Monica Rita Hendricks for the award paper in the nurse category, nurture intervention on neurodevelopmental outcomes of preterm. Please say a few words.
You're muted.
Monica, unmute yourself. And
yes, ma'am, I've unmuted myself. Thank you so much. The entire journey with the study was such a learning experience, and I think our kids in the our neonates in the ICU really require a lot of work, and I think each of us should take part in this responsibility to get healthy children in this world. So, and I take this opportunity to thank Dr. Suman, my guide, and Dr. Prakash and Sister Selsi, who also were my co-guides, and the learning experience was immense. Thank you.
Thanks, Monica. All the best for your future.
Thank you, ma'am.
So, and last but not the least, I forgot to thank Dr. Suman for actually guiding us through this entire procedure, and I request everyone to give a round of applause for her. Now I hand over the podium to Dr. Sahana ma'am to speak a few words.
Yeah, thank you so much, Bharti, and a wonderful work from Suman and team. And I thank KMC Foundation for giving us this opportunity. And I thank Shashivani ma'am, Somshekhar sir, and Suman for taking this great opportunity. And I thank all the great stalwarts like Rekha Udani ma'am, Ruchina Navati ma'am, and many, Kumuta ma'am for all this great initiative in KMC and making us to be a little bit of our contribution in this endeavor, and waiting to do more of such works and continue to be in the KMC group and KMC Foundation. And I'm so happy to receive on behalf of the Free Paper Award to my student. I'm the guide to Dr. Varun. I'm unable to get him connected. From morning, he was there in the conference, but I'm unable to get him. I thank the jury for selecting this paper on KMC and microbiome. And one of our undergraduate second year student also presented. I'm so happy that undergraduate level second year fellow, he is doing an ICMR project and again microbiome and fungal sepsis on the microbiome, fungal growth on the microbiome. I'm so thankful to the KMC Foundation and Suman for organizing this, and I'm happy to be a part of this team and continue to do my work. Thank you so much. Nice to see you, ma'am, Shashivani ma'am, and Somshekhar sir. Thank you so much.
Thank you, Sahana ma'am, for those words. I now invite Dr. Nikhil Kharo to speak a few words.
Friends, it has been a very fruitful learning experience these last couple of days, and also the workshop preceding that. This is the fifth conference KMC Foundation has organized, and it will be an understatement that without the motivational and solid support provided by and the leadership provided by Dr. Shashi Vani, this would not have materialized. We had some very good presentations, and every year there is some new learning, and we will all go back with our knowledge updated, and also even more motivated to do something further to contribute to the development of KMC services in our country. We have realized that we have a long way to go, but still we are at some stage. And let me conclude, this wonderful conference, by quoting from Bhagavad Gita. It's something about being imperfect. So perfection is always a process, and therefore one should not get disappointed, disheartened for being imperfect. And this is what Lord Krishna says in the last adhyaya. Sahajam karma kaunteya sadosham api na tyajet sarvarambha hi doshena dhumenagni rivavrutaha. So whatever is very natural to you, please do it. Don't worry too much about being imperfect. I think if we do with proper intention and our sensitivity, then I think one day we will achieve the goal that we are setting for our country and the newborns. So thank you all very much, and I also congratulate the organizing team led by Dr. Suman for an excellent job. This was the first virtual conference experience for me, and it has turned out to be very positive. And I'm really thankful to the organizing team for that, and also thankful to my colleagues, Dr. Somsekhar, Dr. Parag, and others in the KMCF group who have helped me, Dr. Binita, who helped me in the workshop. Thank you all.
Thank you, sir, for those inspiring words. Now I invite upon our NNF President, Karnataka President, Dr. Kotoresha, to speak a few words.
Good evening to all. And it is a wonderful things happened on last 2 days. And since yesterday, we are observing all the things very well known, and even the faculties and the topics. And hats off to Dr. Suman Rao and the NN of Karnataka and Vani Hospital. Hello.
Yes, sir, you are audible, sir.
Oh, okay. Audible, madam? Can you hear?
Yes, sir. Yes, sir.
Not opening.
Sir, we can hear you. Oration, sir, we can hear you. Please go ahead and speak.
Hearing now. And since last 3 days we have observed, this is the National National Kangaroo Care Conference to be happened physically. It could have been a wonderful session, but virtually they have been conducted well, like physical conference. This could have been a really physical conference. And regarding the faculties and even very good attendance have been taken by the real learners, and the topics and time monitoring and everything went well. And hats off to Dr. Nimbarkar and Dr. Suman Rao and NNF Karnataka and Vani Hospital and Central Medical College supported well. And really we know some of the aspects. This kangaroo care itself has taken a preterm care, can be taken very well, and even the less financial assistance, care can be given home and the day first. What we call it as a first golden minute. The first golden minute starts from kangaroo care itself. So this could be additional point for newborn care henceforth in future also. So that can be taken very well. And as far as virtual conferences, we could not imagine like this also can be conducted as a physical conference. And hats off to Suman Rao once again for this very good organization. And almost all the internal faculties have been praised this one. And this is one of the accreditation point for good support for the with learners and new learners also, with nursing staff also. We have been in the faculty fellows. And very thankful for your kind invitation for me to pause small words, and hats off to once again organizing team. Thank you, madam.
Thank you very much, sir, for those.
Bharti?
Yes, ma'am.
Yeah, Varun is there.
Yeah.
Can you just, hello.
Yeah. So, Dr. Varun, congratulations on winning the free paper for in the doctors category. You may speak a few words.
Thank you, everyone. It has been a pleasure. This topic was given to me by my guide, Dr. Sana. Ma'am has been a real support for me, and this has been possible only because of ma'am. Thank you, ma'am, so much. It's also been possible because of my mentor, Dr. Shivshankar sir, who has also been a part of doing this thesis. I hope many more such papers I'll be able to present in the future, and we will always be grateful to Sana ma'am, Shivshankar sir, and also Malay sir. Thank you so much.
Thank you, Varun, and all the best for your future.
Thank you.
So for the next, invite anyone who would like to give a feedback about our conference. From the faculties.
We would like some of the faculties to please give some feedback, and if some of the parties, some of the faculties, can you please give feedback? Thank you.
I'm Dr. Udani. Can I give my feedback?
Yes, ma'am.
Yes. So I would say that both the days of workshop was very brilliantly arranged. First day for 4 hours also was good. After that, the next day almost from 9 to 5, that was also very good, very nicely conducted. And the other 2 days of conference was wonderful. And one thing which in the first day, it was said that 3 hours, people are giving KMC in India for 3 hours and we should increase to 6 hours. So there I don't agree for it. We have to aim at 20 to 24 hours, then only we can get the results. And I had said on that day also to the organizers, that is one thing which is very important. So quality KMC is very important. And although some of the places they may be doing zero separation, but most of the places, even for newborn, full-term newborn baby also has to be put on skin to skin contact immediately after birth, which is so easy and so nice it is. The baby takes the breast milk also very fast. So that also hasn't been done in many places, and so that also has to be improved. And third thing, now it is high time that more than 20 years of KMC has come up, and we are not having a good follow-up clinic except at 1 or 2 places. So, and wonderful presentation. It was that one doctor had said that it is not a national conference, it is a international conference. And first day when I saw the particular timetable, I had told Suman that this is not national, this is international. And how you nicely selected all the speakers. Wonderful presentation to whole team of Kangaroo Mother Care Foundation. Congratulations. And Bangalore St. John's team who have organized this conference. Congratulations to that team. And of course, Dr. Shashi Vani has been always behind it, and we are thankful to her that she is managing with the help of all her team. We are congratulating the whole team of both the places, and thank you very much. Wonderful fist of KMC. I had never thought that first two papers on the first day were so much. I never thought that such things are existing. So wonderful fist. Academic fist. Thank you very much. And that's all.
Thank you so much, ma'am, for your encouraging words. Would any other participant, faculty or participant, please?
Yeah, I would like to say, I'm Dr. Ruchi Nanavati here. I would like to say, as I've said earlier, that I think everyone who is present here would definitely salute Kangaroo Mother Care Foundation India under the leadership of Dr. Shashivani and her team for organizing this wonderful conference, which has been an academic feast over the last 2 days. And, it has been wonderful. The lectures are wonderful. And it was really inspirational talks. And it was truly an academic feast. And as I always believe that it is not the venue and menu which makes conference. There was no venue and menu was our own menu, but it's the faculty and the delegates which make the conference. We had very nice faculty and the delegates were interested, we had interested delegates. Most of them are present right through the 2 days. And that is, that speaks volumes about the conference. I congratulate each one of you, the organizing team and Kangaroo Mother Care Foundation. And of course, we all salute you. And this conference will be, remembered for a long time to come. And at the end, for our great teachers, Dr. Shashivani, Dr. Rekha Udani, I would just like to say, Divyatvachi Jetha Prachiti, Tethe Karamaze Jodati. Thank you very much.
Thank you, ma'am. Thank you for those energizing words.
Bharati, can I have a word?
Sure, ma'am, sure.
This is Dr. Kumuda speaking. Again, I want to congratulate, and I'm really always envy of the energy Madam can send to everywhere, even in remote, especially Dr. Sashivani Madam, how she keeps on motivating us to do more and all the time. And again, Dr. Ruchi also. See how she said we have to aim at 24 hours quality KMC. So we have a lot to do in KMC, and all this conference, though I didn't attend yesterday, but today I attended, and it was so motivating, and it always stimulates us to do more, and hope all of us would be able to fulfill their expectations when they are arranging such a conference. And again, I am also congratulating Dr. Suman, Dr. Somshekar, who's a pillar of support to Madam in difficult times for conducting such a nice workshop, and kudos to Bangalore team. Thank you for the opportunity.
Thank you so much, ma'am, for those really motivating words.
Yeah.
Any?
Yes, I would like to say I'm Dr. Deepa Banker from Ahmedabad, a member of Kangaroo Care Foundation India. And first of all, I really like to congratulate Dr. Suman and Bangalore team, and of course Kangaroo Foundation, and salute to Madam Vani for her sincere and endless commitments to this conference, and her efforts, her involvement, and her encouragement. She is the real force behind this. I would also like to say that I really enjoyed these 2 days of academic feast with the carefully chosen topics, the great speakers, and we had opportunity to listen to and learn from stalwarts of Kangaroo Mother Care. And I think this conference was the best example of brilliantly organized conference with a smooth functioning and flow, and very engaging and very informative and very, very well conducted. It was it was a pleasure and privilege to be part of it, and wish all the success to everyone. Stay safe. Thank you.
Thank you for those lovely words and those wishes, ma'am. Any of the delegates, please? International? Chita?
Hi, good evening to everybody. I'm Dr. Chita. I would just like to thank the organizers for this very informative conference. I have learned a lot, and I realized that India has been doing a lot of things, and the progress that we see today and the programs are something that we would also want. So thank you.
Hi, hello. This is Anna-Marie speaking. I am so happy to have been a part of this conference, and having been able to meet up with so many of my old friends in KMC, where we struggled together in the olden days. And thank you so much for the wonderful organization of everything, and even making it possible for people with other time zones to be able to participate. So thank you very much, and I look forward to your further virtual conferences in future. Thank you.
Thank you, Tita, and thank you, Anne-Marie ma'am, for those words. So next I invite Dr. Somshekhar to speak a few words.
Thank you, Dr. Bharti. I would like to thank a lot of people for the conference, and first and foremost, the team in the room from St. John's Medical College, which is Dr. Suman, you, Dr. Bharti, Dr. Prashant, and others in the KMCF in Bangalore from BMCRI, Dr. Sahana, and from NNF Karnataka, Dr. Prashant Gowda and Dr. Koturesha. So it's been because of a lot of hard work of a lot of people from Bangalore that we have been able to make this, but it is not restricted to Bangalore as we have seen today. We also had participation from NNF Tamil Nadu with Dr. Rema and Dr. Arasar and Dr. Mangala Bharti, who made it possible for us to have the oration as we would like to have a physical oration. My thanks also to the head of departments of St. John's Medical College and BMCRI, Dr. Chandrakala and Dr. Sana, for ensuring that we get this together. Thanks to all the presenters and faculty members, and also to my team members at KMCF Foundation, Dr. Kharod and Dr. Parag Dagli, who ensured that we do our workshops on time. I cannot forget Dr. Sri Krishna from Hyderabad for ensuring that we have a quality related KMC workshop on 15th of April, and other team members from KMC Foundation like Dr. Ashish Mehta, Dr. Deepa Bankar, Dr. Ravi Parikh, Dr. Jatin Mistry, and Dr. Anuj Grover. We all know that Madam Vani has been the driving force, and there is one word in Marathi that is used for this. It is called as Vedi Manses Itihas Gadavtat. In other words, in English, only crazy people can make history. And so the way she moves about pushing us to do these things is initially I used to think that it is like Madam Vani is doing this, and now, despite having a lot of personal issues at home, she has ensured that we do an excellent conference. Such an excellent conference that has been organized, that because everyone has been saying that it is an international conference and not a national conference, I think that maybe next year onwards you have to seriously consider holding one day fully virtual international conference and one day fully physical national conference to mark. I think that is some kind of learning that probably I have had from the organization of this conference, and something that we would need to match up to. This is our 5th conference, and we have been learning through our conferences every year. And I'm very thankful to UNICEF Hyderabad region for supporting this conference and reimbursing the minimal costs that have been related to this conference. And we hope that we are able to do something in the future too. If there have been any inadequacies from our side, you can definitely blame me for it, and I will try and make up those inadequacies next time. With this, I hand over back to Bharti and Dr. Suman. Thank you.
For last word, but not the least, we welcome Suman ma'am.
Thank you very much, Bharti. The last word is always by Madam Shashi Vani, and I'm sure that we will just wait for them. Madam will be able to share some few words of wisdom with us. And it's indeed my honor and privilege to have conducted this conference. And I was going to start my thank you speech by saying one of my professors used to say that menu is very important in addition to scientific content. But you heard Dr. Ruchi Nanavati already say that. So what made this conference, I do think, is the very, very eminent faculty who, all of them, very wholeheartedly agreed to all the topics that we asked them to do. In fact, we kept them very, very packed. So people who have given their lives for a cause had to speak about it in 15 minutes. And that was a big, big challenge, but they made it so good. So a big thank you for all the faculty and the chairpersons and for making this conference so good. The other important secret that I would like to say is probably this is because of the pandemic, we were able to do the conference. Nowadays, the conferences are so expensive that I must say that I hesitate to volunteer to do a conference. The cost is in lakhs and crores, and it's so difficult for us to raise this money. So one good thing was when Dr. Shashivani asked about whether you will do, I knew it would at least be in hybrid, if not purely in virtual mode. And therefore, this was one of the reasons. And the small cost that we have is being reimbursed by the UNICEF. So a big thank you. And I agree with you, Somshekhar, probably this will be the way to go for things like breastfeeding and KMC, which will not have any industry support, but we still can do very high level scientific content in the meets. So I think virtual would probably be the way to go, where it may be a small group of people, but they are there for the scientific content. So, so let's look at it, how we can move forward. There's a lot of work to be done, lot of miles to be covered, but we can do it. I thank the Bangalore Medical College team led by Sahana. I thank our own team, which, you know, they have worked so well. I thank the KMC Foundation team and NNF Karnataka. But there are 3 people I would like to really thank. One is, of course, you. I don't know, your picture is still on the screen more, maybe Somshekhar. So one is you. You have been a big support. And the second is Bharti, who has worked for this very quietly, but very meticulously for this conference to ensure it is a big success. So a big thank you to you, Bharti Balchandar. And of course, words are not enough to thank Dr. Shashi Vani. Only when you interact with Madam, you really know why Madam is Madam, and how Kangaroo Mother Care Foundation has been doing all the work they have been doing. It's all because of Madam's vision. You all wonder, maybe things are not in place even 2-3 days before the meet, but somehow things are all done by the time the conference is there. And that's Madam's, I would say, USB. Even now from the hospital, she's ensuring that it is all done. I'm sure she will not be satisfied until she looks at the YouTube and says, okay, this was an okay conference. So ma'am, we will get the YouTube link to you very soon. but you have been so inspirational. And I think that if we can do half the work that you do, if all of us who claim that we are supporters of KMC do half the work you do, then I think Kangaroo Mothers Care Scale Up will not be a problem. Thank you very much. And I hand over for the last and final word of this conference to Dr. Shashi Vani ma'am. I am not very sure that you will be able to speak much because I know you are, ma'am, are you there?
I don't think she's there. She's logged out. She was logged in with her son's ID.
Yeah.
Vani, and I don't see it any longer.
Okay. Are you muted? So I think she will see the recording, but thank you all one and all. And even in a physical conference, we usually don't have so many people right from morning till evening. But for both the days, we have had a wonderful participation, not only on this platform, but also on the digital platform and the YouTube platform. So thank you, everyone. Thank you, my teachers, Dr. Rekha Udani and Dr. Ruchi Nanavati, who got me on the pathway of Kangaroo Mother Care. And thank you all dignitaries, all speakers and all faculty and the KMC family. It's always so wonderful to work with like-minded people, and KMC family is one of them. And of course, my own people here in St. John's Medical College, a big thank you, and stay safe. These are difficult times. Many of you all who have delivered lectures have had close family members battling with COVID. But despite that, you have come on board and given your lectures. I wish all your families and you health and safety during these difficult times. And let's continue to do what we do best, that is take care of our babies and the vulnerable small and sick newborns. So all the best and stay safe. Goodbye from the 5th National Conference of Kangaroo Mother Care.
Dr. Kharad was saying something. I don't know.
भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना उच्छल जलधि तरंग तव शुभ नाम जागे तब शुभ आशीष मांगे गाहे तव जय गाथा भारत भाग्य विधाता जय है जय है जय है जय 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 हे
Okay.